Austin, Texas, how we feeling? All right, welcome everybody to the second annual Emergency Medicine Pharmacotherapy with Resuscitation Conference, Empowerx. We are thrilled to get everybody in the same room. This is awesome. I'd say probably the world's largest gathering of emergency medicine pharmacists. Also want to give out a shout out to the physicians, the nurses, anyone else, PAs, anyone else who may be in attendance here today. We couldn't have done this without your support, so thank you so much. Woo. My name is Kyle DeWitt. I'm an emergency medicine pharmacist at University of Vermont, up in Burlington, Vermont. I'm going to be moderating a lot of the sessions today. And at this time, I want to introduce the brains behind the operation, Jimmy Porter.
Good morning, everyone. This has been a dream come true to see all of you guys here, to have emergency medicine pharmacists, physicians, nurses, everyone in one space. This is truly a dream, and it's the definition of what Pharma So Hard means. I'm just so excited to start this journey and to be with all of you guys here, and I'm very excited to really just share all the information that we will be today. So many people today I'm looking at for the first time in person that I've only hashtagged you, I've only added you, or we've had so many experiences together virtually. This is an amazing time for us to be together and just really support each other and to network and to grow together as emergency medicine pharmacists or those who appreciate emergency medicine pharmacy. But I really want to take this moment to shout out my team. People can say whatever they want to say about me or how good or how bad, but I would not, and this would not be here without my committee. So my committee, can you please stand up for me, please? So everyone can recognize you guys. This is the muscle behind all the hustle. These are the people who get everything done, and I kid you not, none of this would be here without thousands of emails sent, hours spent doing all of this, and I'm super excited to be part of this, and it's gonna be something for me, it's life-changing because I dreamed about this before. I sent a text message about this and saying, hey, this would be cool if we can do this. So excited about that. Also, personally, I wanna thank my wife for all of the hours and time that took away to build this, and all of the messaging and stuff she had to hear me act, hey babe, should we do this? Should we do that? So thank Dr. Mrs. Pruitt over there. So I'm hoping that this presentation and this conference can inspire, but ultimately, I want this to empower you all in Empowerx. So let's get set to go.
All right, with that, we'll introduce our keynote speaker today, Dr. Chris Edwards, Assistant Professor, University of Arizona, College of Pharmacy, and a Clinical Assistant Professor with the University of Arizona College of Medicine, Department of Emergency Medicine. You know, if I read Chris's full bio here, we'd be here all day. He is truly one of the individuals who's been innovating this field, pushing us forward. And again, kind of the reason that we're all here in the same room today. So he's going to be giving our keynote address on innovative strategies to move emergency medicine forward. Please welcome Chris Edwards.
Thank you, Kyle, and thank you everyone for the warm welcome. I am really excited to be here, and honestly, I'm a little bit nervous. I've been nervous about this talk since I was asked to do it, but you know, I spent some time really reflecting on why I was nervous about this, and this is the first time in my career that I've ever presented to a group of my peers, right? Usually I'm presenting to emergency medicine physicians, and when I'm presenting to the physicians, I can just say, USP 797, and they leave me alone, right? You guys know what I'm talking about with that. Or I'm presenting to pharmacists, and I say something like emergent thoracotomy, and they're like, they get scared, and again, but to have this many emergency medicine pharmacists gathered in one place for the same purpose, education, networking, sharing information, it's really something special and exciting. And again, just want to applaud Jimmy and your team for putting this together, the whole planning committee. You guys did an amazing job with this. Thank you for inviting me to be a part of it. It's awesome. All right, with that, hold on 1 second. I don't want to close anything, but there's a window here I'm not sure what to do with. But it should be good to go. All right. Really quickly, I wanted to just make a couple of disclaimers and disclosures. I don't really have any financial interest in stuff I'm going to talk about today, other than if there's more jobs out there for emergency medicine pharmacists, it's good for me if I ever lose my job. So I guess I have that financial conflict, but nothing else really. The other thing I want to say is there will be a little bit of a history lesson in this. And our history isn't that well documented. There are a couple of good papers out there, but for the most part, a lot of this is things that I ascertained from conversations with individuals, and it's based solely on my understanding of how we got to where we are today. So if I left someone out or if I missed something, it's simply an oversight, not an intentional slight against anyone. The other thing is there will be some Poll Everywhere questions, so if you'd like to participate, go ahead and log in at pollev.com/EMP. Right. I also have the objectives for today's talk. I don't want to read these. You can read them on the website. You can read them on the screen. I'm just going to stall long enough that I can say I showed them, and we should be good. So to begin, let's talk about what things looked like before emergency medicine was recognized as a specialty, right? Patients would present to the emergency department, and basically they would be seen by whoever was willing to do the work, whether it was an intern or resident, a non-specialist, or a specialist in another area who was willing to work in the emergency department. Now, notice I didn't say emergency medicine pharmacy. I'm going to talk a little bit about emergency medicine physicians and their path to where they are today, because I think it can be instructive for us. There's a lot of overlap here, and there's a lot of similarities in our journey and their journey. Emergency medicine is a fairly young field. It's difficult to say, this is the exact origin of where things started, because obviously there was some discussion about the need for a specialty in 1968 when ASAP was founded. But a lot of people feel like this is sort of the origin or the origin point for emergency medicine, so I thought it was a good place to start the timeline. ASAP was basically founded when two groups, one from Michigan and one from Virginia, got together and said, we need to build emergency medicine as a specialty. They saw the need for specialists in emergency medicine and founded the group, started lobbying the AMA for recognition as a specialty, and within 5 years, they were granted provisional status from the American Medical Association. A few years later, the American Board of Medical Specialties voted on whether or not to establish emergency medicine as a specialty. And it was a resounding defeat. They got told, absolutely not. Fortunately, cooler heads prevailed. The group that was lobbying for this sort of addressed the board's concerns, came back with a new proposal, and were approved as a conjoined board in 1979. And basically what that meant is they had to have some non-emergency medicine folks on the American Board of Emergency Medicine as they still established their credibility. But after this, it was off to the races, right? They were able to put together their first ABEM exam. They were able to credential their first batch of board-certified emergency medicine physicians. But it wasn't until 1989 that emergency medicine was officially recognized by the American Board of Medical Specialties as a primary board. So I was alive for a good part of time where emergency medicine wasn't recognized as a specialty. And I'm not that old, right? Like, this is a pretty young specialty. So for our first poll everywhere, where do you think pharmacy fits into this picture? When do you think the first description of an EM pharmacy service was published? I'll give you a couple of hints. It's one of the dates that's listed on the timeline. You should be able to select it on the poll everywhere. Just go ahead and click. Maybe it launched, maybe it didn't. All right, so while we're figuring out some of the Zoom stuff. Who thinks it was 1968? Show of hands. 1972? 1975? 1977? All right. 1982? All right. And 1989? Okay. So, the majority did not have it. As we're figuring out the technical issues here, I'm just going to stall. The majority did not have it. It was a little bit earlier than I think a lot of you guys think. Basically, I'll just tell you, the first description of emergency medicine pharmacy services was published in 1977. And it was published by a guy named Robert Ellenboss and his colleagues. And if you look at the types of things that Robert was doing, they were really advanced. Well, I think they were advanced for the time, because when I read the list of things that they were doing in that initial report, they're very similar to what I do today, right? The number one thing that they were talking about doing on that, in that document was physician and nurse consultation, right? Which is how I spend probably 60% of my time working in the emergency department. The other thing they talked about was performing patient education, being deeply involved in the medication use process, serving on committees, and educating everyone from physicians and physician trainees, nurses, emergency medicine technicians, pharmacy students, right? In 1977, Ellenboss was doing basically what I do now as an emergency medicine pharmacist in 2023. Yeah, that's fine. So this is Robert Ellenboss, pretty impressive guy. He's done a lot for not only emergency medicine, but also for pharmacy. I started digging into his history a little bit while I was putting this together, and I was blown away to find out that not only was he the first person to ever write about emergency medicine pharmacy, he was also the founding executive director for ACCP, right? So you could argue that clinical pharmacy has its roots in emergency medicine. Ellenboss was also a major driving force behind the adoption of pharmacotherapy as a specialty. Prior to the adoption of pharmacotherapy, BPS only recognized nuclear pharmacy as the only specialty within pharmacy. Ellenboss and his team were able to lobby for the creation of pharmacotherapy, and it sounds like it was a pretty rough road. Ellenboss also was from what I understand, the generator of the idea to allow for a path for recertification that included continuing education, that basically this idea eventually became PSAPs, right? Now, don't hate him for that. I know PSAPs are kind of annoying, but if you think about it, it's really a revolutionary idea, right? Rather than waiting for 7 or 10 years to pass and then cramming for reaccreditation through taking the exam again, this way you're continuously getting high quality content out to everybody who holds that certification in a way that ensures that they're meeting a certain standard, which is really beneficial. So again, just an awesome guy. Because he is technically the godfather of emergency medicine or pharmacy, I thought it'd be worth spending a little bit of time talking about him. So, do we have like 2 presentations up? Is that what's going on here? Oh yeah, we do. Here. I think this is this show. And maybe this is. Sorry for the technical issues. My screen up here is very different from what's displaying on the thing, and I can't advance slides. There we go. That'll work good. So emergency medicine has its origins in the 70s. And in the 80s and 90s, there were a number of people doing interesting things around the country, right? So large academic medical centers were establishing residency training programs. They weren't accredited because accreditation standards didn't exist, right? but they were training folks and getting them into key positions sort of around the country so that we could eventually reach a critical mass of people who knew enough to work in the emergency department, that they were comfortable doing it, that they could train the next generation, and they could get ready for their moment to strike, right? And that moment came in 1999 when the Institute of Medicine published To Err is Human. And a couple of the major themes within To Err is Human were that mistakes happen, and that in order to prevent medication errors, we need to take a systems-level approach. Another major theme with To Err is Human is that emergency departments are inherently unsafe places to receive care. And so the people who were paying attention at this time realized, well, maybe emergency medicine pharmacists can be that systems-level approach to improving medication safety in the emergency department. Around this time, Terry Fairbanks and Dan Hayes published a description of the services that they were doing at Strong Memorial Hospital in Rochester, New York. And the description of their service is very similar to what Ellenboss was doing in 1977. The difference is, at this point in time, there was a lot of institutional support for finding innovative ways to improve medication safety in the emergency department, and Fairbanks and Hayes were able to use this information to get the AHRQ to fund a project looking at establishing emergency medicine pharmacy services in a broader array of hospitals, right? So the AHRQ project was then used to develop a toolkit for implementation of new emergency medicine pharmacy services. At this time, again, there was a lot of institutional support, and ASHP was actually on board with this as well, and they developed something known as the Patient Care Impact Program. The Patient Care Impact Program took pharmacists that were interested and able to implement new pharmacy services in their emergency department and essentially paired them with a mentor and with 9 other people who were in the process of launching a new service. And they would meet on a monthly basis in order to troubleshoot issues that were going on and try to figure out ways to overcome these barriers to implementation. And over the lifespan of that program, they trained about 100 new emergency medicine pharmacists over the course of the 10 years that program was in existence. It didn't advance the thing here. There we go. The next slide has a graph, so I'm going to wait for us to iron out a couple of these technical issues before we do that. Again, apologies for all the tech stuff. So how's everybody feeling today? Everybody get enough coffee? Hit up that free lunch or free breakfast? Pretty good? All right. All right, who's had barbecue since you've been to Austin? Show of hands. All right, excellent. That was my first trip, first time to Austin, so that was my first stop, was hitting a barbecue place last night. It was quite good. I think it was called Cooper's. It's right down the street. If you're into that kind of thing, I'd recommend it. Who's been down to the Bat Bridge just south of here? We went for a little walk along the river earlier and yesterday, and you could hear all this weird chirping sound as you walk under the bridge, and there's tens of thousands, if not hundreds of thousands of bats that live under there. It's pretty cool. All right, and I think Jimmy's got us squared away here. Excellent. So managed to stall long enough, and we're back on track. Whoa, I can even see my notes now. Whoa, it's about to get so much better. All right, so as you can see, there was an explosion around 2013, right? So this reflects the number of ASHP-accredited PGY2 programs specializing in emergency medicine. And the first program was accredited in the year 2000 at Detroit Receiving Hospital. That might be one of your CE questions. So Detroit Receiving Hospital had the first accredited PGY2 program, and that was about the year 2000. When I was looking for PGY2 programs in 2009, there were 12 programs in the country. And then as you can see, around 2013, the slope of that line changed dramatically, right? And there's been just an explosion in the number of programs. Right now, we've got just shy of 100 PGY2 programs in emergency medicine in the country, which is just incredible. And I think this reflects the explosive growth of emergency medicine pharmacy overall. Speaking of residency, here's a picture of me pre-beard in residency with Dan Hayes and Saad Patnwala. And the reason I wanted to talk a little bit about residency is during my residency, there were a handful of useful resources online, things like Global RPH and the Johns Hopkins Antibiotic Guide, but they weren't updated super frequently, and there was no way to know when they were changing things on there. And then all of a sudden, there was one blog that I was aware of. It was called The Angry Pharmacist. I looked at it once. It was like a community pharmacist that didn't like patients, and that was pretty much enough, right? Like, but then all of a sudden, I started getting really advanced questions from my residents. Seemingly overnight, the questions went from, how do I dose nitro in somebody who's having a heart failure exacerbation, to how long can I run this nitro drip at 400 mics per minute when I have someone with SCAPE? And I was just like, what? Like, where did you come up with that? And they told me that they had heard it on this MCRIT podcast. I was like, all right, I should probably start paying attention to this, if nothing else, just to not be totally blindsided by crazy questions from my EM residents. And so I started paying attention to MCRIT, and that was really my early exposure to free open access medical education, or FOAM Ed. If this is working, which it probably isn't, to be quite honest, I was going to have you guys put in the first FOAM Ed account that you followed and kind of have it running, which would have been really cool, but technical difficulties. So the first couple of accounts that I followed once I started getting involved with Twitter were Brian Hayes, Nadia Awad, Craig Cochillo, and then different organizations started launching accounts, right? So ASHP's Emergency Medicine Section Advisory Group was an early adopter of this technology and used it as a method for disseminating important papers or conference information from an organization. And now I'm sure you guys are all on Twitter. If not, create an account right now. It'd be more important than listening to me talk for another 20 minutes. It's a really great mechanism for keeping engaged with our community of emergency medicine pharmacists, for learning about groundbreaking innovations and research that's being published, and just seeing cute pictures of animals if you put some of that kind of stuff on your feed, which I did in order to keep me coming back, because just reading about pharmacy stuff gets a little boring at times. All right, and that brings us through to the modern era. I think probably the biggest innovation that's occurred in the past year is that BPS just finished testing the first cohort of 454 potential emergency medicine pharmacists, right? The results of those board certification exams should be available soon. I can't give you too much information, but stay tuned. No, I can tell you it won't be this week. Soon. But this reflects a long road. Again, similar to the creation of emergency medicine as a specialty for physicians, there was a lot of miasma, there was a lot of things happening behind the scenes, but we'll say that this process started about 7 years ago with a role delineation study that was performed by BPS. And basically what that process involved was getting a group of about 15 emergency medicine pharmacy specialists in the room where we could talk about what we thought the key knowledge, skills, and abilities were that an emergency medicine pharmacist needed to have. These were then used to identify the domains in which we would assess whether or not someone had met those requirements to call themselves an emergency medicine pharmacy specialist. About halfway through that process, somebody, might have been me, said, maybe we should look at the accreditation standards that ASHP put together for residency training, because we're basically doing the same thing that they were doing 5 years ago, trying to determine what do we need emergency medicine pharmacists to know. And it was a very helpful reference document when we were doing the role delineation survey for BPS. I suspect that ASHP will probably look at the blueprint that BPS put together when they go back to revise the residency accreditation standards whenever that occurs. But there's no guarantee that they will, but it seems like they might. So I guess that leads me to my next question, which is, show of hands, who's heard of the EM model? I know at least one of you has. Got one of my talks physician colleagues in the back. I know he knows about it. All right, nobody else. All right, who stopped paying attention? If you totally checked out, that's cool. All right, we're gonna bring you back in here. All right, I think this is probably the most important part of this talk today. So the EM model was first published in 2001. And basically, this document serves as the founding and foundational core for emergency medicine, right? Basically, this document gets updated every 3 years via collaboration between ABEM, ACEP, the Council of Emergency Medicine Residency Directors, the Emergency Medicine Residents Association, the Residency Review Committee on Emergency Medicine, and our hosts, SAEM. This document serves as the foundation of the specialty, right? So it serves as the reference point for developing medical school and residency curriculum, certification examination specifics, continuing education objectives, research agendas, residency program review requirements, and other documents necessary for defining the specialty of emergency medicine. So that sounds pretty good. I want some of that, right? Like, I think that there's room here for an EM-Pharm model. As I mentioned previously, we currently have a hodgepodge and patchwork of really passionate, dedicated people who do awesome work, but they're kind of doing it in a siloed fashion with a lot of unnecessary redundancy. So again, the accreditation standards are set by ASHP and their section advisory group. They do an awesome job with that. Again, not to take away from what they're doing. But then BPS comes up with their role delineation study, which basically does the same thing, but there's no bilateral communication, right? BPS can't really go to the people who wrote the accreditation standards and say, why do you think this is an essential skill for an emergency medicine pharmacist to have? Are we missing something, right? And vice versa. BPS, ASHP can't say, why isn't the board testing for this? We think this is an important thing. It's in the residency accreditation standards. There needs to be some dialogue there so that everybody's on the same page about what it actually means to be an emergency medicine pharmacy specialist. This can also help to inform research needs, right? How often do we get a good practice survey about the number of practicing emergency medicine pharmacists or the number of residency programs other than just looking at the ASHP website? So the EM-Pharm model could be used to set a schedule for doing practice surveys so that we know what the current needs are of the EM pharmacist. We could also potentially do forecasting so we can anticipate future needs, so we can incorporate those into our residency training standards and our board certification requirements so that we're future-proofing our graduates, making sure that they're ready for what's to come. So this should really exist on a feedback loop, right? Where we have aspirational residency accreditation standards that ensure that we're graduating residents who meet the minimum standard to be competent emergency medicine pharmacists. The board should then test to ensure that that standard has been met. Then we determine whether or not they're equipped to deal with the current practice needs, do some surveying and forecasting to make sure that we are where we need to be, figure out what the future practice trends are, and then take all of that information back into the residency accreditation and board certification cycle so that we can update that with real information instead of just vibes, right? So that's pretty much it. No, I'm kidding. There's a little bit more, but that's kind of my vision for how we can really innovate in emergency medicine and really push this profession forward in a way that makes sense. Basically, just do what the docs are doing. They got this figured out. They figured it out 20 years ago. But there are some other exciting things that are happening. Another thing that I really think our physician colleagues do well is shifting away from just doing a CE-based maintenance of certification once it's been obtained. BPS is on board with this. Again, I don't think they've announced anything, but I think I can share it. They're going to be allowing for the inclusion of continuing professional development towards maintaining your board certification. Basically, if you're a preceptor, if you write papers, if you do presentations like this, you can count those towards your CE hours, decreasing the total number of continuing education that you need. It helps to encourage people to do things other than just sit there and plow through PSAPs. But we could potentially do more with this as well. One of the things that I think the American Board of Emergency Medicine does really well is in the last couple of years, they've created this concept known as key advances. And basically what this does is, in order for an emergency medicine physician to retain their licensure, they have to review these documents that are released from the board about major upcoming major papers or guideline changes or things that should be implemented in anybody's emergency medicine pharmacy practice, right? This allows for them to get this information in front of practicing physicians almost in real time. It allows them to suggest a standard of care that should be met by someone who's board certified. And it allows for, again, more consistent and rapid dissemination of this information. Maybe this is something that we could do as a specialty with BPS and BCEMP, but in order to do that, we would need to identify what those best practices and key advances are, and that really boils down to research. Now, there's some really exciting things happening with research in emergency medicine. A lot of the folks in this room have been heavily involved with a project known as EMPharmNet, which has allowed them to do some large trials across a number of different hospitals and health systems. ACCP's Emergency Medicine PRN does a similar program, mainly practice-oriented, but they've done some really exciting things like their EMPIST score, their Emergency Medicine Pharmacy Intensity Score. ASHP does the overall pharmacy forecast, but there's very little that kind of gets into emergency medicine specific stuff. And so when I look at some of the opportunities here, I think the biggest missed opportunity is integration of residents into large-scale research, right? Again, we have about 100 residency programs in the country. Every single one of those residents is doing a project. Let me ask you this. How many of you do either student or resident research project advising? How many of you guys are involved with that? Okay, so if you have your hand up, keep it up, keep it up. How many of you currently have a project looking at tenecteplase versus alteplase? Keep your hand up. All right, y'all should talk. You might want to consider pooling your results so that you could get a bigger study out there, right? And if you do end up collaborating, I've got some data too. Hit me up. I'll be like 8th author or something. It'll be great. So yeah, we have a lot of redundancy with the types of projects that are going on. Again, I keep referring to the miasma, but if you look at sort of the things that people are talking about, there's generally a lot of overlap there, right? And if you can get a couple of residents from different parts of the country working together, it increases the overall generalizability of those results and decreases the the amount of redundancy in the literature. The other types of research projects that I really like to see are things that show the pharmacist impact on core measures. A lot of the documents that we use for justification are based on cost avoidance or soft dollar savings, right? And most C-suite people these days don't care about soft dollar savings, right? They want hard dollar savings and revenue generation. And so when we think about how can a pharmacist impact the bottom line, I think one of the biggest ways we can have an effect is by impacting core measures. For example, if you have a hospital that's having a difficult time getting septic patients antibiotics on time, and you have 5 papers showing that emergency medicine pharmacists decrease the time to antibiotics in patients with sepsis, you can take that to the C-suite and say, we can fix your problem right now. You don't have to worry about losing money from CMS reimbursement. Just hire a couple of EM pharmacists. They'll pay for themselves with this initiative. And so I think more of those types of studies showing the impact that pharmacists can have on core measures would be very, very helpful. Another thing that I've been trying to wrap my head around but haven't quite got the idea yet is if we can show that pharmacists have an impact on throughput, that is an issue facing every emergency department around the country. If you can show that pharmacists get people out of the ED faster, you're going to, again, help more programs justify implementation of new services. And then I mentioned this previously, but I think one of the biggest needs is intentionally timed practice surveys and forecasting so that we can have that data when we draft things like board certification standards and residency accreditation standards. So right now it seems like those things kind of happen when somebody feels like doing it. That needs to be on a set cycle and maybe have an organization driving it. Hint, hint. All right. So the next thing I want to talk about is advocacy in emergency medicine pharmacy. There have been some huge, huge wins in this arena recently. Shout out to Ryan for helping to lead an initiative in Wisconsin, I think, to get emergency medicine pharmacists or pharmacists in general the ability to administer medications. Ryan and a small group of dedicated individuals were able to get that passed through the legislative process, and they can now administer medications without fear of losing their license. Very cool, right? So that reflects the efforts of a small group of individuals, but then you have another big win that recently occurred is the elimination of the X waiver, right? This allows emergency departments around the country to treat substance use disorder in an evidence-based fashion. Now, this represents the work of the combined effort of lots of large organizations, right? ASHP was involved, ACCP, APHA, a lot of the physician organizations were all asking for this, and eventually they were able to get it done at the federal level. Which leads me to our opportunities here. We really need someone who's thinking about the legislative priorities that are going to matter for emergency medicine pharmacists. and then monitoring for successful legislation at the state level so that that can be used as model legislation in other states that would like to advance the profession and move it forward. Right now, if you're not on Twitter, or you don't follow Ryan, you might not have heard about the stuff that happened in Wisconsin. Your state organization may or may not have heard about that as well. But if you were to go to your state org and say, look, this is something that I think we should do here, you can give them the model legislation and they can put that on their legislative agenda for the next cycle. Without that, they're not gonna care what you're doing. They're not gonna think like, oh, this could be really nice for emergency medicine pharmacists. Like, you need to get in there and ask for what you want to see happen, otherwise it's not gonna happen. And I think as a group, as emergency medicine pharmacists, we need to do this in a coordinated fashion so that we can advocate for the things that will help to advance the whole profession forward. So that it's not just Ryan saying this would be really cool. It's a group of emergency medicine pharmacists saying this would be really cool. Another thing, and this is mostly so I can get it out of my head and into yours, and maybe you can figure this out. I've been tumbling this around for years, and I can't quite get there. But billing for emergency medicine pharmacy services, right? I mentioned that the C-suite only really cares about revenue generation or hard dollar cost savings. And there has to be a way that we can get paid for what we do. That being said, the emergency department is a complicated place. You have both outpatient and inpatient statuses, and basically every patient is going to be outpatient and inpatient at some point during their emergency department visit. A lot of the advocacy efforts that are going on at the national level on the pharmacy side are focused on outpatient billing. And it makes sense, right? It's easy to understand. If you see somebody for your diabetes, they adjust your insulin, they should get paid for the time that they took to do that. But what would it potentially look like in the emergency department? Is there a way that we could use those outpatient billing mechanisms to charge for services while the patient's still in the outpatient status? And then what would a win look like in a DRG-based reimbursement model, right? So if the hospital is getting paid one sum of money for their visit, how do we make sure some of that gets carved out for the pharmacy department in order to pay for emergency medicine pharmacy services? Now, if you know somebody who's really good at revenue cycle, or if you're good at this stuff yourself, like, try to let that tumble for a little bit and see if you can come up with something. If you do, please write it up, because I've been trying to figure this out for a little while. I think there's something here. See what you can do with it. All right, the last thing I want to talk about is collaboration with non-pharmacy organizations. So obviously, SAEM has been super welcoming. If there's anybody here from SAEM, thank you so much for allowing us to participate in this conference and generally being very welcoming to emergency medicine pharmacists. SCCM has also been very welcoming. They're trying to get a group of EM pharmacists off the ground. ASAP is a little less friendly. They've got general support for emergency medicine pharmacists practicing clinically, but it's a little bit harder to get integrated with that organization, maybe because it has a physician in the name, I don't know. That being said, there was lots of organizational support for BCEMP. When we put together the petition, we were able to get letters of support from ASAP, from the Emergency Nursing Association, from SCCM, from the American Board of Applied Toxicology, from ISMP. So lots of organizational support for what we're doing. But what are the opportunities here? I really think probably the biggest opportunity is essentially being involved with our physician colleagues for every step of the way, right? So physician training, credentialing, and then having them involved with our credentialing and training processes to make sure that we're being trained in a way that we are best able to meet the needs of our physician colleagues and be part of that team. We should have a voice in creating policy related to EM pharmacotherapy. Shout out to Lance for putting this one on my radar. But ASAP recently came out with a policy, or they're in the process of developing a policy on the use of chemical sedation, and there's no pharmacists on it at all, right? A lot of drug things that are involved with that, but there's no clinical pharmacists there. And so I think emergency medicine pharmacists should be integrated into those processes, just like physicians should be integrated into our processes, and it should be easy for that to happen. They should know how to find an emergency medicine pharmacist. If they Google emergency medicine pharmacist, you should get more than just a couple of individuals popping up, maybe an organization. And when we're speaking about a topic to an organization, we should have a unified voice, particularly for major issues that are facing the profession. And so this brings me to my closing thoughts. So there are a lot of exciting things that are happening across a variety of organizations, and a lot of really cool things that are happening, including this. That being said, there's a need for better coordination and alignment of these activities, and I think the EM model provides a shining example for how this can be done. We don't need to reinvent the wheel here. The physicians figured this out years ago. My personal thought on this is there's room for an organization of emergency medicine pharmacists to coordinate all of these activities and make sure that these things are happening as they should. I'm just throwing it out there. We should call it the Society of Emergency Medicine Pharmacy. I think it sounds pretty cool, although the acronym SEMP sounds a little too close to SIMP. I don't know if I love that. But other than that, again, the poll everywhere isn't working, but what I would like you to think about, how do we move this forward? Like, what do you think we should be doing as a group, as a profession, in order to make sure that we're taking this to the next level, that we keep advancing, keep innovating, and get emergency medicine pharmacists everywhere they need to be. So with that, am I supposed to go through the learning assessments? Yeah? Okay, so learning assessment question 1, hopefully you were paying attention during this part. Which was the first PGY2 emergency medicine pharmacy residency program accredited by ASHP? Hey, cool. Detroit Receiving Hospital established the first ASHP accredited PGY2 program. Major milestone for the growth and advancement of emergency medicine pharmacy. What year was the first batch of board certified emergency medicine pharmacists certified? This year. All right, excellent. Another major milestone in the advancement was yeah. It'll end up being probably, I can't say. You guys did fine. It's going to be great. So yeah, another major milestone here. So the last question, I think, is how does the profession of pharmacy ensure all residency programs are training pharmacists to achieve a minimum standard of competency when entering clinical practice? This is a little trickier, but is it A, board certification, B, residency accreditation standards, C, how good they post, or D, like the overall vibe, like are they cool enough? Yeah, vibes-based. All right, I like that. And that does it for my presentation. Thank you all so much for having me. It's been an honor. Hopefully you got something out of it.
Does anyone have any questions for Chris? We have a microphone.
I was going to try to get away. Oh, no.
Uh-oh. I saw that coming.
Chris,
Yes,
thank you.
Of course.
And speaking as a very old, angry man who didn't have the capacity, skill, or discipline to try and do any of this when I was in practice, I can't help but be very thankful for what you all have done. So that's about as nice as I can possibly be.
That's
and
very
I don't
kind.
know how else to say it. Bless you all. There are two things I didn't see that I think are critical. And so it's not a question. I'm doing the thing I hate the most, which is making a comment. Okay? One is, to me, I love that we're developing standards and we're developing skills, but you need attitudes to go with them.
Yep.
And no one's talking about attitudes anymore. Fair?
Fair.
And for every goddamn critical care resident that thinks they can go to an EM job and just be great because they're critical care, and all the EM people that are getting trained now, the students and young residents who think, well, my job will just be like the one that I saw, we're missing something. And someone's got to pick that up, and it would be better if we did it because we're the ones is that fair?
Absolutely, yeah. And it's such an important thing, and it's so hard to assess, right?
It's horrible. It's horrible.
Yeah.
It's like doing DEI. It's like doing a lot of things because it's very soft and it's just pure subjectivity.
Exactly.
But we've got to do something.
Yeah. I think we got to get the Frank Polycheck
No,
Academy
I'm not
of.
no, I come across real poorly in that regard. Now, the second thing, am I in trouble? Are you pulling me?
She's getting closer so that she knows that second thing's going to be spicy.
Okay, the second thing, I'm going to look around the room. I can't see the people on Zoom, but there is something really bad about this room.
What's that?
I'm the only old person here. Where are we? We lose them at, oh, bless you. You're not that old. But we need, the group needs you people, not me, because I didn't do it. If you're going to take this and you're going to push it forward, how do you take care of each other and be examples to the rest of them for the next 20 years? Because you're 20 years behind me. And I'm coming here while I'm retired because I'm a dumbass. But where is, that's also missing. And if you're going to start the society, it's got to include how to try and keep people in longer.
Yeah.
Is that also fair?
100%. Yeah,
All right.
that is such an important point. And I think that raises a really interesting point, right? I think one of the biggest concerns, and something that I try to warn students and residents about, is the career longevity associated with emergency medicine, because you don't see a lot of old timers, right? You see a lot of people who used to be emergency medicine pharmacists and then, left the profession because they wanted better hours, or, the mental burden of all the crazy stuff that we see got to them. And so, yeah, it's crazy to think that I'm one of the old timers here. It's like, I'm not that old, man. Like, when they first got approached to do the keynote address, I'm like, damn, I guess there really aren't that many people who have been doing it for a long time. Like, it's kind of crazy how quickly people get chased out. Oh, the other thing I want to mention is I don't think it was anything in you that didn't lead to like sort of the creation of all this kind of stuff. I think this was the time, right? I think that all these pieces kind of fell into place, a lot of it based on your work and the residents that you helped train. So, not to be deferential, but, you definitely helped to shape this, so.
I'm going to rope us back in here. Frank, I'm one of those crit care trained EM pharmacists that you despise. And I think we're doing okay. I think we can translate those skills, but I appreciate your disdain nonetheless.
Okay. They can't hear it off of that mic.
So Chris, you touched on, thanks for the great presentation, first of all. We're super excited for this to be happening. And I think you highlighted a number of the challenges that we face as EM pharmacists. I think, one of the frustrating things is that we're probably the most collaborative at the bedside, right?
For sure.
Like, we're in the trenches together with the team. It's so multidisciplinary at the bedside, and then that doesn't translate nationally when you're talking about guidelines, when you're talking about, news media coverage. Like, where are docs going to prep for their, media appearance about medications? They're coming to us. So I wonder what your thoughts are on like the best way to bridge that gap. Why is our representation so poor on guidelines? And how do we move the needle?
I think it's definitely challenging. I think that there are a couple of issues that make it difficult. One is there just aren't that many of us, right? Particularly if you're a physician and if you don't work with an emergency medicine pharmacist who has an academic inclination, is willing to take on all these extra projects, usually for free, right? There's going to be very little opportunity for individual physicians to incorporate a pharmacist into their activities, even if they wanted to. So I think part of it is accessibility, right? Like having a place where we know we can find an emergency medicine pharmacist to talk to, like an organization, would be pretty helpful. The other piece of it, I think, is that, again, that compensation piece. I don't know that people are necessarily willing to put in work, particularly on guideline development, authorship, as a professional obligation anymore. And I think that is an important part of sort of, building your brand and contributing to the profession. And it's something that I would encourage you to consider, particularly as you're getting started. And it also sucks, right? Like, working for free is not something that a lot of us are really excited about. And so I think that it's sort of finding that balance between, taking on projects that you think are cool, that you're passionate about, and also, just taking advantage of those opportunities. I think we got a question from the back here.
Chris, thanks for a great talk.
Thank you.
I agreed with everything you said except one thing.
Please.
It's going after the billing because the C-suite wants it.
Yeah.
Most American people see healthcare as their right nowadays. And to go back and accept the C-suite's nonsense, that quality care that comes with quality medicine, quality pharmacy, quality nursing doesn't have a value unless we can charge for you, it's nonsense, and we should be pushing back on that. This is part of the quality care we provide, and it's time to push back and say, why do we need the C-suite?
Hell yeah. I love that. I don't really have an answer to that. I love it. Hell yes. Excellent.
Chris, thank you for that talk, and also too, and this is another one of those goddamn critical care pharmacists in EM. So shout out, Frank. You spoke briefly a little bit about legislative processes and how EM pharmacy has a vital role and how things can change when we get involved. As someone that has been involved in that, it's kind of difficult when you're just kind of going through the weeds of it without an organization. What recommendations would you make to the group in general and how to get involved with some of these legislative processes?
It's a great question. Thank you. So your state organization is going to be the first place I would start. So much of pharmacy practice is dictated by state level legislation, and the state orgs often have underrepresentation, particularly of health systems pharmacists, particularly of emergency medicine pharmacists. So if you're there and you know the issues that are relevant to your practice and can speak to them, you're more likely to be able to get your state organization involved in advocating for that legislation. And then it's a two-way street, right? They can hook you up with the legislators that are likely to be supportive so you can speak to the issues that matter to you and hopefully get some of that work done. So thank you. Very good question. All right. I think we're just about out of time. So thank you again for all the great discussion. I really appreciate the opportunity.
All right, everyone's waiting for the CE codes. So get your phones out, write these down. The first CE code for the keynote is the number 3, as in the number of technical difficulties we've already had. M is in methadone. S is in SAEM. 3MS. All right, and while we're switching slide decks, I'll start to introduce we got a big group coming up here.
Yeah. This one has the water. Good one. I'll take it.
So this next session is going to be moderated by Dr. Frank Luchek.
I don't care.
He doesn't care. We have Dr. Megan Musselman, clinical specialist in emergency medicine and PGY2 RPD at North Kansas City Hospital. We have Dr. Ryan Feldman, emergency medicine pharmacist, assistant professor at the Medical College of Wisconsin, and esteemed toxicologist expert. And then Dr. Gabrielle Procopio, did I say that right? PGY2 Program Director, Emergency Medicine Pharmacist at Hackensack Medical Center in New Jersey. So I'm going to turn the mic over to Frank and let him take it away.
All right, show of hands. How many other people did I offend by calling them a goddamn critical care pharmacist? I've got 2, 3, 4, 5. Thank you. I apologize. I'll go and find you later, do it personally. I think it proves my point that if we could determine attitudes that go along with skills, it wouldn't matter where people train, we'd be finding the right people. So, I mean, but this is why am I a moderator? I don't know how to be moderate. So, folks, forgive me. I think we have a very nice session. If it matters to you all, it probably doesn't. Dr. Musselman's going to go first, and then Dr. Procopio, and then we're going to finish with Dr. Feldman. And I please, I'm going to stop because, are you ready? Anytime. I'm going to ask your forbearance for 2 things. 1, I talk too much. 2, have questions. This worked last year virtually because everybody was unafraid to ask questions because you couldn't see them, and they were all on Zoom, and everything blew up in chat. And I don't want the people that are sitting here to be afraid to ask questions because now they're live, and nobody ever asks questions when it's live. That's crap. Is that fair? All right. Dr. Musselman, please get this started with some kind of, get us on rhythm or something.
All right. So we're going to be presenting tox cases. We have 10 minutes, but we also have Frank, so we really have about 2 minutes, so we're going to try to do our best, okay? All right. So mine is a crazy case, an EKG gone wrong. I have nothing to disclose. Here's my objective. So we're going to start with a 51-year-old female who presents to an ED about 40 miles from your nearest tertiary care center. 5 hours prior to presentation, she ingested approximately 6 tablets of one of her medications, but EMS did not grab her medication bottles prior to transport. The current offending agent is unknown, but her home medication includes oxycodone, carvedilol, lisinopril, amitriptyline, and gabapentin. She arrives to your ED confused, combative, vital signs of a blood pressure around 90s over 60s, heart rate of 130s, respiratory rate of 23, temperature of 37.4. You have your labs there for you, just so you can take a quick look at that, what you're thinking. Do you feel like you're back to taking the BCEMP exam? And you get an EKG. This is what you see. Sorry, I removed what the writing is on top, which is my normal EKG interpretation. All right, everybody get a good look at that? Okay. What toxicity is this patient exhibiting? Cool, I'm done. Just kidding. Oh, fair. Yeah, TCA, good job. So basically, TCA toxicity, most likely this patient her symptoms are secondary to amitriptyline. Things you can see with TCAs is that it has multiple effects on multiple receptors. You have alpha receptor antagonism, which is where you can see the marked hypotension secondary to the peripheral vasodilation. But one of the more hallmark things we do see with these patients is the fact that it is a sodium channel blocker. And so what happens when that occurs is it prevents that rapid ventricular depolarization, and you have prolongation of your QRS interval, as well as you can see this tall R wave in the AVR, and that has to do secondary to the axis deviation in that lead. If you want to go in further detail, there's multiple things on YouTube by this man that can discuss that. We don't have time today. It also can induce seizures secondary to this blockade. You also can have its effects on the muscarinic receptors, which will cause signs that are representative of anticholinergic toxicity, such as delirium, agitation, and tachycardia. It also has GABA receptor blockade, which also can potentiate seizures, and then it has inhibition of catecholamine reuptake. So we have a lot of things going on. So what does the EKG tell us? So can anybody tell me historically what we have used as a hallmark sign of severe toxicity for TCAs? The QRS widening. So that's things that I remember way back in the day. I say about 10 years ago. It's longer than 10 years. We're not going to do the math. When I was learning all this stuff, and that's what I remember. It was QT prolongation. Don't ever say that word. It's QRS widening, all of those types of things. And the magical number was 100 milliseconds. Okay. So looking at that literature, basically what we have different studies out there that looked at this from the 1980s into the 1990s. So the first one is Boner and colleagues. They did a prospective study, and they found that patients who had a QRS greater than 100 milliseconds, that patients were more likely to develop seizures and arrhythmias, specifically in that subgroup where the QRS was greater than 160. These patients were more likely to develop those arrhythmias that you are concerned about with TCAs. Shannon and colleagues also studied patients with a mean maximal QRS duration of 145 milliseconds after ingestion of TCAs. And they also found that 45% of patients developed seizures and 27% developed arrhythmias. A retrospective analysis was conducted by Folk and colleagues, and they found no significant difference in the rate of occurrence of ventricular arrhythmias or seizures when compared between the less than 100 milliseconds and the greater than 100 millisecond group. So really, if you look at these studies, if you look at the 3 studies in the whole, they did have different methods with they measured the QRS duration. So Burhart and colleagues used limb leads, whereas the other 2 used 12 leads. So this could be an exaggerated specificity, which is why it's come into question whether this is truly a good indicator for us to determine severity of toxicity. There was also a study that came out by Buckley and colleagues that they had 3 toxicologists determine how to agree if the patient had prolonged QRS duration. And they disagreed in 20% of cases. So that goes to show that even people who are trained to evaluate this don't always agree if the patient is truly exhibiting QRS prolongation. So this leads us to right axis deviation. We also have some studies out there as well that has evaluated what we classically call the R wave and the AVR. So Cavardi and colleagues had patients with TCA poisonings, and they noted that significantly more patients with ryward shift in the major toxicity group. Lee Belt and colleagues also studied patients with TCA poisoning within 24 hours of ingestion. And they noticed that there was a risk factor for seizure arrhythmias when the R wave and the AVR was greater than 3 millimeters. And this was shown to have a 43% positive predictive value, whereas the QRS interval had a 35% positive predictive value. When they did a regression analysis for both seizure and arrhythmia, the R wave and the AVR was the only significant factor. And then Buckley and colleagues did a case control study, and then they looked at the RS ratio in an AVR, and if it was greater than 0.7, it was a better predictor of arrhythmia. So it just goes to show that looking at that AVR lead is more of a prognostic factor for us to determine whether a patient has more severe toxicity or the concerns that we would have with these patients. Patients also presenting with an R wave and the AVR greater than 3 millimeters are at a higher risk for serious arrhythmias or seizures. So knowing all that, and that patient does have an R wave, how would you manage this patient? On it. See, I could just sit down. Yes, so you would start with supportive care, can't help it, we have to do the whole ABCs. You would do your IV access, all of those types of things. Patient has hypotension, you would still start with IV crystalloid fluids, but our main player here is gonna be bicarb. And you want to aim for a pH of 7.55. If the patient's intubated, you can use mechanical ventilation to also control pH. If you feel comfortable of time of ingestion, you can consider activated charcoal. It is effective. And then lipid emulsion and ECMO has been reported as possible options as well. For hypotension management, if they don't respond to IV crystalloid therapy, there is agents that are listed out there. Obviously, you know with our literature, we have limited literature, but it is suggested that our main player of use is going to be norepinephrine. It has been reported in multiple studies, and it's effective secondary to the fact that the patient, remember it has, TCAs have the inhibition of catecholamines, so it is proposed that you would not want to use an agent like dopamine because that patient's already depleted and would need the release of norepinephrine, so it's not postulated to be as effective, so that's why norepinephrine has kind of become our main player here. One thing to also consider is if you know your patient has a decreased ejection fraction, is that you might need that inotropic support too. So this may be a time where you make epinephrine be your first line vasopressor. That way you can also get cardiac and peripheral support for the patient. And then lastly, you can also consider dobutamine if you need further inotropic support. So should we give physostigmine? Somebody's making it in their basement? Okay. So here's the questions. When does it clinically make sense? So we really think of this if the patient's severely agitated, aggressive patient without cardiac conduction disturbances, risk of seizures, unknown co-ingestion. So for our patient, no, we would not consider it. There is mixed data. There was a negative one. Negative data is a case report of asystole with physostigmine used in 2 peri-arrest TCA overdose patients, but we also have positive data out there as well, that it shows it can decrease intubation and ICU admission when compared to other agents. And then when we had a larger study and evaluating our TCA overdose patients, asystole only occurred in 1, and that was when you had a co-ingestion of propranolol, which seems that it may be safer than we originally thought. But can you find it? It's no longer being manufactured. They went out of business. So that is one reason why we really don't have to consider it right now, but that's just food for thought. But there has been, when we went through this back order, I'm sure you guys all thought about it, we were like, what do we do? What if it happens? And the big thing was like benzo, benzo, benzo. So benzos can still help us to a point. So don't be afraid to use your benzodiazepines, but there is case reports that are coming out. There is poison centers that have used rivastigmine. Ryan and I were talking about it last night. They have been able to use it as well. You just have to be able to have the oral route of administration. So we do have alternatives if we need it. Okay, assessment question. Patient presents to the ED secondary to an amitriptyline overdose. Supportive care and direct management strategies are initiated. Patient continues to have marked hypotension and bedside echo reports an EF of 25%. which vasopressor would you initiate? A. Okay, good. All right, there's your reasoning. All right, so prompt recognition and treatment can significantly reduce mortality. One thing we've found out is EKG findings can really help guide therapy for these patients or determining severity of toxicity. R in the ABR is a hallmark sign that a patient has at increased risk for ventricular arrhythmias and seizures. Do not administer physostigmine if the patient has increased risk factors for cardiac conduction disturbances or seizures. Our first-line treatment option is still bicarb. And then in patients with significant hypotension, if you have a bedside echo just handy, you can help you determine if you need to start with epi over norepinephrine. For further information on EK interpretation, please go to the following YouTube video. And then I don't know if we want to open it for questions for this one, or do we want to keep going in questions at the end? Sorry. Okay, we'll keep going.
Oh, okay.
No, you're next, right? No, you're next.
Oh, cool. Thank you. All right, so now it's time for our second case. I have nothing to disclose, objective. And we'll start off with AZ. This is a patient I had in September last year. This is a 55-year-old male presenting to the ED today after he was found down at the local 7-Eleven. He states that he does heroin. Police were called. They administered naloxone 2 milligrams intranasally, and per EMS, when they received the patient, he was more alert than what the police described prior to the naloxone administration. He's currently somnolent in your ED, slightly arousable to painful stimuli, and then these are his vitals. So his blood pressure is 78/54, heart rate's 52, temp is 98.6, respiratory rate 7, and O2 stats 93%. All right, we're making this interactive. So what would you do? Shout it out. You guys are doing this every day, right? This can't be the first time you've seen a patient with a heroin overdose. Fluids and Narcan, yes. Okay, so how do you want to approach the Narcan for this patient? So we're gonna give fluids, right? We're hypotensive, MAP's like 62. What do you wanna do with the naloxone? You have IV access, it's a dream. We're done with the intranasal right now. 2 IV. Okay, so 2 IV we could do. We could also do 0.04, right? And then incrementally administer it for your patient until respiratory rate recovers. Okay, so we do it. Oops. So now it's been 4 hours, and after fluids and several repeat doses of naloxone, he's still somnolent. His blood pressure's a little better. It's 96/62. Heart rate's still 55, so still a little bradycardic. Temp's 98.6, respiratory rate's 9, and his O2 stat's a little bit better. It's 96%. The team says to you, what should we do? All right, so his respiratory rate's still 9. So just looking at this, right, he's still bradycardic, he's still somnolent, and it's 4 hours later. So what are some of your thoughts? What do you think's going on with this patient? And it might vary depending on where you're at in the country. Shout it out louder.
Probably fentanyl and lasting a lot longer.
Okay, so it could be fentanyl. What else could it be? I think I heard it. Maybe it's xylazine, right? So we still have patient that is somnolent, still has a little bit of respiratory depression despite multiple doses of naloxone, and bradycardic and has been hypotensive. Cool. All right, so we're going to talk a little bit about xylazine. So this might be different depending on where you're at in the country. You might have had experience with it and you might not have. So we're going to do a little bit of a poll. But xylazine, so it's a sedative, anesthetic, muscle relaxant, and analgesic that's used in veterinary settings. I thought my slides were a little bit boring, so I have scared animals in some of the corners of the pictures. There's a lot of rabbit and horse studies with xylazine, so when you PubMed it, just be aware that that's what you're going to get. It's frequently found in fentanyl and heroin in areas specifically the Northeast, but now it's making its way across the country. Patients commonly refer to it as trank dope, zombie drug, sleep cut, and Philly dope. And we'll go into a little bit about why Philadelphia has a special kind of exposure. It's thought to prolong euphoric effects, and patient experiences are mixed. So what is xylazine? Xylazine is actually a synthetic alpha-2 adrenergic agonist. It's structurally very similar to clonidine and dexmedetomidine. Its pharmacokinetic properties I have listed here, but remember this is more used in animal settings, so these are animal pharmacokinetics. So onset is really quick. The half-life from animal data is about 23 to 50 minutes. The clinical duration of effects is about 8 hours or more, but the elimination is rapid. And xylazine has been around for quite some time. It first came to market in 1962, where it was developed. It actually was seen in human trials to have a lot of CNS depressant effects, so that's why it was never approved for human use. And usually it's just used in animal settings, like our scared horse in the corner over here. In the early 2000s, we started seeing long-standing presence in opioids in Puerto Rico, and then it started making its way up to Philadelphia. So if you look at the data, a lot of it comes out of Philly. And in 2021, xylazine was found in over 90% of drug samples in Philadelphia. So here we can see xylazine positivity in overdose deaths, and this is across the country. This was published last year. And you can see the red and the orange. That's where you see over 10% of deaths that were associated with xylazine that had positive xylazine present, and that's more so in the Northeast. And here you can also see the climbing charts of presence of xylazine and overdose deaths by jurisdiction and year. So you can see that on the bottom, the x-axis of all these charts, it's 2015, 16, 17, 18, 19, and 21. That's where you're starting to see it increase over the last few years. So we're seeing it a ton more. This is being alerted by the FDA, by Congress, and even there's articles in the New York Times. I actually had an instance in the fall where my clinical manager called me and said, hey, just so you know, the FBI is requesting to speak to you. And I was, well, that scared me. I didn't know where that was going. It ended up being about to talk about xylazine and my clinical experiences with it. Luckily, I'm not locked up, so we're good. As far as the clinical presentation, so it's really similar to dexmedetomidine, to clonidine presentation, right? We're going to see sedation, bradypnea, bradycardia, and hypotension. But there's also this presence of skin soft tissue wounds. I have a picture listed here to the bottom right. What's interesting is it can range anything from cellulitis, abscess, to skin necrosis and osteo. And it actually does occur frequently independently of injection site. There's some thought that maybe it's related to levamisole. There's no clear mechanism to why these patients are experiencing these skin soft tissue infections, but obviously they're super gross and we have to manage them. So symptomatic care. So has anybody had a patient that has talked to them about use of xylazine? I'm seeing a few head nods. So in case you haven't, there is this really cool article about patients that describe their experiences from Reddit. On the chart on the left-hand side, you can see the adverse effects from xylazine use. They describe increased overdoses and passing out in 81% of patients, wound infections in 43%, and so on. And then in the table on the right-hand side, the major themes related to Reddit posts about xylazine. 53% of experiencers have described use with other drugs, and then 24% talk about their sentiment of xylazine, so positive or negative effects, specifically one saying, I effing love xylazine, I love it. I was so upset if my Fenty wasn't cut with it. And here is our, the only trial that really describes patients' clinical outcomes and experiences with it. So as we know, more patients are seen in the Northeast. And then they looked at patients that tested positive for xylazine versus xylazine being absent. And they actually surprisingly found that patients that had xylazine that tested positive had decreased rates of cardiac arrest and decreased rates of CNS depression, coma within 4 hours. And the authors hypothesized this could be for a few reasons. Number one, we're going to talk about testing, but testing is actually really, really difficult to obtain. And it might be metabolized off quicker than we can actually test for. But also, we don't know the dose and the amount that's present as well. So testing's not readily available. We obviously have to send it to specialized labs, and clinically it's going to not change our practice at all. It's also eliminated rapidly, so it may be difficult to obtain samples. Our overall management is just awareness. This is not naloxone resistance, right? We're not gonna keep giving naloxone over and over and over again and not seeing effect. We need to just know that this is present and could be in your patient. And then also supportive care, right, for altered mental status, hypotension, bradycardia. It's really difficult to decide what the disposition for your patient's going to be because we have unreliable kinetics in humans and lack of real-time testing. What's more interesting, I think, is what we're going to be seeing more in the future is how to manage withdrawal. So the approach really would be more like clonidine withdrawal, which we're all a little bit more familiar with, managing the hypertension, agitation, anxiety, irritability, and restlessness. All right. So back to our learning assessment question. AZ is a 55-year-old male. We talked a little bit about this patient already. What was best for the treatment at this time? Was it A, IV fluids only, IV fluids and naloxone, IV fluids and naloxone at 0.04 milligrams IV titrated to respiratory response, or naloxone 0.4 milligrams IV titrated to response? C. You guys got it. All right.
Please silence all electronic.
Yes, please silence your phones. Who did that?
I just thought you were giving transition music.
Thank you, I was.
Hey, everybody. Thank you to my co-presenters. I'm excited to get to go after you. I also just want to say this is really cool. I love seeing all these people in this room unified through one cause of loving being EM pharmacists. And Chris's talk about what we can do if we all unify is, I think, a very important and big thing to discuss. But anyways, we're here to talk about toxicology. A little bit of a live demonstration here. We're talking tox, and I'm demonstrating caffeine toxicity by sweating down to my forearm, I'm pretty sure. But I do share my bedroom right now with an 8-week-old monster that screams every few hours, so I love him very much, but he does keep us awake. So I'm heavily caffeinated, and I'm ready to talk about toxicology, but we do have one problem. Oh, I have nothing to disclose, and I do want you to identify some things. But the problem is that I was asked to present a crazy toxicology case, and are there even any crazy tox cases? What am I supposed to talk about? Spiders? I mean, that's kind of old news, right? Or holistic medicines, people taking, weird things they buy over the counter. I don't know. There's always the old snake antivenom debate. We talk a lot about Crofab and Antivit, but Rarely do we talk about chickens one after the other with their anuses well stretched, applied to the site of the bite, until enough chickens die that you know you've sucked all the antivenom out. It is cheaper than crowfab, I'll tell you that. Anyways, it's also mundane. I don't really know what to talk about. And even if I could find a crazy case, what can I teach you in 10 minutes? According to Google, that's just enough time to go for a walk or take a power nap. So I'm hoping you don't do that here. I am hoping that maybe I could teach you to avoid a dangerous pitfall with an increasingly common toxin that you are likely to see. And we're going to go over some data, but data in a vacuum, I want to give you some context with it. So we're going to use a case. And you may have seen the patient in this case before if you were at my ACHP talk, but I'm a little bit of a one-trick pony. So let's meet Camden. Camden is a 16-year-old, very human male who lives at home with his family. His family went out of town. He assumed he would never see them again, and this crushed him. Feeling abandoned, he unfortunately enacted a self-harm attempt, and he took his brother's antidepressant and anxiolytic. He texted a friend letting him know what he had done, and his friend appropriately called 911. EMS brought the patient to the emergency department, and on arrival, he was anxious and uncooperative. He didn't think his friend was going to call 911 on him. But fortunately, his vitals were reassuring. You could see his heart rate, totally normal, blood pressure, temperature, everything looks great. His physical exam is there on the left, but it was totally normal as well. In terms of lab findings, he had a urine drug screen done. Don't ask me why. It was positive only for THC. His tox stuff was negative. A CBC, CMP, ECG, anion gap, antilactate, all stone cold normal. Okay. They asked the patient what he took, but he doesn't know the names of his brother's medications. EMS, once again, did not bring the pill bottles in. Unfortunately, they missed him. And mom, dad, and brother are out of the country. So what did he take? Who knows? You got no history, and you have no toxidrome. Out of an abundance of caution, you observe him for 8 hours. You even call the poison center. A shadowy figure on the other side says, this is tricky. Let's watch him for 12 hours just in case. Maybe this is a long-acting med. Okay, we do a 12-hour OBS. He's asymptomatic, vitals unchanged. Heart rate 72, he looks perfect. You send him to psych to clear up his disposition and figure out where he's going to stay while his parents are out of town. 7 hours later, we're now talking 19 hours after ingestion at the psych facility, he becomes acutely agitated, anxious, tremulous, complaining of bugs crawling on his skin until a full tonic-clonic seizure. He's transported back to the emergency department seizing. He has repeated seizures, a wide QRS, cardiac arrest. You get ROSC. He ends up on ECMO due to cardiac failure. Day 2, full court press, ICU cares, CEG, CT of the head. On day 3, you notice some ghost tablets in the stool. Anybody know what we're talking about yet? Bupropion, all right. Yes, we're talking about the norepinephrine dopamine reuptake inhibitor. That is a prescription cathinone. You probably know of cathinones from their use in the illegal drug bath salts, which you probably know of from the times when people try to eat other people's faces. So, bupropion, the prescription bath salt, is now the #1 cause of death, seizure, or arrhythmia from antidepressant overdose in the United States. It's responsible for more of those events in hospitals than the entire class of TCAs or SSRIs. Quite frankly, TCAs were Frank's problem. We are dealing with bupropion. And the incidence is increasing annually. So if you are treating repeated seizures, arrhythmias, or cardiac arrest from an antidepressant overdose, statistically, you are probably dealing with bupropion. That's why we're talking about it today. And it's a pretty tricky toxin to manage. You can have wide QRSs from not sodium channel blockade, but gap junction blockade. So sometimes this can be refractory to sodium bicarb. You can have cardiogenic shock despite it being a stimulant, and the increasing number of brain death mimicry case reports that are piling up. All things that make it difficult to manage. But we're not talking about those. We're actually going to talk about the fact that the multiple dosage forms mean it can have delayed seizures. So when do these seizures occur? For the immediate release, which we don't see much of anymore, pretty standard, about 4 hours, you're going to see a seizure, but they can be as late as 8. We're more concerned about the extended release products and the sustained release. So let's start with sustained release. In one case series of about 385 bupropion overdoses, mainly sustained release, they found that seizures occurred usually within 8 hours, but if we look at this histogram, we're seeing some at 9, 10, or 14 hours, beyond a 12-hour OBS time, which is pretty extreme for most overdoses. What about the extended release products? Well, in a large case series of XL products, nearly a third had a seizure, which is terrifying in itself, but even more terrifying, 25% of those seizures occurred after 11 hours. And when you look at the histogram of when those occurred, they could have happened as late as 24 hours. Okay, I just threw a bunch of numbers at you. What can we take away from this? Time to seizure is product dependent, but many of them occur late. And with the XL product, which is the most common, up to 25% occurred after 11 hours and as late as 24 hours. So, are all these bupropion overdoses just ticking seizure time bombs with unknown detonation times? Sort of. If we go back to that first case series, they noticed something interesting. All except for one of the patients who seized had neurologic effects before the seizure: agitation, tremor, or hallucination. So good news. There does appear to be a prodrome prior to a seizure. You're not just going to sit there looking great and then seize. And we look at the XL case series, they actually noted that tachycardia, agitation, and tremor were statistically significantly associated with seizures. And tachycardia even had a 93% negative predictive value. So if you weren't tachycardic, you probably weren't going to seize. In fact, a number of other studies have shown that tachycardia duration and severity also predicts seizures. So tachycardia greater than 120, greater than 140, or for greater than 2 hours, as well as some other signs of systemic toxicity like hypotension or QTc prolongation. So bupropion is a ticking time bomb, but tachycardia is the ticking of the bomb in both duration and severity. And we have a few other things we can use to risk stratify, like the presence of agitation, hallucination, tremor, or other signs of systemic toxicity like QTc prolongation or hypotension. But Camden's heart rate was totally normal. So why did I just go through all this? Well, I mean, maybe, it's only 93% negative predictive value. It means we would miss 1 in 14, right? Maybe he was one of the 14. But he had no symptoms and then had a cardiac arrest 20 hours later. That seems pretty odd. And statistically, that is odd. In the largest case series we have of bupropion overdoses, all the patients who had a cardiac arrest actually presented with a pre-hospital seizure and were already tachycardic on arrival. So he's not fitting the mold of the data that we have. Unless it's a tricky tox case. So, after Camden's arrival, the pharmacist bursts onto the scene and says, the brother is on bupropion and clonidine. Bum, bum, bum. And as we know, there are case reports of patients, such as a 16 and 17-year-old, who took bupropion with clonidine and guanfacine and experienced seizures at 20 and 24 hours, with one of them, unfortunately, dying. And both had a normal heart rate and no prodromal symptoms prior to the seizure. So symptoms that predict seizure can be masked by co-ingested alpha-2 agonists or other potential toxins that can prevent you from seeing those predictive signs. So our takeaway from today: bupropion is bad news rising. Seizures can occur late, and this makes patients high risk for an inappropriate discharge. It's not something you want to miss. Neuropsychiatric symptoms and tachycardia mean your patient is at high risk, and these are good signs, good screeners, but they're not perfect. You could miss 1 in 14 using just tachycardia. What I do think you could take away is you should not dismiss situational anxiety or tachycardia as situational. You want to make sure these patients have normal vitals and normal symptoms before they're discharged, and even that's not perfect. And then recognize some of these symptoms can be masked by co-ingestions. I'm probably over. A couple more quick things. So bupropion is a tricky toxin, and we have some tachy triage tricks, but even our training can be tricked. So how can we prevent? Tips for preventing bupropion time bombs: take a thorough history, rule out co-ingestions that might mask your symptoms, observe these patients longer, figure out an observation time in conjunction with your poison center or a toxicologist, and ensure your vital signs are normal before discharge. We have limited time together, but if you do want to hear more about this, this feels weird. I feel like I've been shouted out too many times already, and now I'm kind of shouting out myself, and I'm sorry, but this is free. It is completely no conflicts. It actually costs me money. So if you want to learn more about it, I have a podcast where I interview different experts in toxicology, and we talk about the gap junction problem, the brain death problem, the cardiogenic shock problem. It's called thepoisonlab.com. We recently did a whole series on this. Feel free to check it out. And I do want to shout out one more thing. If you like the vital signs that we had in here, it's a free downloadable program from an EM physician named Dr. Adam Blumenberg. He's an EM tox doc in Columbia, at Columbia, not in Columbia. It's called MedSim Studio. So if you ever have a case you need to make vitals for, feel free to use this free program. And with that, we're going to get to the learning assessment. Which antidepressant causes the most overdoses with serious effects, arrhythmia, seizure, cardiac arrest in the United States? A, TCAs, B, SSRIs, C, MAOIs, D. Okay, okay. And there's your explanation. And one final shout out. Thank you to my wife for watching her kids so I could be here today.
All right, two things. Let's get some business done first. In acknowledgement of some of the technical difficulties today, the CE code, 9CC, 9 Charlie Charlie. Everybody got it? Anybody need me to say it again? 9CC. Don't play with me. All right. And we have 5 minutes on the schedule. But I'm a tox person, maybe more than I ever was an EM person, and you all don't get to see enough tox if you aren't got a situation like mine. So let's get some questions, and we have a 15-minute break. If you need it, take it. But stay here if you have questions. We'll answer as many as we can for as long as we can. Does everyone understand that? I haven't been polite to anybody today. You don't have to be polite to me, and they're used to me. So questions, anybody here? Somebody watch Zoom chat, because now I can't see it. And Anne-Marie, there must be something you can ask. Yeah, but, oh, thank you, please.
Hi, I have a,
I will repeat it. Thank you.
thank you, those were all super awesome. Just a question on the prodrome for the toxicity with clonidine and bupropion. Did they give a timeline? I know you mentioned that, that usually they show up with the tachycardia or the prodrome, but did they give a timeline for like exactly the situation where you're like, I'm not gonna keep every patient where I have an unknown ingestion for 24 hours plus. So if we have that timeline, maybe you can rule in, rule out better.
Well, yeah, I would say.
Repeat the question.
So the question was, is there a timeline for when symptoms would develop if there's a co-ingestion that might
Here,
mask your symptoms?
up here. This microphone has been deemed bad.
Okay, so the question was, is there a timeline for when symptoms might develop? If there was a co-ingestion, when symptoms would be masked? There's not really a good, I mean, you got an N of 2. Really all these case reports do is to serve as notice that your rules are going to be broken, your rules about using tachycardia to rule out toxicity. We know that they're not going to be perfect. And just regular, if it's an unknown ingestion, there's other substances too that can cause late toxicity, like sulfonylureas or delayed release, verapamil, those kinds of things. In terms of OBS time, that's like a hot button topic where I know some poison centers are like, 12 hours for unknown. Some places do 24-hour ingestion observations. It really comes down to narrowing down what's available to the person at home. If it's a clonidine bupropion, they're totally fine. Still probably going to watch that because of the known fact that they can really do poorly if they're not watched at home. But let's say they don't have access to any of those things and they're totally asymptomatic. That might be someone who can go home earlier. So I would just say work with your poison center or your tox service to figure out a decent OBS time because each patient's going to be a little bit different. And the data we have to predict this stuff is pretty fragile. It could be changed by a few case reports. But that case report is listed, I think, in the slides if you want to check their timeline that they put out there.
I'm going to add to Ryan's answer 2 things, 2 points at least. Way too often, these are patients who actually psych needs to clear before they can be sent home, and they won't clear them until they think they have. At my shop, at what was my shop, they wanted 24 hours medically clear before they would take them. And so you have an indirect safety net there. But the second thing, and this is for all you all that need to start writing more and doing more, as Chris encouraged us earlier, research is great, but we need to be more visible, period. And case reports with good timelines, like vitals were checked every blank what? Help us, because if there was a gap in that case of 8 hours of nothing being checked because they were on a medicine floor because they kicked them out of the ED, then we don't know if those symptoms weren't seen earlier because nobody was looking for them. And we could take on the duty of trying to say things could be bad for the next 12 hours, so let's recheck vitals every something. Is that fair? I don't really give a rat's ass. That's what y'all should be doing, period. Another question. Is there another? Kyle, get to a mic or something. I'm not kidding. I'll repeat it.
It's a quick one. So with regard to the gap junction and the cardiac depression that we're seeing from this, are you still using bicarb? Are you pulling lipids out earlier? What's your...
Ooh. So the question, Kyle, in reference to the gap junction, are we still using, is Ryan still using bicarb? I will always use bicarb. And where is he with lipids?
And always, if you have a wide QRS, just give some bicarb. It doesn't. There's much more to the human body than the simple physiological models we have in our minds, and just do what works. So there's 2 case reports of sodium bicarb not working. There's many case reports of bicarb actually working, and sodium channels might actually be sort of disproportionately localized around gap junctions anyway, so there might be some kind of a play in there. I've posed this question to Dr. Travis Olovs, who's the medical director or assistant director over at Hennepin, and he is like brilliant. And he's like, yeah, I don't know, it shouldn't work, but it does, so do it. And I agree with his thought there. Lipid in the peri-arrest patient, I believe lipid is kind of phooey for a lot of things. It does have one of the only recommendations for use in the evidence-based guidelines for lipid. Bupropion is like one of the only ones that it says use it. I use it in a patient who's got crashing blood pressure, wide QRS, who I'm thinking might need ECMO. It's my bridge to ECMO. That's pretty much.
We got one more question from the Zoom, and apparently this mic works again for the Zoom people. So the question was, given the 24-hour OBS with bupropion XL, anyone else rec prophylactic benzo/phenobarb if patient has tachycardia, tremors, or anxiety?
So I'll start. I don't like prophylactic anything. I mean that quite sincerely. I think and you're going to have to talk, but if you're going to mask any chance of seeing if the damn thing is still there, then you might as well prophylax them for the next. Well, let's see. The record right now of a well-described case report is 96 hours before peak concentrations of carbamazepine SL happen. You're going to watch them for 3 or 4 days? I mean, if you're going to take it to that extent, what's the point? So, I like it when we give bicarb, and I like it when people stand there and wait for 2 or 3 minutes to see if it did something, and then if it did, wait before they start the infusion. We're ED practitioners. Maybe we can stand by that bedside, and if the QRS doesn't widen again in the next 2 hours, why did you start the damn drip in the first place? But God knows, everybody, time, money, too many patients, too much to do. They start the drip, and then you're stuck. What do you say to that?
I don't know about, do you guys use benzos at all in these kind of tachycardic agitated stimulant patients?
They all switched up.
Yeah. I mean, titration to tachycardia is reasonable in an agitated, stimulated patient, right? Let's turn that stimulation down a little bit. I do understand, yeah, let's not mask someone who's about to have a seizure, but maybe let's not let them have a seizure. So we definitely give, if I have a tachybupropion patient and they're kind of agitated, I'll probably recommend benzos. If it's isolated tachycardia, maybe you can OBS them. Same thing with R-wave and AVR and a TCA. If that's up, I'd say, hey, give them some benzos. They have a decent shot of, I mean, they're probably going to be pretty sick anyways. But yeah, it doesn't mean you can just give them a benzo and send them home, right? So, yeah.
So hopefully you're hearing us say there's different approaches. Just have some sense with what you're doing. There's no one way to do it. There really isn't, not in my opinion. I could give a rat's ass how many bags of this or that you use. Anyway, other questions?
Thank you all again for the presentations. They were great. This kind of adjacent question related to Akron and physostigmine. Have any of you considered, I know the case reports with rivastigmine PO, but using the transdermal patches, or if there'd be any potential benefits using that and having to avoid oral? I had a toxicologist ask.
Yes, ma'am.
That might be.
So the question was in regards to no longer having physostigmine. If we looked at, I discussed rivastigmine, but if there's any options of looking at the patch formulation. So basically you need an agent that crosses the blood-brain barrier, and so that's why we look at those agents. I know when we were going through the expiration, extended expiration, was it coming back, looking at that, the biggest thing when I evaluated it, and I'll let them speak up too, is really the time to onset of action. If using the patch, you're not going to be able to get the concentrations in the time frame that you need to adequately treat those patients, because oftentimes when you institute this, they're already agitated, so time is of the essence. So it really, clinically, to get that peak effect, it does not make sense. And that was one of the questions we had with the oral formulation rivastigmine, but honestly, based on the case reports that have been out there that came from the poison centers, is that it actually, they do respond fairly quickly even with the oral formulation. I don't know.
I'm going to thank the audience for actually asking questions, because if you didn't, I would be asking them the questions. And we're going to stop here. Get a quick break in before you go to the next one. All right, everyone? All right.
For our virtual audience, we will have a presentation on eloquence and renal function. So we're gonna, for you guys that's virtual, we will have our sponsor have a quick 15-minute presentation. Oh, no, because again, so you have it now for live, you have 30 days to do so. So once we get done with the conference, it'll be available on the website to get them sent over. We'll send an email. The problem is, I think our company's so small, we're not a big one. We're not even making it people's inbox. We're getting spammed out, and people say they can't find it in the spam, so that's what we spent this entire morning working on. So I'm gonna put it on the website, and the same thing for the CE instructions, that is now on the website. So the first thing you see come on is the instructions to go on there, so all that should be available. And we're gonna send out the CE codes like we're here at the end as well. So once we get done with today, we'll have a screen up that just has the CE codes. So again, you guys can kind of sit back, I'll make that announcement once we come back. Perfect.
And certainly one of our main areas of focus is Pixaban use. And so it is with great pleasure that we have the opportunity to share some data with you today around the Pixaban use in patients with venous thromboembolism and renal disease. When we're in the field, the questions around the use of Pixaban use in renal disease are frequent ones.
Let's see if there was a...
The problem is I don't see like the settings.
Population with VTE and renal disease with respect to what you encounter frequently in the emergency room department, as well as recognizing
the problem is, yeah, I don't know if I want to, because they're presenting all virtual, so I guess when we come back, I can come in and put hide video panel.
Population, as well as
yeah.
bleeding events secondary to population. Next
You can
slide.
also do that.
But again, okay, that's fine.
That's cool?
Yep.
So let's start with a little bit of the basics, things that I'm sure you all know in your sleep, but just to sort of level set the group. Renal disease represents a concerning population for all DOAC use because to varying extents, all DOACs are excluded. Just as a quick reminder, Pixaban is the least dependent upon renal function elimination, accounting for about 27%. And very importantly, there are several alternative pathways of elimination that can potentially help to compensate as renal function declines. Certainly, there is CYP3A4 metabolism in the liver, but also direct intestinal excretion and biliary excretion. Next slide. Also, as a quick reminder, with respect to dose reduction guidance in the setting of renal impairment, I'm sure there's a lot of pharmacists online today. Certainly, as you know, most drugs dose reduce with respect to patients that fall below a certain catheter threshold. With the Pixaban, the directive is quite different. One must first consider the indication, and for patients with atrial fibrillation, patients need to meet 2 of 3 criteria before the dose is reduced from the standard 5 milligrams twice daily to 2.5 twice daily. Certainly, one of those criteria is serum creatinine of 0.5 or greater, but again, even if they meet that criteria, regardless of attitude, they must also have either an age of 80 or greater or a body weight of 60 kilos or less before one should technically dose reduce, unless there are drug interaction concerns to comment on that. Of interest, those same criteria also apply to patients that might need dialysis. And very importantly for today's discussion, as a reminder, the ABC dose reduction criteria do not apply to those patients that are being treated with a venous thrombolytic event. Drug interaction concerns might warrant a dose reduction, but not those criteria. So with that in mind, let's talk a little bit about data. So with respect to support for the dosing guidance around apixaban, if you were to look at our prescribing information, you will see reference to two small single-dose pharmacokinetic studies. One by Chang that looks at pharmacokinetic parameters in the setting of the varying levels of renal function as defined by reactive clearance. The other study by Wang and colleagues looks specifically at the hemodialysis population. While both of those studies do show modest increases in area of exposure with respect to declines in renal function,
So as long as we don't, and then you should be able to get to them. Maybe just wait until, here comes Kyle to take over the screen.
Megan told me to do it now.
Oh, perfect.
Well, you're up next, right?
Yeah.
So-
I think that's what they're
No, but that's why I'm like, this slides and the music while we're
Audio on.
Yeah.
I'll take.
Yeah. Do you want this chair again over here?
Sure.
Oh, look at this timer. That's intense.
Right?
There are some limitations with these trials, and those are listed here for you. They obviously cannot prove finality, but they do.
So no one can see your.
We're gonna just play some filler slides. Is that okay?
Why can't I?
What's that?
Product activation
gotcha.
failed.
Okay, we'll make sure. Yeah, we got a couple minutes in between the next. So.
Okay.
It doesn't say that anymore, so hopefully it's okay.
I might need your help, Kyle. It doesn't let me like edit anything.
Do you have the file that you need this text?
But it's on my computer. Oh, sure. Yeah. It says like
Yeah. This computer is really weird, so I wonder if you can just like email it.
I'm fixing our slides.
Are you trying to change drugs?
Yeah, I actually put you as AA now. I emailed it to myself and pulling it up now.
We do sort of intro, efficacy, safety, and then we want to do rebuttal. Probably not rebuttal. Probably just questions.
Yeah.
Since we kind of rebut each other. Well, I can put my slides up and then she sort of where you go to tailor it, you know?
Yeah. Oh.
Oh, you think so? Oh, really?
I don't know. I feel like everyone's PCC, and I'm just gonna be like, see, so I don't know.
Yeah.
Man, is this computer is from like 2000? What is this?
Yeah, is there anything we can do to mitigate any of the stuff? They're all in one though. Yeah, we combined them. Yeah, which is smarter. Is that the one?
I think so. I got rid of the open-ended slide.
Oh, you did?
Yeah.
It's not that hard.
Good?
Good to go.
Okay.
No, I think I want them to see my face. What happened to bros before? No, it's fine. Okay, fine. It's not reversing. I know. I don't know why they took it out. This was the original slide.
Should I take my jacket off for this?
I don't know.
they get done, we'll kind of transition over. The problem was, he said that when we cross over to this, it's not crossing back over to the mic, so he can kind of make sure. Because the audio was messed up because it was picking up from the computer.
Oh, and not the mics. Got it.
Have they? You guys went through these and kind of messed around with it? Is all the stuff on there?
It's good. Everything's ready to go. Yeah. We'll just have to. So I don't know. He like unmuted the Zoom thing before. We can do that right before.
What he did was he came and we had to put it on this one. It was picking up from the computer. It wasn't picking up from there. I know, but I want to make sure. Just want to make sure.
If you start getting, you know,
I want to make sure I'm using the right one. Is it Sure Digital?
Microphone, Sure Digital. It's already on Sure Digital.
Okay, I just want to make sure.
CMA system. Actually, I think it might be microphone.
Microphone, this one?
The top one.
Perfect.
And then, is there any way we could test it?
Yeah, we'll wait till she gets done talking and then go from there.
No, I have you muted down back here. Can I bring it up?
Okay, yeah. I got it over here. Okay. Apparently that one's good.
Okay.
Oh, sorry, Kyle.
Oh, you're good.
Oh, do we need a...
Again, so one of the things I want to make sure we do at the end, make sure it's in your name, your industry, or any disclosures before any question. So I'm serious about that.
Okay.
So I just want to make.
Before I answer.
No. So when they ask their question, I'm gonna ask them. State your name, and then we can kind of repeat if they can't hear certain stuff. So I'm gonna have Helene bring the mic to them, and she can say, "Hey," and she'll probably echo, "Hey, name your any disclosures to release."
Are they all here?
No. Right. Testing. Zoom, can you hear me? The Zoom audience, can you hear me? You can just type in the chat.
Do I have to unmute from up here?
Testing. Zoom audience, can you hear us? Thank you.
And then do you just want to make sure this
Yeah, it's fine.
All right, while we get our slides going, I'm going to introduce our next speakers. We have Brian Gilbert, emergency medicine clinical pharmacy specialist, practicing at Wesley Medical Center in Wichita, Kansas. He currently serves as the PGY2 Critical Care Pharmacy Residency Program Director and Adjunct Assistant Clinical Professor at the University of Kansas School of Pharmacy. And we also have Dr. Caitlin Brown, Assistant Professor of Pharmacy and Emergency Medicine at the Mayo School of Medicine in Rochester, Minnesota. She's a clinical pharmacist in the emergency department and neuroscience intensive care unit. And they are going to be discussing a debate which I don't think has ever been talked about before. And so let's welcome them to the stage to talk about andexanet alpha or PCCs for factor Xa reversal.
All right. Well, thank you, everyone. Thanks for coming, and thank you to the Empowerx Executive Committee for allowing us to come here today to talk about, as Kyle said, something that really isn't very heated or been discussed at length anywhere. So in terms of, did that go? Sorry, it's my first time using PowerPoint. Oh, there we go. This doesn't bode well. In terms of disclosures, I have no relevant financial disclosures or conflicts.
Yeah, and I awkwardly need to disclose I have funding from Alexion and AstraZeneca as the pro Andexanet alpha side.
So take that as you will. So our objectives for today's talk will be to describe pharmacological characteristics of andexanet alpha and 4-factor prothrombin complex concentrates, or 4-factor PCC, compare, contrast literature and guideline pertaining to hemostatic efficacy and safety of andexanet alpha and 4-factor PCCs for life-threatening bleeding in patients on factor Xa inhibitors, and then develop patient-based treatment plans. So we were going to poll, and I don't know if it's necessarily going to be working, but just show of hands, what do you currently use for factor Xa inhibitor reversal at your shop? So andexanet alpha? Oh boy. PCCs? All right, I'll see you guys later. I was a little optimistic with this talk and telling Caitlin I'm sure it would be more 50-50, so I'm very glad to see the latter there. And then other. Does anybody not use anything? Okay. Hey, that's also an option. So next we'll be discussing, the way that we're going to have this talk kind of broken down is we'll go back and forth here. We're going to discuss efficacy first, safety, and then some final conclusion thoughts. And so for those of you who are maybe even considering potentially andexanet alpha over 4-factor PCC, again, this is a highly contested and debated topic. And with a debate, the sort of inference is that there is a winner to this. And so I am not above putting pictures of my cute child into my slides to win this debate. So Baker would like you to know that he is not mad at you for thinking about andexanet alpha, but he is disappointed. So I refuse to come to a hemostatic lecture and there be like the clotting cascade and the sort of boring approach to how we treat or teach hemostasis. And so, with that said, we understand that the coagulation and hemostatic process is a lot more complicated in terms of just a linear coagulation cascade. One activates this, and this. They're very intricate and they're very in-depth processes that occur simultaneously. So I actually prefer the cell-based model of hemostasis here, which breaks things down into the initiation, priming, and propagation of clot formation. So in terms of what we're talking about today, we are talking about factor Xa inhibitors, and we are talking about essentially where they work. And as you can see, they have multiple places here where they do exert their pharmacodynamic effects to lead to reduced thrombin and reduced fibrinogen, right? So the patients do have, quote unquote, thinner blood. The other thing I want you to really think about when you look at this process is that there is a myriad of things that could go wrong in terms of the hemostatic process. And so factor Xa itself is just one single process. So it can be multiple things wrong with the patient that can lead to bleeding. So beyond that. So wouldn't it be nice if we had an agent that had multiple different things in it in terms of a broad spectrum approach to allowing and creating thrombin and creating fibrinogen? So here we have the commercialized 4-factor PCC product, Kcentra, which is currently the only FDA-approved 4-factor PCC in America. That will be changing probably pretty soon. But you can see, so things I want to just sort of highlight here is obviously you're all aware of this, the different factor contents and the different half-lives, right? So this is probably beneficial in a patient that has a bleeding episode beyond just a medication-induced coagulopathy. So if you have somebody that's got a traumatic event plus a medication-induced coagulopathy, I think it's pretty beneficial here to see how this agent may be able to produce that thrombin and then leading to fibrinogen cross-linking. So pictorial-wise, so it took me a long time to actually make this slide, so that's why it's in there a bunch of times, so I do apologize. Dr. Reck told me one time it's so much easier just to have your own slide and then use it for repeated purposes, so advice heeded there. But this is essentially when we look at the process of four-factor PCC and hemostatic management. I will concede that the title of this probably should have been not reversing, but the hemostatic management of factor 10A inhibitor bleeds. It doesn't reverse. Who gives a shit? So, and when we look at PCCs, the way that it works is we overwhelm and overburden this clot formation process. So we administer four-factor PCC and we generate thrombin, right? That's ultimately what we want to do in this process. We want to generate thrombin to lead to fibrinogen. Now the question becomes like, how well does four-factor PCC do that in comparison to indexin alpha? So we have two graphs here. So the graph on the left is essentially looking at a patient that has received apixaban concentrations and then also four-factor PCC infusions. The patients on the left received apixaban 10 milligrams twice daily, and then on day 4, they received their morning dose and then a 50 unit per kilo infusion of four-factor PCC. And as you can see on the left, on that y-axis, that is thrombin, endogenous thrombin potential. And then on the right there is essentially the other drug that will be discussed today. I'm not going to name it. The other drug in terms of how it works for endogenous thrombin potential as well. So obviously pretty comparable when we look at that. But you're sitting there saying, BG, I don't treat test tubes. Who gives a shit about that? So, right? So when we look at real world efficacy of four-factor PCC for hemostatic management of these bleeds, this was a pretty good meta-analysis, and I will admit there are several meta-analyses out there on this topic. This is one that I found that had the least amount of commercial bias, so I tried to include it sort of as a good litmus test. There were 554 patients, with the majority of these being intracranial hemorrhages. And in terms of mean hemostatic effectiveness, you can see that the patients in the indexin alpha group had an 82% hemostatic efficacy that was positive at 12 hours and then 71% at 24 hours, compared to PCC that was 88% at 12 hours and then 76% at 24 hours. In terms of the ICH patients, a pretty broad difference there, but again, I will say that none of these were statistically different. Mean in-hospital mortality was 23% for indexin alpha compared to 15.8% for PCC. One thing that is pretty interesting to think about is that 12 and 24-hour hemostatic efficacy endpoint. As we begin to see more and more of these patients receive factor 10A inhibitors that are going to have indications that may prolong the drug presence, so CKD, liver failure, these type of things that would reduce clearance, it's interesting to think that maybe that longer hemostatic efficacy will be of benefit. So guideline recommendations, I'll go through these pretty quickly. The Society of Critical Care Medicine and Neurocritical Care Society do recommend four-factor PCC at 50 units per kilo. However, this was prior to the approval of indexin alpha. And I will say that they have a caveat in the guidelines that say that if there is a specific antidote available to use that specific agent. ACEP actually recommends indexin alpha over four-factor PCC. I will say that guideline was funded by the makers of indexin. There's really no way around it. It was funded by educational grants from Alexion and AstraZeneca. The American Heart Association, American Stroke Guidelines, they do recommend four-factor PCC over, or recommend indexin alpha over four-factor PCC as well, but don't really give a clear rationale as to that indication or why. And then the Anticoagulation Forum recommends indexin alpha over four-factor PCC, a fixed dose. However, this was prior to the fairly robust fixed ICH study that evaluated over 400 patients that had ICHs and received PCCs. And having spoken with one of their guideline authors, that would have been something that they would have considered moving forward in their recommendation. Other operational considerations, four-factor PCC can be given expeditedly, really quickly, usually stocked in automated dispensing cabinets, has easy reconstitution. Indexin alpha has been associated with delayed administrations in randomized controlled trials, up to 3.5 hours average on the Annexa 4 trial that just finished. It's usually not stocked in your automated dispensing cabinet. I'm not really sure how you could. And then has a complicated reconstitution process. Not to mention the dosing algorithm for this, for anyone that's ever had to do it, it's pretty complicated, right? Whereas 4-factor PCC, we do pretty much flat dosing, either 50 units per kilo, 25 units per kilo. So this slide represents basically the different strategies of dosing at various rivaroxaban concentrations. And so one of the things that's pretty important to note is that 25 units versus 50 units in terms of endogenous thrombin potential look to be about the same. And it's likely due that as you escalate the dose of PCCs, you're also getting escalating doses of protein C and S, so probably no added benefit. So example case here. So you have a 53-year-old male with history of atrial fibrillation receiving apixaban 5 milligram twice daily, a history of CKD, and then in stage 2 comes to your ED. They experience an isolated TBI. GCS is a 12, and then you get a anti-10A assay that confirms that there is serum drug concentration. So for me, in this setting, I think all of us would want to have something that exerts prolonged hemostatic efficacy. And so this is where PCC would really tend to be of benefit over indexin alpha, which is associated with rebound levels, which I'm not sure my colleague will talk about or not. Anyway, so in terms of our assessment question, PCC generates thrombin similar to indexin alpha. With the data I did show you, again, that was true. So in terms of our efficacy bottom line from the pro-PCC side, PCCs have the ability to generate thrombin at a rate similar to indexin alpha. There's sustained pharmacodynamic effects, which we obviously are beneficial, especially in protracted factor Xa inhibitor coagulopathies. And then operationally, it's much simpler. So if you are team PCC, this is the hashtag that we're asking you to use on top of the Empowerx hashtag. So with that, I'll hand it over to my colleague, Dr. Brown.
All right, so the raise of hands, it was like my 2 colleagues from Mayo and 2 other hands for Indexa, so I clearly have the less popular opinion in this room. But I'm going to jump in and talk about the efficacy of andexanet alpha. So because Brian spent so much time on this slide, I decided to use it as well. But andexanet alpha's pharmacology, it's actually a reversing instead of like PCC overwhelming the coagulation cascade. So andexanet alpha is a decoy molecule which has high affinity for factor Xa inhibitors. So it will take those factor Xa inhibitors and bind to andexanet alpha instead of the 10A, which leads to thrombin generation and then fibrinogen. It also inhibits activity of tissue factor pathway inhibitor, which we'll talk about a little bit more when we look at thrombin generation. So the onset of andexanet alpha is super rapid, 2 to 4 minutes, and I have a question mark for duration here. As Brian noted, the anti-factor 10A activity does return to baseline after andexanet alpha about 4 hours. However, what we're probably more concerned about is the thrombin generation, and this is sustained for at least 22 hours after andexanet alpha, and I'll show some slides about that from the Nexa-4 trial. Apparently to Brian, andexanet alpha dosing is difficult, but it's really not that hard. You need to know 2 things, and you're practicing in the emergency department, and you're probably gathering this information anyway. So you need to know the last dose that they took in milligrams, whether 5, 10 in the drug, and then the time of the last ingestion. So I will recognize that sometimes it's difficult to know when they took their last dose. However, it's less than 8 hours or greater than 8 hours. With those 2 pieces of information, you're going to determine if they get the low dose or the high dose regimen. So the low dose regimen is a 400 milligram bolus followed by an infusion for 2 hours, and then the high dose is an 800 milligram bolus followed by an infusion for 2 hours as well. I have to jump into this Liu and colleagues study since Brian talked about endogenous thrombin generation, so bear with me while I go through these graphs. The first one on the left there, what they did was this is an in vitro study, and they added rivaroxaban, similar results for apixaban, but I have rivaroxaban shown here, and then they added 4-factor PCC or andexanet alpha. So orienting you to that graph, along the x-axis is rivaroxaban concentrations nanogram per milliliter, so ranging from 0 to 2,000. And then along the y-axis is endogenous thrombin potential. The dotted line around the 1,000 is where a normal plasma would be. So if you're not on anticoagulation, your endogenous thrombin potential being around 1,000. That shaded yellow area is where about 75% of patients in the Annexa A had levels, so you had to have a level greater than or equal to 75 nanograms per milliliter to look at efficacy outcomes in the Annexa A4 trial. So the black line is 1 international unit per milliliter. So this is equivalent to giving 50 units per kilogram of 4-factor PCC with someone on rivaroxaban. The blue line with the circle, the 0.5 international units per ml, is equivalent to about 25 units per kilogram of PCC on someone with rivaroxaban. And then the red one is 0, so basically like placebo. So we can see that if you're to the left of that 75 nanograms per milliliter of rivaroxaban, I'm not going to argue, 4-factor PCC leads to endogenous thrombin potential and therefore probably works for reversal when your factor 10A concentration is low. However, once you get above that 75 nanograms per milliliter, you can see that the 50 units per kilogram and the 25 units per kilogram do about the same thing as giving placebo. So 4-factor PCC, when we have a therapeutic concentration above or equal to 75 nanograms per milliliter, probably isn't doing much. Then if we look at the slide on the right is rivaroxaban with andexanet alpha. Similarly, along the x-axis, we have our rivaroxaban concentration, endogenous thrombin potential along the y-axis. The black line with the 4 is the high-dose regimen, and the blue line with the 2 is the low-dose regimen. And again, the red is 0 or placebo. And despite having rivaroxaban concentrations greater than equal to 75, andexanet alpha does still lead to endogenous thrombin potential. So in summary, the anti-10A concentration matters. Brian showed you some data. Maybe the rivaroxaban concentrations or apixaban concentrations were low there. You could overcome the coagulation cascade by giving 4-factor PCC there. But once you get above the 75 nanograms per milliliter, it looks like it's not doing much. So in February, they published the Annexa 4, an updated study, I say because they enrolled more patients and had about 400 patients now in their results. We're probably all familiar with this study, so I'll just go through it briefly. It was a multi-center prospective open-label single-group study. So the biggest limitation and why we're having this debate today is there was a single arm, so we have no comparative randomized controlled trials. They included patients with apixaban, rivaroxaban, edoxaban, or enoxaparin, and they gave the bolus and infusion in the dosing I listed previously. Their primary endpoint was % change in anti-10A activity, and then they also looked at excellent or good hemostatic efficacy, which was adjudicated by a committee. So they had 479 patients in their safety outcome, so they looked at thrombotic events in this group, and then 349 patients in their efficacy outcome. The numbers are different. They only looked at efficacy if their anti-10A level was greater than or equal to 75 nanograms per ml. So they were ensuring that they were looking at efficacy when patients had drug on board. Rivaroxaban and apixaban were the most common factor 10A inhibitors, and they did include about 70% of patients having an ICH. Anti-10A activity at baseline and then end of bolus and end of infusion did drastically increase. We have time along the x-axis and the anti-factor 10A activity along the y-axis. It does rebound at 4 hours, as Brian was hinting at, and then as the body clears the drug, it starts to decrease. Similar outcomes for apixaban that you can see here in the graph. Drastically decreases anti-10A level after the bolus, stays low for the duration of the infusion, and then a bit of a rebound at 4 hours. However, thrombin generation at the end of the bolus, end of infusion is high, and thrombin generation stays sustained for at least 22 to 24 hours. So its reversal effects for thrombin generation are lasting more than that 4 hours. The results of the study in terms of hemostasis, in all patients, ICH, GI bleed, 80% excellent good hemostatic efficacy. For just ICH patients, 79% hemostatic efficacy, and then for GI bleed, 82%. So let's talk about comparative trials, since that's a single-arm study, great, Andexa, 80% efficacy, but how does it compare to 4-factor PCC? So Brian didn't touch on most of the 4-factor PCC studies are retrospective studies. There's a heterogeneity of definitions in these studies. So are they using the definitions that Annexa 4 did with 20% and 35% hemostasis, or are they just looking at expansion and CT scans, et cetera? And they don't have any anti-10A levels to confirm drug on board. So are patients really taking the factor 10A inhibitor, or are we just reversing someone who wasn't on any drug? So in the lack of randomized controlled trials, we do have 2 propensity match trials by Costa and colleagues and Cohen and colleagues. The first, by Costa and colleagues, they looked at patients from Annexa-4 and they matched them to a historic cohort in just ICH patients. They did match them on baseline GCS, ICH volume, age, comorbidities, and they found that excellent or good hemostasis was 85% for AA and 70% for 4-factor PCC, and 30-day mortality was also better with andexanet alpha compared to 4-factor PCC. And another propensity match study by Cohen and colleagues, they also included the Nexa-4 patients, and they matched them to a historic or a control from the Orange database, which is a database in the UK. It's a prospective observational database, and they found that 30-day mortality was worse for 4-factor PCC at 34% compared to 14.6% with AA. I will note that limitations in this prospective or propensity match study, they couldn't match based on GCS and ICH volume. That information wasn't available from the Orange database. So time to administration, Brian brought up. So this graph is looking at studies that looked at time from order to administration with andexanet alpha and PCC, and then time in minutes along the y-axis. So the ones in blue are real-world studies of andexanet alpha and the time it took from order to administration. So 46 minutes and 61 minutes. And then your dark red is time from order to administration with PCC with a pharmacist, and then the light red, the pinkish color, is without a pharmacist. So we can see that andexanet alpha in the blue compared to the red, I'd argue that maybe 16 minutes isn't too much of a difference. And then if you don't have a pharmacist, andexanet alpha performs similarly. And lastly, cost. So when andexanet alpha came out, it ranged from, let's say, $28,000 to $60,000 for a dose. And I can't fault anyone for not wanting to use a drug that costs that much. However, that is not the case anymore. So AstraZeneca just dropped the price over 50%. So let's say you gave 4-factor PCC at a dose of 50 units per kilogram to a 85 kilogram patient, and the wholesale price is 2.62 units. Your cost at your institution might be a little less, might be a little bit more, but costs about $11,000. The low-dose regimen, which is about over 70% of patients get the low-dose regimen, is $12,500. So if you're using cost as your argument, it really no longer stands, as they're very similar in cost. So with that, I'll highlight that Brian talked about the guidelines for me, so I didn't need to touch on that. All the guidelines recommend andexanet alpha over 4-factor PCC. So which agent is FDA approved and recommended by several guidelines? And this would be andexanet alpha. So bottom line, AA is approved by the FDA and endorsed by several guidelines. AA has prospective trials with adjudicated endpoints to support its use. And propensity match studies provided better efficacy, and cost is now similar between the two agents.
My fist was balled up as I was listening to some of that stuff. So yes, efficacy, definitely a big part of that, but obviously safety is another huge issue that we need to dive into. So any safety issues certainly makes Baker upset there. So let's get into it. So Dr. Brown did discuss that andexanet alpha also works to generate thrombin by the tissue factor pathway inhibitor. So going back to our neat little graph here, like, what does that mean, right? So tissue factor pathway inhibitor is basically your check engine. It basically allows for a way to prevent erroneous, or not erroneous, but like just too much thrombin and clot in that situation. However, when you add andexanet alpha to that mix, we now are, the graphic went away, sorry. In the old slides, the graphic was there, basically showing andexanet alpha inhibiting tissue factor pathway inhibitor, which then allows, oh, there we go. All right. So then we end up having sort of excess thrombin generation, right? Which could lead to, inappropriate clot formation, right? So we're already removing the drug to patients that are in a prothrombotic state. So that's check one. And then check two here is that we're removing our brake pedal. So we can lead to inappropriate clots there. So a third mechanism by which andexanet alpha actually is sort of leading to some of these inappropriate clot formations And this is sort of emerging. It's sort of happened in the past few couple years here with more and more case reports, but heparin resistance. So andexanet alpha itself can convey this effect, and there's been case reports of excessive doses of unfractionated heparin needed during cardiac surgery for after andexanet alpha utilization. So, if you're not able to heparinize these patients that need a complicated cardiac procedure, what in terms of efficacy, we can go into that, but like safety-wise, what does that mean for our patients? So this heparin resistance can have extremely detrimental outcomes for procedures and may explain some of the thrombotic rates we see with andexanet alpha. Going back to the same meta-analysis that I had previously, essentially the same data here, but now we look at our VTE rates. So 30-day VTE rates in this meta-analysis was 5% for andexanet alpha and then 1.9% for PCC. And then 30-day thrombotic events was 10.7 for andexanet alpha versus 3.1%. So one thing to highlight on any of these studies, whether or not you're using andexanet or PCC, is the appropriate reinitiation of anticoagulation prophylaxis or full dose anticoagulation, depending on the indication. So, this is something you got to consider in terms of, with any of these agents, and something that I think we both would agree on that's an important aspect in the literature that we need to continue to make sure that we as pharmacists can emphasize. The other thing I want to consider, or everyone to consider too, is when we talk about VTE events or thrombotic events, VTEs will fall into that thrombotic event rate. But all of those are not created equal. When you look at the proportionate amount of thrombotic events for andexanet alpha, the majority of them are through mechanisms of acute ischemic stroke, whereas with PCCs, it's mostly VTEs, right? So certainly not VTEs are certainly not something we want for our patients, but if you had to pick a VTE over a stroke, I think we all would pick stroke or VTE in that situation. I'm having a stroke. Mama made much money. It is a sunny day, and sorry. Am I clear? Any physicians in the room? Am I clear? Okay. All right. The other thing I want to think about in terms of safety too is formulary management, which is really something to be concerned with if you have andexanet alpha. So you're not getting rid of PCCs, right? So you have to have it for warfarin. That's still going to remain our drug of choice for reversal in that situation. And so you've got an issue here where patients, you get kind of confusing sort of backgrounds. You're not sure which medication they're on. So what do you do if a patient receives andexanet alpha or PCC, vice versa, and utilizing both? So that can become detrimental in terms of formulary management. So just something to consider. So this case in terms of safety is one that, it's a very real case. It's not I wouldn't say a rare event, but imagine you have a patient that has a pulmonary embolism that develops a critical bleed, right? But now all of a sudden you have to begin to anticoagulate this patient again, right? So in this patient, if you administer andexanet alpha, you essentially have deheparinized this patient and placed the patient at higher risk for some of those more detrimental thrombotic events. Sorry, I'm playing catch up because I was talking a little slow there. So safety and bottom line in terms of 4-factor PCC. Again, regardless of the agent utilized, resumption or initiation of prophylaxis or anticoagulation is imperative. I would, in terms of the literature, beyond just the meta-analysis I shared, and I think that what Dr. Brown will show as well, is that the rates of thrombotic events are really similar. However, if you look at the weight at each of the thrombotic events that the patients have, needs to be considered, right? So thrombotic events for andexanet alpha is primarily going to be strokes versus with PCCs is going to be VTEs. So just something to consider. And then all the additional mechanisms by which andexanet alpha can generate clot and inappropriate clot needs to be considered depending on the indication, especially if a patient has to undergo a procedure that heparinization may be critical. So, all right.
All right, there's maybe some points Brian and I actually agree upon on this part. So, andexanet alpha safety. So I think we need to ask ourselves when we're thinking about thrombotic events and reversal agents, is it the reversal agent or is the patient predisposed to having thrombotic events? If we think back to Virchow's triad, these patients are hypercoagulable. They were on anticoagulation for a reason. We've removed that. They now have stasis from being in the hospital and then potentially endothelial damage as well, depending on what caused their bleed. So timeline matters. So if you have a thrombotic event that happens 2 days or 1 day after reversing them, sure, we could potentially contribute that to the reversal agent. But if it's happening 30 days after reversal, you're going to have to convince me really hard that it's from the reversal agent and not from not restarting anticoagulation or their predisposing factors. So looking at the results of ANEXA-4, they found the percentage of patients having a thrombotic event was 10.4. However, 7.1% of those occurred before anticoagulation was restarted. 32% of their thrombotic events occurred in days 15 to 30. So it was after the acute phase of them being reversed and probably secondary to not having anticoagulation restarted. No events occurred after resumption of oral anticoagulation. So agreeing with Dr. Gilbert that it's important that we restart anticoagulation when safe in these patients. A different meta-analysis found no significant difference between thrombotic events with andexanet alpha versus PCC. However, they did find a lot of heterogeneity in outcomes with PCC. If we're looking at the results from ANEXA-4, there was an adjudication committee. We were looking for thrombotic events. They were trying to look at safety outcomes. If we look at all the retrospective studies with 4-factor PCC, it's chart review. If it's documented, not documented. Some studies use a definition of 7 days, some use 30 days. You're really comparing apples to oranges when we're talking about thrombotic events here. So safety bottom line for andexanet alpha, anticoagulation should be resumed as soon as possible, and there hasn't been any difference in thrombotic events between agents in the meta-analysis or propensity match studies. So another case here, GB is a 62-year-old male. He's 102 kilograms on apixaban. That's Brian's initials backwards, for atrial fibrillation. He comes in with altered mental status and is found to have interparenchymal hemorrhage about 15 milliliters in size. His last dose of apixaban was 10 hours ago. His GCS is 12 and his ICH score is 1. Your site has both andexanet alpha and 4-factor PCC on formulary. What do you choose? I don't know if I want to know the responses here, but andexanet alpha, 4-factor PCC, or neither. Who's giving andexanet alpha? Great, thanks, Nick. And Mayo people have to raise their hands. So that's 4, awesome. We maybe gained a person, and I won't ask the other 2. Okay, so AA or PCC? I'm just kidding.
I do have a question. Apples, oranges. Why can't fruit be compared? But anyway. So overall conclusion as we look at this debate, it's certainly not going to be ended here with just this. We really need randomized controlled data, large data sets to really make that decision for us. But overall, PCCs do generate thrombin at a similar rate to andexanet alpha and has real-world efficacy, demonstrating similar hemostasis rates. The thromboembolic events might be more common in andexanet alpha, just depending on the meta-analysis you look at. But again, the degree of that thrombotic event needs to be accounted for. And again, it has several different mechanisms by which it can promote inappropriate clot formation. And I still stand by that there are operational and formulary considerations that give the advantage to PCC. So with that said, before you go, if you're not on Twitter, I've seen my phone blow up a little bit, make sure that you are hashtagging Team PCC. This makes Baker extremely happy. So, and that's what we live for, right? So
in conclusion, Baker's very cute, but AA is FDA approved and recommended by several guidelines. We have higher quality data to support its use in a prospective observational study, and propensity match studies have shown better outcomes with andexanet alpha. The cost is now comparable between agents, so cost shouldn't be the prohibiting factor, and most thrombotic events happen before anticoagulation is reinitiated. Also, hashtag there for Team AA. So I think with that, we'll take comments or any questions.
yeah, okay.
All right. I'm Nick Peters. No conflicts of interest for money-wise. My question is for Brian, actually. I think an argument against Indexa is the complicated dosing scheme, right? Low, high, less than 8 hours, greater than 8 hours. So what would your response be to somebody who said that the PCC dosing scheme is complicated, that everyone has different fixed dosing regimens, people decide to do fixed versus weight-based in various indications? How would you respond kind of thinking that, if you actually think about it, the PCC dosing scheme might be a little more complicated in some cases than the Indexa dosing?
So the question was essentially a cumulative question about dosing strategies, and is Indexinate alpha that much more difficult than PCCs with all the variability in weight-based versus fixed dose? And I would argue that she states that the majority of the patients received the low-dose Indexinate alpha, but is that actually the right dose for the patient? So are you at 70% are receiving that, but how many of that was inappropriate? In terms of your question for PCC, I think that if you operationalize it at your institution, many have actually switched to four-factor, like flat dosing for warfarin and flat dosing for PCCs, which essentially equates to anywhere from 3 to 4 of the 500 vials. So you're looking at 1,500 to 2,000 units for most, which is actually recommended by the Anticoagulation Forum, which takes about roughly 2 minutes to reconstitute each vial bedside. So you could, and then in terms of administration time, I think most of us would argue that in those life-threatening bleeding situations, you're taking, anywhere from 60 to 80 cc's and just pushing it over 5 minutes. So you're reducing operational considerations not only for getting the drug to the patient, but also the downstream effects of your inpatient pharmacy not having to take up time for that particular patient and reconstituting all of that. So,
Okay. Thanks, Caitlin. I tried.
So my question for both of you is, let's say Indexinate alpha costs $5. Would we ever be even having this conversation?
So this was posed by Gary. Anybody knows Gary Pesca at Rush? He posed the same question, and I would argue yes, right? So if you look at thrombotic events, and my sort of hesitancy with the drug has never been really the cost. I mean, the cost is what it costs. If it works great and is safe, there's much more highly pharmacoeconomic burden drugs, I think that the safety endpoints is certainly concerning. Again, when you can't just lump thrombotic events together as one thing. VTE is one thing, but acute ischemic stroke is another. So.
I'd say no, but that's what I'm supposed to do. So I think if you look at Annexa 4 and you look back at, the Sarod study that led to PCC approval and the Praxbind study, you can't argue with me that those studies are higher quality than Annexa 4. Like, Praxbind study is garbage, and we had no problems adapting Praxbind. The Sarod study didn't even show an improvement in outcomes with PCC versus plasma. We got lower INRs, but we didn't have better hemostatic efficacy, and we all started giving four-factor PCC in Praxbind. So in my opinion, I think cost was a very prohibited factor in adoption of Indexinate alpha, and then has led to probably some fair and some unfair critiques of the drug, and now here we are today.
Caitlin, I'm going to direct this.
I would rebut one thing to that comment. So PCCs reduce INR. Indexinate alpha reduces anti-10A activity, which in Annexa 4 did not correlate with hemostatic efficacy. Boom.
We had an online question from Nikki Newton. I'm going to direct this to you, Caitlin. For Indexinate alpha, have you had providers want to extend the infusion beyond 2 hours if hemostasis wasn't achieved, or while still in the OR? And have you had providers want to potentially repeat the regimen if the ICH were to worsen or not resolve?
Do I need to repeat that on this mic? Okay. I have not had that situation. So we've just given, we also are fortunate, I've never run into the situation of someone getting PCC. If someone got PCC at one of our community hospitals or outside hospital, we're not giving them Indexa when they get to us. Like, they're reversed and not getting 2 agents. And we haven't had anyone ask for extending the infusion or giving another dose. So we've just said no.
So they got PCC and you guys were happy?
Megan Rack, no conflicts. If I have time for one more question, what do we do with surgery? We saw the concerning Indexa S initial data with 10 patients enrolled. What should we do? What do you guys do for surgery now, especially given the heparin resistance? If we do add Indexa to formulary, like, do we have to still use PCC? And then is that, duplicating our efforts and making things more complicated?
We use PCC if they're going to surgery. For neurosurgery, our neurosurgeons have found good efficacy. What are we debating? No, because I practice evidence-based. There's no data looking at Indexa going to surgery. So we've followed the evidence, and we still use PCC given the lack of data for Indexa alpha. However, our neurosurgeons have found neurosurgeons being neurosurgeons have used Indexa for going to neurosurgery and say that it stops the bleed and are very preferential to using Indexa alpha. So that's the one group that's using it prior to surgery, but we are not using it for other elective or emergent procedures since we don't have any evidence to support it right now.
Yeah, I mean, well, that one too, I mean, not going to get as much heparin in that situation, so it probably makes more sense too. The other thing to consider is if you even need anything, especially in a patient that has good clearance, depending on when the surgery is going to be. Like, if it's an emergent within the next hour, sure, but if the patient can wait 12 hours or so and let one of the half-lives of the drug go, then I think that's also something to consider. We have to be considerate of that because, again, these patients are at a prothrombotic state, so adding anything that could increase the prothrombotic risk needs to be weighed. So perioperative management of that with the anticoagulation forum has really good guidelines, so does CHEST. So.
Hi guys, thanks for a good presentation. I'm Tony, I'm a PA, don't have any conflicts. Just in terms of speaking on safety, do you guys know, I know we give a lot of other blood products to these people, platelets, whole blood if we need, FFP sometimes. Do you know if they controlled for giving those and matched those patients with efficacy or safety? And then do you know how many, like the proportion of strokes versus VTE comparatively? I know you spoke that Andexanet has more strokes in it, but how much? Is it 1% more or is it 20% more?
I actually don't remember the Annexa 4 rate, but it was fairly concerning. In terms of matched, I'm aware of only a small case series of PCC administration with something like platelets and desmopressin, and the author's sitting in this room. And so there was no thrombotic events with that combination. Others, in terms of mass transfusion and requirements, there was actually a recent study that looked at PCC administration in trauma, like severely ill trauma patients, in the ProCoag trial that actually showed no difference in terms of thrombotic, or actually there was a slight increase in thrombotic events, but you're also just at an increased risk because you're a trauma patient, and they didn't really look at or demonstrate VTE prophylaxis rates and initiation times. So still within less than 5% rate for even getting concomitant blood products with it.
I don't have anything to add. I should know what the stroke rate was, but I don't want to misspeak and give the wrong number right now. So.
Thanks, guys.
All right. Thank you both. The CE code for this session is 5, C as in Charlie, T as in Tom. It's 5, C as in Charlie, T as in Tom. All right, so I'm sure I'm not speaking for myself. I remember, mid-pandemic when we were playing pandemic bingo, and monkeypox was the next thing that came up on the bingo card. I was ready to start pulling my hair out. Our next speaker is going to offer some amazing inside advice on kind of what the situation was like on the ground. So Faisal Minaj completed his PGY2 emergency medicine pharmacy training at the University of Rochester Medical Center, and that was followed by a toxicology fellowship at the Maryland Poison Center. He's currently an epidemic intelligence service officer at the CDC within the pox virus and rabies branch, and he is going to be speaking to us today on the pandemic response team lessons from Mpox.
Thank you, everyone, and thank you for the organizers for asking me to talk today. Standard federal government disclosures that the views are mine and not of the CDC or HHS or any other federal entity. The objectives of this talk that are all listed there. And let's get started because I have a lot to get through and I want to see how much I can. So I do want to provide some background, as monkeypox virus is a rare disease, and it's not one that we're often used to. It's in the same family of poxviridae and orthopox virus that we have some history with, of course, with variola virus being smallpox, and then vaccinia virus being what's used in the smallpox vaccine, which, again, looking at the age of everyone in this room, I think there's only a few people, probably Frank, that still has a smallpox vaccine scar from birth. But really, looking at monkeypox virus is not something new. It was discovered in 1958 after 2 pox-like disease outbreaks were in research colonies in Denmark. And that was really concerning at the time because this was, again, during the smallpox eradication era. And if there was an animal reservoir for smallpox, eradication realistically probably wouldn't be possible, which is what led to the discovery of monkeypox of a completely different virus. And it was shortly found after that, and through studies that CDC and others have done, that really the animal reservoir of monkeypox virus is unknown. It's likely to be small mammal species similar to other orthopox viruses, but truly it's unknown what is a carrier of this. And then importantly, for the remainder of this talk, I'm going to be using the term Mpox because in late November, we did try, the WHO has used that as the preferred form for the disease, and I will be using that from here on out. So talking about first historical data and what we had to go off of. And this is data from endemic countries, mainly Zaire, Democratic Republic of Congo, and also from Nigeria and some West African countries. And we knew that the incubation duration was really this 3 to 17 day tight window, and the illness was usually around 2 to 4 weeks. And historically, we knew that the development of the initial symptoms and would really mark the beginning of that infectious prodromal period. And most patients experience this prodrome with high fevers, malaise, generally feeling unwell, and profound lymphadenopathy. And the lymphadenopathy was important because, again, during the smallpox eradication era, because smallpox doesn't have lymphadenopathy, this was a great diagnostic criteria to differentiate the 2 diseases at the time, and it still is a key feature of Mpox today. And of course, this all precedes that characteristic rash that had appeared shortly after the prodrome. And I'm going to have a lot of rash pictures here, and I love that I'm right before and keeping you guys from lunch, so you get to see wonderful pictures before that. But lesions really, they develop anywhere, but most often they were on the face and on the extremities, including the palms and soles. And you'd usually have a cluster of lesions in one area that began simultaneously together and went through this evolution, starting maculopapular, going to more vesicular pustular, and then you'd have scabbing resolution over the next week or two. And it's important to recognize that pox lesions are really characteristic, which is why I'm going to go through a bunch of pictures of them. They're really well circumscribed, deep-seated. They often have that central umbilication, and they're often painful when they occur, and then they start to be pruritic once you have the healing phase. So here's some rashes that we had from endemic countries. You can see on the right side are strains of clade 1 Mpox, or Congo Basin previously referred to, and you can see those vesicular lesions on the lower image, and then also in later stages on the upper image, and you can see some lesions still coalescing together. And on the left side of the screen, you can see that you have lesions from the 2003 outbreak of clade 2 Mpox that was secondary to small mammals importation from West Africa. But importantly, these lesions are very firm and they're really deep. If you, well, not that you would, but if you ever touch one of these lesions with appropriate PPE, you'd see that they're very firm lesions. They're not superficial, which can help differentiate, because one of the biggest differentiators of Mpox in endemic countries is varicella. Besides that, we already knew that there were some complications with Mpox, and especially with severe lesions. We know that mucosal lesions themselves can appear as painful ulcers and result in the inability to eat, urinate, or defecate due to the pain or development of strictures. There's also can be myonecrosis or secondary infections if the ulcers penetrate deep tissue. And these skin lesions can become confluent or necrotic and require specialized wound care and transfer to burn units that are more equipped to handle these types of wounds. And there have been other complications such as neurologic myopericarditis, obstructions, and then sepsis and hemorrhage, which are really associated with the high mortality of Mpox when we look at historical data. So then let's transition over to what happened almost exactly 365 days ago last year. So initially, we were closely monitoring our situation in early May because there was 3 unlinked clusters of cases, one being a traveler, which is not out of the ordinary from Nigeria, the other being a couple household members but had no epi links, and then the last one being this STI clinic with 4 cases of men who have sex with men with no link to Nigeria. And then, of course, on May 17th, I'm here getting a phone call from the Massachusetts Department of Health. And, you know, when you answer the phone, you're like, oh, crap. And that's essentially what I was doing at this point. I was like, yep, this is very consistent. This is something we need to test. And we confirmed on that day our first case of Mpox in 2022 in the US for this outbreak. And as we started to hear more and more about these cases, often coming to my cell phone, so that was going off like no other for the first couple weeks, we knew that we had to change our response efforts, and we knew that this was going to be much bigger than we initially thought. So CDC has this graduated response framework, which is this tiered level to manage public health emergency responses. And this figure kind of shows the levels of organization within the CDC's structure. So the poxvirus and rabies branch where I am is in that tiny red triangle in the corner, and we quickly outstripped our resources and supplies and personnel to respond to a response of this nature. And we had to move up to a center-led and very quickly to an agency-wide response to pool our resources and therefore move between these phases as we go to expanding a response for the environmental and operational needs. And when starting this response effort, we had some main priorities set out: to enhance our surveillance, expand laboratory testing, use of medical countermeasures for post-exposure prophylaxis and treatment, and disseminate this information as it is a relatively unknown disease at that time. So a crucial point of any emergency response effort is to knowing how many cases are out there. And a key priority identified immediately during the initial phase of the response was the need to enhance case detection. As is with most rare and neglected diseases, there seldom exists any type of reporting structure or surveillance system, and it's not equipped to handle large case volumes. So going back to these first few days that we were, all of us working, 18-hour days trying to figure out what was going on and build our capacity, we knew that we needed to work with our informatics team to create a robust surveillance system that is able to detect all of these cases. And this was a REDCap and Decipher-based system which is continued to use today, and we keep adapting based on state and key stakeholder input. I also want to add in the National Notifiable Disease Surveillance System, or NNDSS. So this is the system that CDC uses in general to monitor diseases across the US. Importantly, diseases that become nationally notifiable generally become reportable within states so you can get accurate counts. So a part of this early effort was to ensure that Mpox became a nationally notifiable disease, so then that would streamline reporting throughout this process. On to expanding laboratory testing. Now, from smallpox preparedness efforts, we had multiple tests already within the laboratory response network that were ready to test for Mpox and other orthopox viruses. So on day one, we already had 69 laboratories spread across the nation that had the capacity to test 6,000 samples per week when the outbreak began. However, we knew that this was not, and the public health infrastructure really needed to adapt, and they weren't going to be the sole testing source for any type of outbreak. Although it's great for that initial detection, as cases started to expand, we knew that this had to be scaled up. And it was scaled up to run on a higher throughput platform, so that way labs could test more samples at a time. And CDC began to work with commercial labs early on so they could become online and be the brunt of our testing workforce. And then using medical countermeasures for post-exposure prophylaxis and treatment. So the US government stockpiles a number of medical countermeasures from various diseases. Specifically to variola virus or smallpox, the Strategic National Stockpile contains both therapeutics and vaccines. And on June 28th, the National Vaccine Strategy was released. This was shortly followed on August 9th with an emergency use authorization for intradermal administration of Jynneos vaccine. This expanded the limited number of doses that we had to cover the great population that we needed to. And throughout this time point, it's important to understand that CDC already held investigational new drug protocols for tecovirimat, vaccinia immune globulin intravenous that really helped to use them on day one for other types of orthopox virus infections, including Mpox. And throughout the response, the number of forms and the process for this had decreased to, again, facilitate use of these agents where needed. And lastly, the other key priority that we had was to disseminate information. So as orthopox virus infections are generally rare in the US, we needed to disseminate this to health departments, providers, and the public. So the first health alert network notification was released 3 days after our initial case detection, followed by a clinician call 1 week after the first confirmed case, and an MWR publication that detailed the first 9 states that was within 2 weeks of initial case detection. And CDC continues to message via various platforms, including social media, to reach the appropriate populations at risk. So what was different about this outbreak than what was previously known from outbreaks in endemic countries? And during this one, something that we saw were lesions were much smaller, and the characteristic rash often presents and starts in mucosal areas such as the genital, perianal, and oral areas. Skin lesions tended to be more scattered, or they could be localized to a specific body area. And over the next few slides, I do want to highlight some of the rash presentations since it's very important as far as the diagnostic criteria for Mpox. So importantly, in contrast to some of the earlier images that we saw, you can see that many of these lesions are much smaller. They're not as clustered, and they can spread out diffusely. However, you can notice that even though they're smaller lesions, they still have that well-circumscribed area, generally have that central umbilication that's characteristic of a pox lesion. Image G on the right is a patient that had deep verrucous lesions that were then debrided over time. And then moving on to some others, these were images from the UK Health Securities Agency, again highlighting the small lesions as well, but also some of the other atypical findings, such as the necrotic lesion seen in image G on the right. And then when we move to genital lesions, you can clearly see why it was commonly confused with various STIs at the time, often with syphilis or HSV. But in these lesions, you can still see that you still have some central umbilication, you still have well-defined borders, and those that are still characteristic of Mpox. Even when looking at perianal lesions as well, although it's harder to visualize, you can still see that structure is still there for Mpox. So moving on to treatment and interim clinical considerations. Starting with this, we knew we had a bunch of medical countermeasures available, although we didn't know how and where to best use them. So looking at Mpox prognostic indicators, and it really depends on a few different variables. One of the biggest being previous Mpox or smallpox vaccination status, immune status including HIV status and CD4 counts and viral load, along with other concurrent illnesses and comorbidities. Importantly, Mpox is generally a mild infection and self-limiting without specific antiviral therapy, and the vast majority of patients will recover without any antiviral therapy needed. That doesn't mean that we don't give them anything. These lesions are very painful, and we should employ good pain management and good skin care recommendations and wound care, because that's an important part of the treatment plan for recovery. Now, what we're most concerned about in these patients are those at risk for severe Mpox. Now, these are patients that are developing very large lesions throughout the body, having persistent infection for months on end, and are often occurring in those with inadequately treated HIV, often with CD4 counts under 350, or other immunosuppressive conditions. And for these, we really recommend consultation with CDC and our clinical escalations team to initiate appropriate treatment early on. About a month and a half ago, we released our treatment algorithm. And I know this chart's really hard to read. It's not meant for you to read right now. There's a publication out which details it. But it really highlights the treatment pathway for those at risk for severe disease and at high and with severe disease. And you'll notice where it starts out on this is important because it's identifying those at highest risk with immunocompromising conditions and HIV. And really, the goal initially is to optimize immune function in these patients. Orthopox viruses generally are not able to be cleared without a functional immune system. We know that from smallpox data. We know that now from Mpox data as well. So for immunocompromised patients, we need to do everything that we can to facilitate a native immunity. And that means for these patients with HIV to receive effective antiretroviral therapy to bring up CD4 counts so they can mount an effective immune response, and to limit the use of immunocompromising therapies like chemotherapy or corticosteroids. Doing this really may decrease the duration of Mpox therapies needed and minimize the morbidity and mortality that we've seen. So moving on now to the specific antivirals that we have. So it's important to remember the orthopox virus life cycle, which I'm sure not many people in this room are familiar with, as it's a very niche disease. But upon entry and after fusion, the orthopox virus releases its DNA, which is then replicated and then forms virus, which is then exocytosed and released for cell-to-cell transmission. So the different agents work on different mechanisms. Both cidofovir and brincidofovir work to inhibit DNA replication, versus tecovirimat works on VP37, which is a viral egress protein. Importantly, this just prevents extracellular envelope virus from escaping and terminating cell-to-cell transmission. Neither of these agents are virucidal, and it's important that because of tecovirimat's mechanism, if a cell lyses, there's still immature virions which can infect other cells nearby. Again, highlighting the need of why a competent immune system is needed to fully clear this virus. So talking about tecovirimat, you might also see it as TPOXX or ST246, but it's approved in adults and children down to 3 kilograms, and it can be used for non-virulent orthopox viruses such as Mpox under a CDC-held EAIND. And as far as treatment efficacy for tecovirimat, there are a bunch of animal studies that do suggest a mortality benefit, especially if started early in treatment. However, the controlled human data is really lacking. Human case reports suggest that there may be reduced illness duration and maybe reduced viral shedding, but this is hard to compare as it is just observational. And then the use of it as post-exposure prophylaxis is really unstudied. So looking at patients who we want to use tecovirimat in, and these are predominantly going to be those that either have severe disease, and that can either be hemorrhagic, confluent lesions, sepsis, encephalitis, or those at risk for severe disease, being those severely immunocompromised, breastfeeding, pregnant, pediatric patients less than 1 year, or having a skin condition that affects skin integrity, like eczema. The other thing that we're concerned about too is those with lesions in areas that are highly concerning. We know that lesions in the eye can lead to blindness, so any lesions near or within the eye are of high concern and should be treated, along with those in the genitals and the anus. Along with those, other criteria for those receiving tecovirimat should be that they could have one of the other complications associated with Mpox. As far as the availability of tecovirimat, it's important that the oral capsules really need to be taken with a full fatty meal. There's been documented cases of inadequate tecovirimat levels in patients who are unable to take a fatty meal with this. Breast milk does count for this as well, and the capsules can be opened to be mixed with food for pediatric patients. Importantly, I do encourage every single institution to try and enroll patients through the STOMP trial, because we're at a point now and where we were at the beginning of this outbreak where we still don't have good randomized data to know whether or not tecovirimat is an appropriate therapy for patients. We don't know and have comparative data whether or not this provides a benefit compared to placebo. And although a lot of the forms and things were operationalized quickly to get tecovirimat to people with CDC's EAINDs, it's important to enroll in an actual clinical trial to figure out whether or not the treatments that we're giving are actually providing any benefit. Outside of that, CDC will continue to support oral and tecovirimat formulations available through the Strategic National Stockpile. However, I do take my little soapbox here of it'd be great to have human data. So if your site isn't a STOMP site, I do encourage you to try and get your site to be a STOMP site. In terms of safety and side effects, tecovirimat is actually very well tolerated, and we haven't seen any severe adverse events associated with it. It's important that because of excipients in the IV formulation, it is contraindicated in those with creatinine clearance less than 30. Looking at our other two agents that are kind of our second-line therapies of cidofovir or brincidofovir. Cidofovir is an agent that, some of us who are familiar with it or used it, it's not ideal with the renal toxicity associated with it, the probenecid and the drug interactions associated with that we have to give, although it is commercially available and has demonstrated in vivo efficacy against orthopox viruses. Brincidofovir was formulated to kind of resolve a lot of the renal toxicity, provide an oral option for patients, and can be used in children and adults and is approved for treatment of smallpox. It's available through the SNS, again, through an FDA authorization for single patient use. There's really unknown efficacy in human data for either of these agents, and brincidofovir does not have the renal toxicity, but it does have hepatotoxicity associated with it. And as mentioned earlier, one of the points that I like to stick on as well is ocular Mpox. It can be very severe and be a sight-threatening illness. So usually we want to encourage ophthalmology referral early on in the course. We don't know what dose of tecovirimat is needed to achieve therapeutic ocular concentrations. But based on what we know from other data, we want to avoid topical steroids. We still want to start tecovirimat. And based on a rabbit model, we know that trifluridine really tends to help with other orthopox virus keratitis, and which is what we usually recommend for any ocular Mpox treatment. It's preferred in this instance, and although we need to caution use beyond the recommended duration of 3 to 4 weeks because of corneal epithelial toxicity that can occur. And the last agent that we have here is Vaccinia immune globulin intravenous, which is our FDA approved for treatment of vaccinia vaccination, or ACAM 2000 dry vax complications, such as eczema vaccinatum or progressive vaccinia or severe generalized vaccinia. So these, again, through a CDC-held EAIND, we are able to use for treatment of these patients, and we generally tend to reserve use in patients that are severely immunocompromised. Orthopox virus antibodies generally react across the genus, so it may provide some benefit, especially if someone is unable to mount an immune response. However, efficacy for pre-exposure, for post-exposure prophylaxis, or even treatment is really unknown here. And that really gets on to prevention on what we have for Mpox, especially as we start seeing cases starting to increase again, and we're going into Pride Month where we know we have a lot more activity that's occurring that has high risk for Mpox transmission. So vaccination is a key aspect of any response for vaccine preventable diseases. I do want to highlight some of the differences here between the old live replication competent vaccinia virus vaccines versus Jynneos vaccine currently. Because it's replication deficient, it is much safer than the previous vaccine. You're not actually infecting someone with a virus. There's no take after vaccination that you typically see. The serious adverse events are very minimal. And the myocarditis and pericarditis that was seen often with ACAM 2000 really hasn't been reported sufficiently with Jynneos from our passive monitoring services that we have through VAERS and vSafe. As far as effectiveness, Jynneos seems to have a similar immunologic response to ACAM 2000 after a 2-dose series that's administered 28 days apart. I think a lot of that information I said is also on this slide in a different form, but importantly, it can be used intradermally for those that are adults and greater than 18 years of age, or sub-Q for children less than 18 years of age. And similar vaccines to MVA have been used down to 4 months, and so has Jynneos during this outbreak. Importantly, looking at vaccine effectiveness of Jynneos, it measures the proportionate reduction in medically attended Mpox cases amongst vaccinated persons. And this is the most recent data, which I think is going to be published formally this Thursday. And it really puts that VE estimate right around 69%, and partial vaccination VE right about half of that, really highlighting the importance of getting that second dose to complete the series, which is one thing that we've been struggling with, of getting people their second doses. So in summary, Mpox is generally a self-limiting illness, and cases have declined since their peak last summer. However, there is still concern for possible reintroduction. This week, we recently just released another Health Alert Network notification because of cases detected in Chicago. And we do have medical countermeasures available, such as vaccines and treatments, such as tecovirimat. And we also published interim clinical considerations for the treatment of severe Mpox, which really highlights optimal use of these medical countermeasures. And then lastly, public health responses to emerging outbreaks are very complex. There's a lot of aspects that require different resources and coordination with various state, local, and federal partners. Lastly, I do want to say again that, for any clinical consultations on severe cases, as that's what we're hearing a lot of, please contact the Emergency Operations Center at CDC or our poxvirus email. With that, I have my couple of assessment questions. So what is true about Mpox? There's a prolonged viremia, which can cause blood to be infectious until it is cleared. B, the rash is typically superficial, resolving within about a week. Mpox is rarely fatal, but severe outcomes can occur in immunocompromised persons. And then monkeypox virus often infects only the skin without systemic symptoms. So who in the audience is going for A? And B? And C? Yeah, so it's going to be C here. So it is rarely fatal, but severe outcomes have occurred in generally immunocompromised persons. That's also where we've seen all of our deaths as well. And last assessment question is, which part of the following is not part of CDC's response priorities? Research on available therapeutics, enhancing surveillance, disseminating information, and expand laboratory testing. So how many people are going to do A, and B, C, and D? So this one is actually A. Although we do a lot of research, that is not one of the priorities. We are still a public health organization focused on surveillance activities. So our 4 main activities were public health surveillance, laboratory testing, and disseminating information and getting information out about medical countermeasures and treatments. We still are performing a lot of research related to this. We still get a lot of DoD funding to do that research. And we want to ensure that we have that information available should future outbreaks occur, to be prepared for those as well. And then lastly, which of the following is a first-line agent for the treatment of Mpox? Is it A, brincidofovir, B, cidofovir, C, tecovirimat, and then D, VIGIV? And yeah, it's going to be C-tecovirimat. It's our safest and really our first line agent for treatment of severe disease. With that, I can take any questions that you guys have.
Hi, thank you for the interesting talk. When the slide where you're comparing the two different vaccines, you were talking about whether or not the vaccine takes. What does that mean?
So previously with live vaccinia virus, replicating competent vaccinia virus vaccines, you'd have administration was done by a bifurcated needle via 15 to 20 different punctures, usually on the upper arm. With that, you'd actually have scar formation and you have like vaccinia virus lesion that would appear. And that was referred to as the take. So with Jynneos vaccine, because it's not live, it's not replication competent, it's administered subcutaneously, you don't really have that take and that scar that appears. Mm-hmm. Okay. Thank you.
The CE code for this session is 7L, M as in Mary, 7LM. So at this point, lunch is going to be available over yonder in this room. That's a Texas term I learned. And we also have put together some great panels for you that we're going to do some lunch and roundtables informally in this room right here. So the first panel is going to be discussing strategies for research in emergency medicine, and then we also have a discussion on how to improve PGY2 residencies for our learners. So we're going to do a 5-minute break. Feel free to join the roundtables. If not, grab some food, and then we'll resume with our main didactics starting at 1 p.m. Central Time. Thank you.
All right, can everyone hear me? Hi, everyone. Yes, we should be, so this should be on the Zoom. Hopefully everyone can hear us on the Zoom. We're trying to moderate the Zoom and the group me chat and also the audience questions. So the idea with this is just a formal, informal discussion of research. Anything that you want to ask us, we'll take questions from the group chats, we'll take questions in the audience, and hopefully spur some conversation. And then we also have a list of questions to ask each other. If no one feels like talking, if you all just want to eat right now, that's fine too. So we hope that this can be kind of, you know, a fun way to talk about new ideas in research, and then also as it pertains to residency training. We'll start it off with the research discussion. I'm Megan Reck. I do a little bit of research in EM, so hopefully I have something to lend to the conversation. I'll let everybody.
I'm Caitlin Brown, EM pharmacist at Mayo Clinic. Also do, if Megan says a little bit of research, I do a very little bit of research in emergency medicine.
My name is Mark McDowell. I'm at Christ Medical Center on the south side of Chicago, and if any learners are out there ever considering, you feel like a lot of imposter syndrome, just realize there could be a day you sit next to Megan Reck and Caitlin Brown on a panel about research. That feeling does not go away.
Great, so we'll open it up. If anyone in the room has any questions, feel free to step up to the mic or raise your hand or come up. If not, we will get it started. I guess I'll start by posing the first question to the two of you. How can high-yield research topics in EM be effectively identified? It's always a problem, right? Like when we're trying to come up with resident questions, resident research that's attainable. What's your process for trying to identify high-yield questions?
So I'd say, as you heard my introduction earlier, I also work in our neuro ICU, so I'm biased that, in my opinion, high yield questions are neuro related. But I think what I'm trying to get at with that answer is what we're seeing in clinical practice and what we need to answer. So for example, our resident Kyle is in the room. We are looking at a reversal of GI bleed, warfarin-associated GI bleeds, and if we can just give vitamin K, if we need to give PCC or nothing, and how can we stratify patients in those different categories of what they need. And that study question just came because I didn't know what to do when I saw a GI bleed. So I think the highest yield is what you're seeing and what you need to answer in your clinical practice.
That's really well said, and I'm glad you felt comfortable kind of sharing some of your ongoing research too. I think that might be high yield for us to kind of comment on too. And I think, we're all ER people for the most part here, right? We're pragmatic people, and I think that's really where the high yield things come from in my view, right? It's the things that, certain providers do that may spite you and really upset you. I think that's very right for resident research projects, and that's legitimately practice changing, right? If you can come and bring data from your own shop to those providers, that's gonna be a big win, and I can guarantee you other people throughout the country, even the world, are also having those providers who are, still stuck in their ways on some things. So I think that's really, really low-hanging fruit for high yield projects. And then two, just realizing we all work almost in small vacuums across the country, and Twitter's really done a great job of kind of highlighting our uniform things that we do together. But I work at a place called Christ, and we call them Christisms, right? We know that everyone's going to get a liter of fluid ordered for whatever reason the second they walk into triage. That's not the right thing to do, right? And if we can kind of focus on those little minute, strange things that your institutions do, I think those are, again, highlight really low-hanging fruit, especially for resident projects too.
You want to add, Megan?
No, this is always a tough thing. Like, how do we know that our projects are worthy of pursuit? And I think that you guys hit a lot of the high points with that. Like, is there something that you're coming across frequently where you're like, I know this is not the right way to do something, or we butt heads a lot? I think, I just keep a tally on my phone. Like, when I work a shift, I come across something that like irritates me or that I want to dive into, I just write it down, and that accumulates, and then you talk about it. I think talking with colleagues in this type of setting is one of the best ways to brainstorm research projects. Like, is there a way we could do it differently? I think going to conferences like this really stimulates a lot of interesting topics and highlights the holes in the literature. So that's another way, I think.
The next question, what strategies can be employed to leverage the skills and knowledge of pharmacy residents and students in research projects?
Megan, I'll let you kind of touch on the army you've developed of student researchers, but I think that's something, I'm lucky that, Megan and I practice in the Chicagoland region, and, for better or worse, there's 7 colleges just within the Illinois region itself, and these students who are hungry for actual clinical research experience, interested in pursuing more advanced achievements after they graduate from school, it's a huge opportunity you can have. And I'm no longer faculty, and I'm not associated with the college, but we can still offer those obvious opportunities for these students to kind of come down on their time off, get them registered as student volunteers, get them some hands-on time, mining that data, if it's a project for yourself or for your resident. I think there's a huge opportunity in those students.
Yeah, so as Mark mentioned, I have an army of students working on research right now. My last count was about 60 students that are doing research. So I'm research director for our Department of EM at Loyola, and with that comes the responsibility of coordinating research for all the attendings, residents, and then just a boatload of medical students that are interested. And so I picked up a few tips and refined my way for doing that so that I don't drive myself crazy with all the emails. It still drives me crazy with all the emails, don't get me wrong, but to make it more efficient, I think I only start projects one time of year. I started in the summer when the students are ready to get to spend their summer on work and get invested. I try to have a student leader that stays on from the year before, and then have new people come on as data collectors, and have that student really take on the burden of orienting the newbies to data collection. Because every student wants it for their CV, and then they get busy as soon as they get into rotations, and then it kind of falls off. And so we're constantly rotating learners that are participating in research. I also don't rely on students for anything because, you know, they love to commit, and then they, particularly for the medical students, some of the pharmacy students, they just get really busy and overwhelmed, and then, you know, so if I have a deadline to meet, I generally try to do it myself. One thing I can attest to that I found really helpful for pharmacy student rotations is I only take elective rotations in the ED, so I don't do any like advanced medicine, or what is it called, internal medicine rotations. They were sending me those students for a while. I don't do that anymore. Everything is elective, and I make them all spend 1 week off service collecting data for me. And if it's pre-mid-year, then I let them do a poster for mid-year so they get something out of it too, gets them research experience on their CV. So it's mutually beneficial. But if I have something where I like need a project knocked out for data collection, they're so efficient if they can just get in an office and collect data 40 hours in 1 week. So I do that for every single student rotation. And if you take a couple learners a year, it's a really effective way to maximize your time.
I'll add some stuff because Mayo Clinic, we don't have a school of pharmacy, so our logistics are a little bit different. We have students come from a number of Midwest schools, but they're only there for a block, so admittedly have not tapped into using them for research. May or may not work at your institution, but what we do have implemented last year, maybe the year before, is our summer interns. They do 1 day a week that they're like on rotation, but their internship is all projects. So our staff can submit projects, and then those projects are selected based on like a grading process, and then the intern works on that process. So it's similar to the week Megan's talking about. So their whole Tuesday through Friday is working on that project with you for 3 months. So they're actually going to get the data collection done. They don't have competing interests then. So we've used pharmacy interns in the summer that way. And we do have a medical school, so we've tapped into a lot using medical students or pre-med students for our research, and also done it mostly in the summer, so applied for like some internal grants where we're paying them, so they're like $4,000 or something a month, and their whole time is spent doing data collection. So you mitigate that competing interest, they're not meeting deadlines, all of their time is spent doing data collection and learning the research process.
Great, we have some questions in the room. Please introduce yourself and let us know what you want to talk about.
Hey, my name's Sarah, and I'm a current resident. I guess one of my questions is, as a resident, most of my experience with research has been very, single-centered, pretty like small scale, kind of moving into, first big girl job. How would you say, do you have any like recommendations on getting involved in like larger scale projects, like multi-center projects, those sorts of things?
I have a couple. So we have actually formed a EM PharmNet, Emergency Medicine Pharmacotherapy Research Network, and we welcome anyone who wants to join. Our vision is really just to conduct multi-centered, high-yield research. It's a great way where if you're not comfortable with leading your own project yet, you can just get involved as a site, contribute your data, and then we try to mentor those that are stepping up and taking the role of PI for a project. So there's a lot of resources provided with that. It's all voluntary. Everyone is, very few pharmacists in it, I would say, have like buy down specifically for research. It's just the common goal of doing high quality research. So you can do that. There's also like the ACCP EMED PRN has a research committee I would encourage you to join. We try to tackle like one new project every year that you can get involved with. We've been pretty productive in the last couple of years and had a number of projects. One of them I'm presenting as a poster here. And so there's been a number of projects go through in various forms. We've done systematic review and meta-analysis, multi-center data collection projects, just wrote a paper on like non-antidote stocking for mass casualty stuff. So you can propose an idea, you can join, it's kind of similar format. So there's a number of ways that you can get involved. There's also ways in other organizations like SAEM that are kind of EM adjacent.
I think beyond that, the only thing I add would be like networking here and at SCCM and other conversations. Like I met Megan through networking, and now we do research together along with other people in the room. So I think it's just making connections here. You hear a talk, it's something you're interested in, talk to that person afterwards, and that'll build your network as well.
Yeah, really nothing to add. I don't know, Ryan, if you want to ask your question.
Oh, Yeah. So I just have two potential questions. One, an army of 60 students is very impressive. I am running into some hiccups when submitting research that's been primarily collected by students or maybe multiple students, where the larger, or at least the more, I don't know, rigorous journals are asking me for what my kappa was in my data collection, and I would love to say that I always remember to do it every time. Are you doing assessment of accuracy of data collection of the students every single time before they kind of get going into the project? Okay, I just wanted, because I think a lot of us use students, a lot of people just say, get going, but you really should double check to make sure that they are accurately doing it, especially because you might need to report that in the actual publication.
Do we need to repeat the question? Okay. Yeah, just to summarize really quick, is you addressed the kappa issue, which is, I think, becoming ever more apparent in all the editorial reviews we get back now. And two, kind of how you structure our student logistics in terms of, are you having two people collect data? Are you having them fact check each other? And I don't have anything to the scope of Megan's Legion, but I will have my first year students collect the same exact data together, and they'll have like almost a tiered model above that, where our third year, or even like the PGY1, will go back in and spot check those things afterwards as well.
Yeah, we're doing the same thing and ensuring, because of feedback and reviews, like what was our training process, or like what did we use to train the data abstractors? So like having a more formalized way of doing that as well.
I don't have much to add to that. I definitely, so in using the layered model, whoever the senior student is, or maybe it's a resident, like a resident project, and they're utilizing student learners, I have them QI the first like 5 cases and make sure that that everything looks appropriate. And then we try to do like 10% of cases, just going through, spot checking, making sure that we agree with things. So yeah, I mean, if you're gonna leverage an army, you have to make sure that it's not garbage that they're putting into your database. Another thing I would advocate for is really optimizing your data collection tool, like making it kind of idiot-proof, if you will, to make sure that there's no ambiguity in your responses, that there's no like free text if you can help it, where you're getting a bunch of garbage put in there, and that you're able to really eliminate any inefficiencies and streamline everything. So I spent a lot of time up front doing REDCap. Like I make every learner test at least 5 cases in REDCap before we make it go live, to make sure that it is collecting what it's supposed to. So I think that helps as well.
A follow-up question unrelated to the first. I think you've all done some form of prospective research. This is really the barrier that I think we're all great at, going through charts and doing systematic whatevers. How do you implement a prospective, especially evaluating different drugs? Do you always have grant funding for it? Do you ever do it without grant funding? If you don't have grant funding, who pays for the drugs? Who consents the patients? Is it you? Do you have a research team? Please answer all those questions. Thank you.
The first answer is it takes blood, sweat, and tears to do a randomized control trial. So I've done one. I'm on my second randomized control trial that's placebo-controlled. And as the pharmacist on the team that's making the intervention, I cannot be the one consenting the patient. So that's the first thing. So you need a team of people in place. You have to have people that are going to be in the department. And so the way that we've accomplished this over the last couple of years is we have a summer research program for our M1s going into M2 medical school. And so we make it projects that are multi-year. It usually takes us like 2 years to complete an RCT. And we have the students set up a schedule so that they're in the department and they can do the consents. We also have a number of faculty, like 4 or 5 faculty that are really research heavy and can be there for the consents as well. And then once we get consent from the patient, then I set it up so that randomization is blinded, nobody else can see that, and then I make the drug. The 2 trials that we've done have been on our own dime. They're really not that expensive because they're both with ketamine, and ketamine's cheap. I think it costs $250 for a pack of 20 vials of ketamine or something like that. So we've got ketamine for days. It's really the time that's the most intense process. So it's definitely doable. I think, Mark and Caitlin can also attest. Mark's got some really interesting setup where you're doing prospective research with your pharmacist, if you want to try to elucidate.
Yeah, so what's interesting is we pre-pack our actual study drugs. So I'm the one who's mainly doing the consenting, myself and my team, and we're blinded to the actual intervention to it, and our operations manager, whoever compounds it in the clean room, is the person who's unblinded to it. So that gives us a little bit of ladderability and flexibility that we have 24/7 pharmacy coverage in the ED at my shop. So we're enrolling and capturing a lot of these patients, which makes my enrollment time decrease from 2 years to, in our ongoing trial, probably closer to 3 months, which makes it very easy to kind of churn out some of these more pragmatic, smaller intervention studies. So our first one, we accomplished in about 3 months, and then we have 2 ongoing RCTs that are double-blinded that probably be wrapping up by the end of the summer. So I think, one, we're just leveraging that we have so many pharmacists and know we're very lucky. 2, we don't have any ketamine, so I think Megan probably took it all. And then 3, you had touched on the cost of the drug, right, which is really, really important. And I think it kind of plays into something else I was going to say for another one of our future questions. But I'm fortunate in that the lizard brain that I have, the drugs I'm using are very cheap. And our department has agreed to pay for those. But you're going to run into the point where you're going to be looking for open access fees, or you're potentially going to have to pay a statistician depending on what you guys have financially available with your institution. And that's where I would kind of leverage your multidisciplinary groups. So your nurses and your physicians, they most likely have a med fund or a med exec fund that they pay dues into that pay for things just like that, right? So if you put a physician, APP, or a nurse on your project and get them involved in whatever degree you think is necessary, that opens up a ton of funding to you guys. And that's really how we've been able to pay for our statistician in the past, really how we've been able to pay for, going to some of these conferences, paying for some of these drugs, and actually paying these open access fees. So that's a huge untapped thing that I don't see a ton of in like pharmacy-centric research, where we're incorporating, as like 4th or 5th authors, nurses or statisticians or even like our APPs. So just always remember that those guys, they might have some other streams of revenue that, the pharmacy department might not have access to.
You guys have a favorite?
Brad's coming back.
One quick follow-up for Dr. Brown. How do I get that drug money? How do you go about? Well, no, but I mean, when you guys are considering these prospective trials, do you ever consider reaching out to a drug company to see if they can? I know some drug companies will sponsor trials. I don't know if you guys. I'm curious, honestly, how you guys.
Yeah. So most drug companies have what's known as like investigator-initiated studies, and they have portals like doing something with Briviac now to look at, and you basically write up your proposal, submit it to them, different platforms for different drugs. And I'll say like your contact wouldn't be like an MSL, it's like the outcomes research. So submitting the proposal through them and then potentially meeting with them and then having the conversation of how much money do I need, et cetera. I'm making it sound easier said than done, but really you can create a proposal and submit it on that, which is what we've done for our Indexa stuff, we're doing for Briviac, et cetera.
If I can just add, so we've done a couple of those through EM PharmNet, our research network, and we have been successful, I'd say 50% of the time, so not impossible. You're gonna need to start with like a high number and then it'll probably get negotiated down, but it's really not a big lift in terms of the proposal. You start with really like a one-pager specific aims, like NIH style proposal, and then submit it. Usually I've contacted the MSL that I know from the company, and they put you in contact with whoever you need to from their research side of things. But it's not as strenuous as you might think. The thing that you do need is an institution that is really good at handling grant funding. We've been really fortunate that my colleague Brett Faney at Iowa, his hospital is awesome with like handling all the contracts and grants. Mine at Loyola is not so awesome, so that may be a limitation if you're coming from like a community hospital or some other setting where you're not as set up for research.
You can, to like that point, like the Briviac study, for example, like we have a great infrastructure, people at Mayo help me get all the money. I don't have to do much. I'm very fortunate. But if you're at a center that doesn't, you can collaborate, like Megan's saying, and then like I can get the money at Mayo and their co-investigators and then send it to their institution so they can get money too.
I have a funny anecdote to share about that. So what's remarkable is the hard work you're going to do is creating the IRB, right? And you already have a resident doing that for you, hopefully. Essentially, you can just tailor edit that to your IIR, and that's really what you're going to be submitting in short form to most of these companies. And these guys have money, right? Like, they're willing to throw around a lot of money if they think there's actual good benefit they can see out of it, which obviously when you guys come up with good ideas is most likely. But a funny thing is, I didn't realize that I should probably contact my contracting department before I was asking for these millions of dollars from this company. The company was more than happy to give it to me, gave them my contracting person, but never really spoke with them. And they saw that, okay, they're going to offer us X million in drug and money. And they're like, okay, can you ask for X million times two in cash? I was like, that's the weirdest thank you I've ever gotten at my job. So then I have to go grovel back to that company and be like, hey, you know, the corporate really wants us to increase our funding aspect of this by another couple million. And they kind of laugh at your face, right? And you kind of maybe sabotage that relationship a little bit. So really reaching out to your contracting department and seeing what their needs are and what their interests are, because, you know, they have to get paid too. So that should be something you factor into like your budget analysis, paying for our corporate overlords.
For the Zoom.
Blake Porter, University of Vermont. So I have kind of two questions, I guess. The first, it sounds like you guys utilize your resources around you really well, residents, students, and obviously you have some resources I think some of us may not have as good access to. From the nitty gritty side of things, like you're more consenting on the job, how does that affect that clinical time? So like you're covering the ER, do you have a department that supports that sort of thing? And I think the second part to follow up on that is, how have you guys been successful in getting, if you do have it, buy down time? Like what strategies did you use?
I can answer the first part of that. So just kind of how I incorporate consenting into my workflow process. Kind of going back to the first answer I gave at the start of this was, I'm identifying research topics that, one, really interest me, and two, that are taking a component of my time already. So it's a patient I'm normally going to be seeing anyways at the bedside, and so spending that extra, few minutes to kind of explain the trial, explain what a consenting is, and really kind of offering the benefits of it, I found that very easy to work into my workflow. Obviously, it's chaotic. I'm sure there's a few patients here and there that I probably could have enrolled that I missed, or I didn't do as good of a job as I could have consenting those patients in terms of losing them to the actual enrollment process. But I'm just fortunate I'm not looking at, my Tylenol dosing and triage. I'm trying to find some higher yield stuff to look at. So, but I can't speak to the other portion.
I totally forgot what the question was. Buy down time. There we go. I was mentally preparing a checklist of what we need to do next. Thank you. You can tell how scatterbrained I am with all these minions running around collecting data. So in terms of buy down time, yeah, I have 40% buy down as research director, and I think I was kind of in the right place at the right time. We don't have a lot of faculty in my department, and we were starting an EM residency program at the same time where we really needed someone to take on like the research curriculum for the EM residents and help with just our faculty achieving promotion and tenure. And so I was able to negotiate 20% initially because I was doing the work. So basically, for 5 years, I just did the work. I brought home everything. A lot of it was on my own time. And then I took it to my chair and said, hey, look, I have this many publications in X number of years, and it's becoming unbearable. I need you to buy down some of my time, or I'm going to have to start looking for employment elsewhere. And so that was the initial step of just like saying, hey, we need to work on something here. And so I was able to get 20% initially, and then we had some grant funding come in for HIV testing and treatment and linking to care from the emergency department. And so I took on that role, which really doesn't take a whole lot of my time because I have a moderate amount of data analytic skills, and that's a lot of doing that. And so I was able to leverage the grant to pay for the other 40%. So I know that people that have research directorship jobs, some of them use investigator-initiated funding to fund their entire salary. So like once you get startup, then you kind of bring in more funding and it offsets your salary. And some really successful shops have been able to do that and also hire like program coordinators, like maybe gap year or pre-med people that want a year of research experience, and they do all the consenting and they do all the paperwork and stuff like that. So you really just have to start small, show an interest. I would encourage you to like speak to your chair, speak to the people in your department. If you already have someone that coordinates research, talk to them about how you could get more involved, and just do the work.
I'm going to acknowledge that I am very spoiled with my answer here. So we have created a pharmacy research committee, and within our Mayo pharmacy department, we actually have 2 full FTEs that were approved for research. So our Mayo research committee, we have like a chair. I'm chair of our grants committee, so I get time from those FTEs for that. But within those FTEs, for example, I had 20% time for 2.5 years. Because we use those FTEs to have new investigator awards, which get 0.1 for 1 year, and then a career development award, which gets 0.2 for 2 to 3 years. So I had 0.2 FTE from that career development award. But people before me have put in the work and the structure for us to get those 2 research FTEs to have those new investigator award, career development award, and then the extra time that we have, people submit research projects to our committee, we review them, and they can request project days. So you could submit a project, it's graded on a scale of how competitive it is, and then you can ask for project days from that as well. Now, when my career development award ended, now I've got industry funded, I have intramural grants through Mayo Clinic, and I heavily lean on our emergency department now to help me with grant funding and getting some intramural grants and stuff with their help too.
I was going to ask for more clarification. That's fascinating. That's really unique. So can I ask like how resident research is incorporated into that role? You kind of oversee all of that then?
Yeah, so our Mayo Midwest Research Committee reviews, we have a scientific review committee, a grants committee, and an education committee, and our scientific review committee reviews all resident research projects and provides feedback just like a peer review would. We don't give time to people that are mentoring resident projects. But with that, you can submit for funding to have a statistician, et cetera. Yeah.
Great. All right, next group, I think that's all the time we have. Thank you so much.
Hello. Okay. Oh. So this is the next roundtable. We're talking about enhancing PGY2 emergency medicine residency programs, best practices, and future directions. My name's Megan Musselman. I am the PGY2 residency program director at North Kansas City Hospital.
Hello. I am Brian Gilbert, emergency medicine pharmacist at Wesley Medical Center. I actually am an RPD, but not of the EM program, but critical care program. I'm one of those dumbasses, apparently.
I am Ryan Feldman. I am not a program director or associate director, but I was the first emergency medicine resident in the state of Wisconsin, so I'm gonna put that one on there.
Do it.
And I am deeply, deeply involved in helping with our EM PGY2 program, where we take 2 residents every year at Freighter. There's a couple of core preceptors, and we all do a good job running it.
Ryan took my resident.
Oh, yeah. Yeah, I'm excited about that. Yeah.
Was he critical care?
No, he was going
No,
all the way.
we didn't steal him.
Oh, okay.
He's coming voluntarily.
Yeah, so we'll open it up to the floor like this. If not, we have kind of staged questions as well, but.
Or we'll just talk.
Or we'll just talk.
Which is dangerous.
What grinds your gears?
I don't think we have time for what grinds my gears. No, what helped you guys drive the decision to have 2 EM PGY2 residents? Like, I feel like we have the workload, we don't have the bandwidth for project management, et cetera, for a second resident.
That's, well, the reason was in two-part. One, we do have some, we self-schedule in the ED, so the group of ED, faculty basically makes sure all the shifts are covered. Having an additional resident does help cover additional shifts. Since, a lot of us are working every other weekend, it's nice to be able to get some of those off by getting some additional resident buy-down. That was not why we did it, but it is a nice perk. But we really are just following the market, and kind of if they continue to be employed afterwards, which we think is good. And so clearly, and when we started, I was the first resident in 2015, and I think at that time I'd have to go back to Chris's graph, but I think there was only like 25 programs or something like that. And now, there weren't that many training opportunities. So it was more just, we think we have a lot of experience to offer, and we wanted to make sure people could get that experience. So having another opportunity was nice, and it helps with our scheduling. In terms of the project management, we do try to select for residents who we feel would be good at running a project relatively independently with us overseeing it. But then we just take turns as a preceptor group being the project advisor. And they end up working on a lot of projects as it is beyond just that, year-long EM one. So there was a lot of different reasons, but overall I think it was a great move because it's also good for the residents to have someone to work with and lean on throughout the year.
All right, so the planted questions. So one of the discussion questions is, how have PGY2 emergency medicine programs evolved, and what are the important future directions for new programs to consider? So I think just looking at it from the residency standpoint, I think we keep going back to Chris's presentation, but it did a good job just to show that involvement. I think the nice thing about it, as someone who is fairly new in this residency program director role and establishing a program, is one of those concerns. I'm sure, as you guys are well aware, that pharmacy student enrollment is going down. And what does that look like for the landscape for us as far as residency program directors or people in residency programs? I do think that emergency medicine still is a field that people want to go into because we're amazing, number one. I might be a little biased. But I do think that it just provides a lot of opportunity for the learners to expand their horizons, and that's what I like about emergency medicine. We're not just in a box. I don't think we are. Again, you're gonna find out very biased and think we're amazing, so there's that. But, so I think that we've been good in leveraging that. There was just some concern of discussion of like our rapid growth and what that may do for application pool. But I don't think we have seen that yet. I don't know if other programs want to speak to that as well. One of the things I did find interesting, at least locally and kind of outside of a geographic region, is like the level of applications people felt that they got maybe on the decreasing trend. And I guess I'm curious just to open it up to the group, like I'm just doing this however I want. But did anybody else feel like the application pool was the same, different? Any concerns about that? I know, I'm looking at other people I know that are in programs. Down.
Number or quality?
Number and
Yes.
quality?
Both.
Both.
Number down, quality.
Did you guys see that?
Yeah, I mean, at least from thank God I got to early commit, so. But yeah, overall, I think you see that in the match numbers. Thank God it wasn't affected within the emergency medicine realm. I think you really saw it, obviously, with sort of the overabundance of administration positions, PGY2s and combos. You saw that, and who knows what that's all about. But I think that having conferences like this and being more present and having our own thing, and it will always attract the sort of inherent emergency medicine people and personnel. Is kind of going back what Frank said, the personalities of people. As long as we're staying out front, we have those leadership opportunities and doing what we can to stay. I know it's difficult, but trying to maintain a positive outlook on things. That's not to say just to kind of ostrich and put your head in the sand, but I think that a lot of our learners, PGY1s, PGY2s, and students really look at the content that we're putting out on social media, the interactions we have at our institutions. One of the things that I found kind of interesting at our local state affiliate conference was the number of high-quality technicians that we had that were considering pharmacy that no longer are because of the interactions they had with certain pharmacists at their institutions. So those all are kind of intertwined, and not really sure I've got it figured out or anyone does, but those type of things are something I've tried to stay focused on within my own practice. So a lot of rambling about nothing.
Yeah, well, we've seen numbers of applicants drop each year consistently. It's been decreased by about 4 each year. Fortunately, that's meant it's gone from like unmanageably large to we can actually review some applications. So I still think there's plenty of applicants out there. The quality is, you're always going to have good and bad. Obviously, I think a lot of it stems at pharmacy school. Acceptance rates are 85%, and there's a massive proliferation of pharmacy schools, and then we have more students, and then the rigor of their screening is lower, so sometimes that'll wash out over time. But I think that pendulum is swinging too, where now we're starting to actually evaluate if all these pharmacy schools should be open, and some of them are kind of now shutting down, which is interesting. So I don't know. It is an interesting landscape, but employment seems to be continuing, which is good. That's all.
Did you ask me a question?
No.
Okay.
I have a question. Okay. Do you guys have any advice to prepare your residents for being prepared for a breadth of EM positions? For example, if you're at a big academic center, do you send them to a community hospital? If you're a big trauma center, do you send them to somewhere else to kind of get those experiences they might not be getting from your institution? Or any advice to prepare them for a job that just may be different than where they're training?
Well, I think every program should do a good hard look at what your weaknesses are and reach out to people. We don't have a ton of peds. We send our residents out to our community site so they can see some peds, they get some peds and talks, but we're like, you're not going to see this. So we try to get affiliate or partnerships with places that can provide that. So that's number one. Everyone should just see what you don't have and see how you can offer it in some other way. But yeah, then we send them out to a community hospital, a sister hospital that we have, so they can see what community practice is like. And you touch on something really interesting. It's like, what are people going through our training programs still getting the same opportunities that we got when we went through our training programs? Are they all gonna, I still think, are there more jobs or less jobs now? And are they just as illustrious, or are they maybe the less desirable ones? And I don't actually know. When I went through PGY2, I had the mindset of, I need to do this it has to be enough just to get the experience. And I kind of think that's still how people should think about it, because unfortunately in our profession we penalize each other for becoming a specialty, and now you have to fight for a job where maybe a generalist position opens up and they think you're going to leave because you did PGY2 training. That's insane to me that we do this. But I do think, the landscape that we're in, sometimes you just have to say, hey, if I care enough about this, it's got to be worth it just to get the experience. And then once you have that experience, you could take it anywhere in any place, and it might not be what you trained, but you're definitely going to make wherever you are better. All right, so
So I
feel like I've kind of had a unique position in the fact that my earlier years were all in an academic setting. So worked at Nebraska Med all through school, then I went to U of I, PGY1, Detroit Receiving, PGY2. First job out was academic, and then I was like, let's try out this community gig. And I'm gonna be honest, I was one of those people that was like, academic's the only way you can go. That's what was ingrained in me when I was in pharmacy school, like that's the way, the direction they went. And I honestly feel like this is also, I've already told you guys I'm biased, so it's going again, but I honestly feel like the level of impact that I've been able to have has happened at a community hospital. So I do a lot of having my own, like internal, having those different experiences and taking that. I do a lot of like the discussions with my residents. I sometimes feel like it is harder for a learner from a community to jump into academic. I do think that that is a difficulty, but ways that we have circumvented that is through networking and doing those outside rotations. I have no qualm saying that they're gonna get something better from someplace else that we're not able to provide. It's just impossible. One of those things that I've learned as I've gone through this is that you can't be good at everything, and you need to learn where your resources are and where those experts truly are and reach out to them. That's not something that I was always comfortable with in my formative years, but that's something that has been helpful in just having those conversations. But I do think that just making sure that they get those types of experiences and networking and having those types of things help. But I do feel like it is hard coming from a community hospital sometimes to help them when it comes to jobs, because I currently have a PGY2 that was looking for jobs to get their foot in the door for a large academic medical center. I truly think that it was harder.
Yeah, I practice within a community setting, community teaching, and I think some of the things that, feedback that I get and just inherently things I've seen are maybe the things that are not taken for granted at an academic setting in terms of like colleagues around you. I mean, places that Mayo, you may be working with like the top XYZ person that wrote some of the guidelines that you're implementing, whereas like when you're going from that academic to a community setting, the sort of inherent like this is going to happen may not be there, or so anyway, I mean, I say all that to say you can have a maybe larger impact, but there may be more frustrations of being able to practice at the highest extent of your physician colleagues and nursing colleagues and things like that. So there may be, it's a give and take. I mean, there's certainly benefits to the community setting and there's certainly benefits to the academic setting. I think ultimately when you're talking to your residents about it, you just have to decide like what's most important to you. Like what are the things that you could live without? What are the things you could live with? What do you find most fulfilling in a day-to-day operation? Like when you walk in, do you want to be the person that they walk into the room and can change the entire vibe and treatment plan because of what you know versus like, you know, maybe in an academic setting, it's not as robust. So I mean, not knowing everybody's practice, but that's just usually the conversations I have with my residents on that.
Just brought me back to one of the things I think that's important is that we are type A and we just like have everything outlined. And like, I think that's the worst thing we can do for ourselves. And I think sometimes that's one of the things that I've had a lot of discussion with my residents is that you need to be open for the unexpected. And I think sometimes, yeah, we work in EM, things are fluid all the time and all those things, but we still are very structured human beings. I think that's why we do what we do. And so we have like an outline and path, and I think sometimes we're our own worst enemies with some of the language that we carry through when we talk about things and what we envision is the ideal. And that's one of the things that I have discussions with them is that there's no true ideals, and you have to be open to those experiences, whether they are what you envision or not. And I think that that has helped a lot with those discussions, because I think oftentimes, like as they go to apply for positions, I think a lot of the way they present themselves or the narrative that they're giving can be detrimental, if that makes sense what I'm saying. So.
I actually think, you know, you're talking about, you know, how do you get people, they all want these like level 1 trauma job or whatever. Trauma gets so boring after a while. You can only give so much fentanyl and tetanus. You're not going to care about that in 5 years. Yeah, you get to see a Thora, it's cool, but what, like, in fact, if you are in an under-resourced community site where it's you, the physician, the nurse, and a code is going on for a peri-arrest DKA patient, you're going to make way more of an impact there doing it by yourself. You know, in my first trauma of the day at an academic center, and 30 people show up. It's not like, it's actually a little bit harder to feel like you're really in there playing a role. So I think nobody should discredit any job they're bringing great training to that they're going to make a difference in.
The other thing too is it's great everyone shows up here because not everybody in this room right now is working at an academic medical center. So we need more inclusivity of community hospital settings, training. We need more voices. And that includes not only at these conferences, but we need it more in guideline representation because obviously you're create all these treatment plans and guidelines are based upon these amazing plans that a lot of community hospitals can't execute, right? And so not having that voice or representation can actually harm patients. And so having, you know, again, these opportunities, if you're ever presented with the chance to speak at one of these or, rewrite a protocol or whatever, we need those community voices to allow for that representation because it is so important because it could just be you, nurse and physician bedside, and that's it, so. How questions? Yes.
Oh, I just wanted to make a quick comment. So I actually found Farm So Hard podcast about 2 weeks before the previous conference, and hearing that podcast and kind of being a part of like seeing what the community is like and seeing that the passion that a lot of the people in these rooms have kind of actually turned the needle on me going into emergency medicine. I knew it was kind of what I wanted to do, but there was a lot of influence in seeing the representation, seeing the community, seeing the efforts, and I think it's really important and to not underestimate what kind of like reflecting on your comments before on how influential that is, and it was for me, so just wanted to share.
You're turning needles, Jimmy.
We're bad at that.
I know. I've been trying to read it, but then my ADD kicks in.
My name's Zach. I'm from OSF St. Francis Medical Center in Peoria, Illinois. My question was more about, I guess, an initiation of a PGY2, like in the kind of world we're in right now, trying to find funding for that kind of thing, especially when you're not near a school of pharmacy that might help you fund a PGY2.
So I've embarked on that recently, so I'll take lead, if that's okay with you guys. Yeah, okay. So one of the things that we did is we actually were able to start a PGY2 during a pandemic. Now that was fun. And so I got to write my first executive summary. Not fun, but trying to figure out ways to leverage that. And one of the biggest things that stood out for me is looking at them as a way to be a service expander was the biggest way for us to get buy-in from the administrators. So it came at a time where staffing shortage was the buzzword, nursing, everybody was leaving the bedside, all of those types of things. But we were able to leverage our PGY2 to expand hours. And that has been a draw to our program is because we had a tiered approach to where as they went through their residency year, that they were able to expand hours further and further, develop that autonomy, and be able to be the pharmacist that was in the ED without a preceptor staring over them. And I think they liked that autonomy. It helped them build the rapport and be part of the team. And by doing that, they also were a third of a cost of a pharmacist. So you were able to expand services and provide different types of services or clinical pharmacy services in the ED with a lower price tag. So that's how we were able to do it. There was more into it to that, but administration bought onto it. The first thing they asked me is, can you do 2 of these? And I was like, there's one of me. I like man-on-man defense, not zone. So we started with 1 to kind of do that. And I really liked the ability for them to that's how you learn when you're on your own, not when somebody else is telling you what to do or saying all those types of things. And so I think it was good for the growth of the program to be able to have that and that stepwise approach. We are currently, it's been so successful, it's allowed administration to want us to expand services. So we're getting more FTEs in the ED. We're going from 1 to 3 currently. And I'm actually concerned about how that's going to affect the learning for the PGY2. It's a positive because there's going to be more pharmacists down there, but I do think it is something that people should look at if they want to start a PGY2 is look at your resident as being a service expander. Really look at them as being part of your clinical team and increasing coverage and being that autonomous learner.
I think the other thing to do is to consider what Chris was saying this morning about how you can create either the revenue generation or to essentially align your research projects with whatever the hospital goals are, which throughput is such an issue for everybody right now. So we've tried to align a lot of our resident PGY1 projects, or if you have your own projects, like what can I do to show and demonstrate, as she was saying, a pharmacy extender. Like, so if the hospital is hung up on throughput for right now, like what interventions am I doing that equate to this, that aid in that process? It's an easy, you're gonna do the research project anyway, and it already aligns with something that could value in terms of FTE development. So those are some of the things we've tried to do. I'm at a HCA facility, so it's always numbers and always like money. So we always are looking for hard dollar savings in any way that we can do to look at length of stays and all that.
Oh, we're cut off.
Yes.
I think we're at time.
All right. Yeah, well, hopefully we answered some questions. We tried to answer some in the chat too, but this was great. And I think there's a lot of interest in PGY2 EM training, and that should stay because it's a really great experience for people, I think.
You guys can get the chat section and answer some more.
Is
I'm gonna
it
let
through
you
a
guys.
group meet?
Yeah.
Okay.
Oh, yeah, I'm driving home.
Okay, should I announce that?
Yes.
And just for the people that are virtual, Ryan and I will get into the group me chat and answer your questions. So if you had a question we didn't answer here, just put it through on group me.
Perfect, guys. And the CE code that we have here today is going to be 2, C as in Charlie, M as in man. So again, that's going to be our CE code. We're going to be posting this throughout the rest of the conference. So if you guys forget to write something down, or if you guys are virtual and you want to take a screenshot of this is a perfect time to take a screenshot of this session here. And we're going to post this all throughout the rest of the conference. And at the very end, of course, we'll end with this slide again. And if you guys are having any issues.
Hi, can I get a grande vanilla sweet cream cold brew? And can I add 1 pump of classic syrup to that, please?
Yeah, it already comes with 2 pumps of vanilla, and that's okay.
Yeah.
Okay, so should I give you another what else today?
And then can I just get a chocolate cake pop, please?
Yeah, how many?
Good choice.
Just 1 chocolate cake pop.
Mm-hmm.
Okay.
And that'll be all.
All right, then I'll see you up at the.
All righty.
All right, welcome back, everyone. We're going to get started on our afternoon sessions. Our first speaker is Charles Foster, who's currently a content specialist for Micromedics, where his primary role involves developing clinical drug information with a focus on cardiovascular drugs and critical care. Just previous to this, he was practicing as a clinical pharmacy specialist for the University of Colorado Burn Center, and today he's going to be talking to us regarding the overview of acute burn care. So please welcome Charles Foster.
Hi, everybody. Good afternoon. So it's kind of hard to follow that Starbucks order, as well as this excellent panel that was up here. But yeah, my name's Charlie. I am here to talk to you guys today about acute burn care, basically. I've just been notified that it was a highly requested topic, so hopefully we can all learn something today. So a couple of things, a little bit of background disclosures. First, I got to pay recognition to the band Asia, a progressive 80s rock band. The song 1982 came out, Heat of the Moment. If you've never heard it, you should absolutely listen to it. But I did not come up with that clever name. So as we've mentioned that I'm a full-time, I work for a company called Meritive, who now owns Micromedics. I mainly sit in my basement and write drug information, so it's excellent to be here and see all you guys' wonderful faces. I also geek out on the internet a lot, and I have this big vision, so I operate a professional networking site as well. But before getting into the healthcare IT area, I did spend quite a bit of time in emergency departments, both at Denver Health and at the University of Colorado, as well as spending about 5 years in the burn center, and as well as the other ICUs. I too am one of those critical care trained people that we've been talking about today, but on that note, they are very different, I will say. But I've been fortunate enough in my practice to have some time spent in both areas. A little bit of financial disclosure just in terms of full transparency. I just have a handful of stock in this autologous cell therapies company that is used for burn patients actually quite a bit to grow their own skin. So objectives for today, we're going to discuss emergent needs of acutely burned patients, how to facilitate some best practices in the emergency department, determining the initial fluid resuscitation strategy according to assessment of size and severity of the burn injury. It's a difficult thing to do, so we're going to spend a fair bit of time just talking about that kind of thing. We'll also touch on incorporating some other best practices regarding fluid management, infection, nutrition, metabolic derangements, a little bit of VTE prophylaxis, and glycemic control. So on that, let's go ahead and get started. So burn injuries are actually very complex. They're considered a trauma. However, they really, following this injury, there's a huge inflammatory response. This is both local at the site of the injury as well as systemic inflammatory response that comes on, usually in the case of when the TBSA effect is about 20% or higher. A lot of this, the initial part has to do with the fluid resuscitation according to this TBSA estimate or assessment that, of course, first takes place in the ED. So other topics that we'll talk about, we'll touch on PK/PD, some things with hypermetabolism you may have heard in the past or more recently about burn-injured patients. They tend to have hyperglycemia and some other things. We won't talk much about electrical burns, chemical burns, and frostbite, but those are other things that are often managed in the burn center. And most importantly, the importance of pharmacists, both in the ED, caring for burn patients across the board. I think we can all agree of the importance of pharmacy practice and our role in the direct care of patients. So as far as some epidemiology goes, it's estimated over 450,000 burn injuries each year. This incorporates all the severity, but really the over 40,000 people are hospitalized with a burn injury each year. Overall, the available data suggests that gradually survival of a severe burn injury is actually pretty high, with survival rates upwards of 97%. Length of stay is very, very highly variable. It really has to do with the severity of injury, comorbidities, age. That really can go anywhere from a couple of weeks to over a year in some cases. So males get burned more often than females across all ages, except for over the age of 80. I think that's probably because females probably just live longer and are smarter generally. So as far as how people get burned, when we talk about definition of a burn injury, it's really damage to the skin and the underlying tissues after exposure to an energy source. Most of the time it's fire or flame, or hot liquids, scald injury, things like that. Can also be related to chemicals, electricity, radiation, other stuff like that. So in terms of, you can see that fire or flame or hot liquids basically is about 3 out of every 4 people that walk through the door is one of these 2 things. Hot liquid, so scald injuries, is a little more common in pediatric patients. Fire or flame, so this can be in a house fire, this can be in an automobile accident. People set themselves on fire sometimes. It's a whole wide range of things that can bring somebody in with a burn injury. So in the, this is more, I'm not going to go through this whole thing, this is more just for your own sort of viewing pleasure, but really the acute changes that happen when we're talking about a severe burn injury, so say like 20, 30, 40, even higher percent TBSA, a whole bunch of systemic things start happening. One of the things that I wanted to note on here that you may see in the ED from time to time, and you may see somebody get an escharotomy because this is a circumferential burn. So if you have an entire, the whole perimeter of the arm, say, is burned, you can get compartment syndrome in that area. So they'll oftentimes have to free up that, that area. So the other things to talk about, so notice here, this is from an anesthesiology journal, altered pharmacologic responses. There's no information there, but in fact, there is a lot of that. So we'll get into a little bit of that. So here's another nice schematic that I wanted to focus on. What we'll talk about today kind of is looped into kind of phase 1 and phase 2 when we look at this. It's probably kind of hard to read, but you can look at it at a later time. Really, a lot of the stuff in the emergency department's really only the very beginning. Obviously, that's kind of the case with a lot of emergency care related stuff. But really what I want you guys to understand here is that when a patient comes in to see you, say they have a 40% burn injury. That's actually interesting about burn patients is they tend to be a little different than the majority of people you'll see in that when they arrive to you, they may not actually seem that sick right away. They actually tend to go kind of downhill and then hopefully back up. So a lot of times, say in a trauma or acute sepsis, non-burn related sepsis, these patients come to you guys in their sickest moments and then work up from there. Whereas sometimes if you see somebody right after a burn injury, they may actually look not that bad except for having a lot of burned skin, but they actually, over the next few days, 24 to 48 hours, are gonna take quite a bit of a really kind of a dive, really, to be honest with you guys. So going on from there, after they get admitted, it really just kind of depends. There's a 48 to 72 hour window where it's like crucial. So they're getting fluids, they're getting, starting to get debridements, they're getting all these things happening to them. And really, after that 48 to 72 hours, then you get into more of these later phases where they have to have surgeries and they have multiple rounds of sepsis a lot of times. They have skin grafting, and then all those areas that are healing, they're very prone to contractures. So there's a lot of PT and OT involved. It's a very, very long, drawn-out process for somebody to go from an acute, severe burn injury all the way to leaving the hospital, which again can take, I think the longest patient I remember seeing was, well over a year, probably like 18 months, 19 months, something like that. So quite a long time in some cases. So when we talk about a patient coming in with a severe burn injury, the primary survey is kind of the typical thing that you would see, airway, breathing, all of those things. The one thing that we really need to talk about, though, is this preliminary assessment of the size and severity of the injury. And the main reason that that's so important is because it guides the resuscitation of these patients. The other thing, too, that we all kind of partake in the ED is helping with RSI meds. So sometimes patients will have an inhalation injury. We're not doing the assessments there, but we can be there right at the bedside ready to help with RSI. Just a little tidbit there, kind of similar to trauma patients, succinylcholine is generally considered not one to use for the hyperkalemia risk. So after that, then we go into things like definitive evaluation of the burn injury size. So we'll talk about what can be done in the ED, but then after the ED, there's a more in-depth assessment of the size. And this also helps guide fluids as well as surgical plans, stuff like that. Down at the bottom left, we want to talk about the referral criteria to go to a burn center. And really, obviously, the American Burn Association is going to be a little biased on this. However, it's really, a lot of times there's not much reason to not transfer a patient with a severe burn to a burn center, just because it's a very complex dynamic process that takes a lot of hands, a lot of people involved. In terms of the criteria here, you can see that really a burn over 10% size, really any, if you're gonna need skin grafting on your fingers, you're gonna want an expert kind of doing that kind of stuff. So really there's a lot of criteria there. And so a lot of times these patients, if you don't have a burn center at the place where you work, a lot of times they will be transferred, but they'll come to you first. We're gonna talk about what we can do in the ED to set them up for an appropriate transfer or go to the burn center at your institution if it is there. So as far as continued care goes, after they get admitted, again, fluid management. So I think you guys may see a resounding theme here of fluids, right? So there's also the wound care, dressing changes, surgery, skin grafts, and pain, right? So it's a very painful situation, even though we'll talk about the severity does kind of come into play as far as the acute pain in the ED goes. But you got to remember these people are getting their skin scraped off, and it's very painful. I actually, when I worked at CU, I was fortunate enough to have my desk directly adjacent from what they call the tub room. So I got to hear all the people so I listened to my headphones a lot. Anyway, on from there. When we talk about the depth of burn, this really has to do with the severity of injury. So here we have a cross-section of a chunk of skin, basically. You can see here is epidermis, dermis, and it goes into the subcutaneous fat and the muscle tissue there below. When we talk about first-degree burns, this is really superficial. I think probably safe to say everybody in the room's had a superficial burn. I burned myself just last week doing something. It's very common, right? But those heal up. They're quite painful, but then they heal up. So when we talk about superficial partial thickness, we're talking about getting into a little bit more of the dermis layer, so the immediate layer underneath just the epidermis there. And then when we talk about deep partial thickness, it's going even farther down, sometimes can get into the subcutaneous fat. And then when we talk about full thickness or third-degree burns, these are areas that essentially will not heal, like without question are not going to heal. Same thing goes with deep partial thickness and in some parts of the partial thickness burns. And so those are the areas that need to be essentially removed, and then with grafted skin at a later time, then it heals. Obviously, those things can get infected. It's very complicated. So the thing to note here, though, in the ED, you may see somebody come in with severe burns, right? So a lot of deep burns, full thickness burns. And the thing is about that is like the pain of the acute pain that's associated with the burn actually is kind of inversely related to the severity. So if you have somebody with some superficial partial thickness burns, it's kind of like very, very sensitive. Like just to light touch, it hurts incredibly bad. Whereas a full thickness burn actually is not that painful unless you are really deep pressing on the area. So that's just a unique thing about a burn injury there. Fourth degree burns really are, it's completely gone. Like the injury, and this can happen, say, in an automobile accident if somebody's entrapped, say they have their legs caught up in there and there's a fire going. Oftentimes they'll need these amputated. So when we talk about estimating the size of a burn injury, again, this is a very important thing because it really prompts the initial resuscitation fluid rate. Primary methods that we can use to do this is a rule of nines is something that's most commonly used in the ED. And there's another thing called the London Browder, which may be used for pediatric patients in the ED. It's quite a bit more complex. Again, so superficial, those first degree burns, these aren't included in the TBSA. And I want to just kind of reiterate that point because that's an easy way to overestimate the size of a burn. If you have somebody that has what appears to be a very large burn, only one smaller area is actually more than a superficial burn, it may be easy to consider that at 20 to 30%, where in fact it may be like 5 to 10. So first degree superficial burns are not included in the TBSA assessment. So the rule of nines, here along the left side of the slide here, it's basically a breakdown of nine percentiles across the body. So the head is 9%, and this includes anterior and posterior, same thing with trunk, so 18 on the front, 18 in the back. Arms are 9 each, so 4.5 front and back. And legs are 30%, 36%, 18 each, anterior, posterior of each. So you can see that this is already kind of complicated to come up with a TBSA assessment. But fortunately for us, we're not usually doing that assessment. So we can judge those assessments, right? So we can give feedback and say, that seems awfully high. So that's why we're here educating ourselves a little bit on this approach. In terms of children, hopefully you'll never get to see a pediatric burn injury, but they do occur. One of the things about kids is they have huge heads, right? So I have a 16-month-old, his head is enormous. It's, you know, he's in 95th percentile for his age, so I mean, his head's huge. But as you can see here on the, towards the right side, as the kids get older, their heads don't necessarily shrink, but they make up a smaller portion of the total body surface area. So this is the London Browder on the left, and really what this is in the upper part, you can see that there's sort of a cross sections of the body areas, and really what usually an admitting attending or one of the residents will fill this out, and they'll go through and they'll make a definitive assessment of the size of the injury, and that will then help guide subsequent fluids. So when we talk about fluids, right? So how much, how fast, you know, which one? So there's a lot of different fluids to give, right? There's isotonic crystalloids, things like normal saline, LR. There's hypertonic crystalloids, so there's 3%, 23.4% saline, as well as colloids, so albumin, FFP, and starches. You know, we all know that starches aren't really used that much, but they are in fact a colloid. So when we think about fluids, and particularly in a burn patient, I think we all know this here, but fluids are a drug, right? They're not just some innocuous thing. It's not like drinking a glass of water. You can actually cause significant harm if you use the wrong fluids at the wrong time or give way too much fluid in a patient that may not need that much. So it's a complex physiologic process. They change over time. So when we start getting into initial fluid rates, we got to understand that these things change. You know, the stuff we'll talk about here in a minute is really just an initial guiding principle in terms of giving fluids in an acute severe burn. And then the thing that I'd like to point out here is appropriate type and dose of resuscitation fluid in patients with burns has not been really determined. It probably depends on who you ask, but I will reassure you that there is a lot of opinions on this. And so each and every one of you that may have a role in a care of a burn patient may hear even something a little different than we talk about today. And really, every burn surgeon's got their own opinion. So, any Radiohead fans in the here we got one here. So this is Tom York. He's king creep as far as I'm concerned. And so what Tom's here to talk to us about is why we should avoid creeps, including, not necessarily himself, but this little guy on the right here is our fluid creep in himself. So let me just throw it straight out there. LR is going to be your fluid of choice, right? So lactated ringers, balanced crystalloid, that's going to be the fluid that you give to a burn patient in the ED. So then we talk about colloids, so FFP or albumin. These are frequently used when the TBSA is greater than 20%, and they might start in the ED, and I say might because it can be highly variable when this person shows up to you guys, right? So say they got burned just right up the street from your hospital, and the injury occurred 20, 30 minutes before they got there, versus someone who had a burn injury in a rural area and then has been, in the ambulance getting fluids, and they get to your ED and it's been about 6 or 7 hours, they might start to get into an area where somebody might start bringing up the idea of colloids. But really, when it comes to colloids, they're more often than not, they're sort of outside of the ED when they get sort of incorporated into these resuscitation protocols that are oftentimes driven by the bedside nursing staff, actually. So the majority of burn centers would have a nurse-driven protocol to help guide fluids. So the idea of fluid creep, though, it really is a significant issue in burn patients. So it really relates to too much cumulative fluids and really over-resuscitation, essentially. The initial fluid rate that we pick in the ED can actually impact this. So again, it's like, say you pick this fluid rate, set it and forget it, the patient then has to wait for transfer or something. The fluids are really monitored down to the mill pretty much in a burn patient because it's so important. Things that can happen from fluid creep are, edema, complications, compartment syndrome, other things that can really impact the overall outcomes of the patient. When we talk about burn shock, it's a little bit of a different type of scenario than the shock we may usually consider, such as cardiogenic, septic, distributive shock. It's kind of like a combination of all these things. In general, a TBSA 20% or higher is going to be at risk of developing burn shock. They lose water from their injured skin. They have endothelial compromise. So some of you may have heard of a glycocalyx on the inside of the endothelial lining of the vasculature. That actually really starts breaking down. So they get very, very leaky. And that's part of the reason where colloids are called into question, because there's actually some people that believe if you give colloids too early, you can actually have the colloids go out of the vasculature, creating an osmotic gradient to actually worsen the distribution of fluids in the body. You're going to end up with more fluids in the third space. So when we compare again to something like septic shock, burn shock is not easily resolved. And I'm not saying that septic shock or trauma injury related hemorrhagic shock is easy to resolve, but you kind of have something that you can give and you kind of have an expectation that they'll respond, right? So you give antibiotics, you give fluids. Typically, if the patient's going to get better, those things are very helpful. They start getting better. Same thing goes for trauma. You stop the bleeding, give blood, hopefully their blood pressure comes up, right? Whereas in burn, we give these treatments, we give them, and the patients respond sometimes, but it's highly variable. And it really has to do with that first 48 to 72 hours are really this critical window where burn shock can occur. So again, back to the colloid stuff. So naturally we think, okay, well, if we're having difficulty resuscitating a patient, we're giving these fluids, let's think about colloids if they're not responding to the crystalloids. So there was a meta-analysis in 2016 that included all of these. So from 1975 to 2012, you can see there's not a whole lot of data, right? So this was crystalloids versus albumin for burn shock in adults. They were looking at a primary outcome of an odds ratio for mortality. There was 4 RCTs, 4 non-randomized trials included. Demographics, the patients had a TBSA range 32 to 57. They were between the ages of 25 to 50, and some had inhalation injuries, some did not. And you can see here, when you look at the resuscitation fluids that were compared, you can see that even with the albumin, there's not 1 or 2 that are even the same there. Really, it was highly variable. And so we already know that, like I said before, everybody's kind of got an opinion on what to give. So all of these things are highly variable. So when it came to looking at the data, you can see it with this forest plot that there was a sort of favoring albumin here down at the bottom. You can also see that there's a fair bit of heterogeneity across these studies, which is, again, not surprising. But, in the event that we have heterogeneity and we take out the studies that don't sort of align with the methods of the other ones and that just have significant things that maybe we're not controlled for that contribute to that heterogeneity, that's when you'll probably hear, if you looked or read about it and looked into it, that mortality is that albumin may serve a mortality benefit in burn patients. But the data is a little bit sparse. So additional outcomes so compartment syndrome, again, if you give too much fluids, you can cause compartment syndrome. So giving albumin tended to have less people get compartment syndrome. And so the author concludes that based on the totality of currently available evidence, acute burn shock resuscitation with albumin may reduce mortality and compartment syndrome. However, the evidence is poor. So then we think about, okay, so let's give pressors then if we have burn shock, right? So this was just a systematic review looking at ICU patients who got vasoactives and or inotropes in the first 48 hours after a severe burn injury, or they did not. So this again kind of sums up the burn literature in that these authors found over 1,000 records they wanted to screen. They ended up with 2 studies. So one of these studies I just want to shout out to the pharmacy people is Kate Pape. She is the 2019 paper primary author. These were both retrospective studies, and they basically just were describing the vasopressor use in the burn population that they were analyzing. And really what they came to find out is really not, it was more of like, it's a descriptive data set, right? And so older patients with a higher Bow score, which is essentially a predictive sort of thing for mortality related to severe burn injury, these things were really associated with the need for pressors. Vasopressor use was correlated with the need for dialysis and mortality. It's not that the vasopressors cause these things, that these things are highly correlated, basically. So on that note, so the practice guidelines from the ABA, there's not really a routine role for pressors in the setting of severe burn injury. It's just, though, if you need a pressor, you need it, right? So we still apply that, but generally speaking, pressors aren't typically gonna be something you're starting in the ED. And really acute hypotension immediately following a burn injury really should be thought about almost like, well, what else is going on here? Because the hypotensive effects and burn shock, those don't take place right away. They take a few hours to kind of set in. So depending on when you're seeing the patient, you really ought to take those things into consideration. So resuscitation formulas, you can see here again, a whole slew of different ones. The Parkland formula is the most common one. The Brook formula, modified Brook, is another common one. So you can see that the mils per kilo per percent burn on the Parkland is 4. Modified Brook is 2. They all sort of implement colloids, but usually after the first 8 to 12 or beyond hours. And again, this is a starting point. The idea that you can calculate a 24-hour need of fluids for a burn patient and then set it and forget it is not going to happen. So this is all just an initial burn resuscitation fluid rate. The usually targeting a urine output of 0.5 mils per kilo per hour or 30 to 50 mils per hour. Again, these are a lot of times RN-driven resuscitations. And you can go up, or a lot of times you can go down on fluids, and that's an important aspect here. So what are people doing, when it comes to resuscitating burn patients? So here there's a survey of 173 respondents. They were from 58 countries, mostly in Europe. Background was mainly in intensive care or anesthesiology. Most respondents declared working in a mixed ICU, and 60% worked in centers with less than 50 adult burn patients admitted annually. So in terms of what they asked questions about, so what's the most frequently used parameters to guide volume therapy? Urine output appropriately was very high up there. Other things such as lactate level, we're chasing some things around here. So as far as triggers to initiate a colloid, there's a whole list of other things here, but as you can see, highly variable, right? Same thing goes with vasopressors early. What treatments do you give early on and giving vasopressors early? So again, it's all over the map here when it comes down to how do we do it. So this slide right here is, I think, a very good one to know. I put a little QR code there. It's basically a PDF on the internet from American Burn Society. And they have a couple of tips here. So an easy way to remember a consensus formula is to sing it. So if you guys want to sing it, you can. I'm going to take it one step further and just tell you to do the rule of tens. This is very much more of a simplified approach to derive the initial fluid rate for a severely burned patient. And really what that is we're gonna get an estimate of TBSA from one of the physicians. We're gonna kind of think about that and say, yeah, that seems about right. If there needs to be a further discussion, you should do it. Otherwise, it's TBSA times 10. That's your initial rate in mils per hour, okay? So what about the patient after they get out of the ED? What happens from there? So they go in and they have burn hypermetabolism. So this is where, this is 48-72, and then for months on end thereafter, they have a high resting energy expenditure, they have high metabolic needs, they have a whole bunch of a need for high nutritional requirements. Interventions that sometimes are used for this are insulin, propranolol, oxandrolone. Again, these are things that are implemented thereafter, not in the ED typically. So other PK considerations, pretty much any drug you give a hypermetabolic burn patient is going to affect PK/PD. Can be absorption, distribution, so these patients are going to have a very large volume of distribution. They tend to metabolize things quicker after they get into the flow phase of 48 to 72 hours out. Really, the excretion, they have increased renal clearances sometimes. So other considerations, burn depth and size, renal hepatic function, all the other normal things you would take into account when evaluating a patient on how to dose a medication. Those things all still apply. The thing is, though, is 9 times out of 10, if they have normal looking kidney function and they don't have an acute liver injury looking picture, you're going to want to give them pretty much normal higher doses of pretty much any drug. Consensus definition for sepsis. Sepsis in burn patients is difficult because they basically always are tachycardic. They have fevers all the time. They often have an elevated white count. And then you go look at the microbiology, they have just all kinds of bacteria all over their wounds. So it can get a little bit difficult. And so the ABA has really a consensus here on infection plus 3 or more of the following. I'm not going to spend much time on here, but just understand that like burn sepsis is a little bit different. There's a lot of times where patients will be febrile, they'll have a white count, and really they may not even be on antibiotics despite having a bunch of cultures that say positive, because really it comes down to the assessment of the injured areas itself. So the burn surgeon would look at that if they can tell if the wound's infected or not. But otherwise, serial cultures oftentimes will show that bacterial growth is always there, basically. So Dr. Reck here did a nice paper that y'all should look at from 2019, basically saying that sepsis in burn patients is a bad deal, and it definitely increases their risk of demise during their hospital stay. Pharmacotherapy for hypermetabolism, again, I'm actually, I think, over time already by a fair bit, so I'm going to skip that, but there's drugs that are used. And burn pain, so treat burn pain as you would any other pain. If the patient's in pain, give them pain meds. Inhalation injury, if you have to intubate a patient, reach for the non-succinylcholine based treatments. Treat cyanide exposure. Post-admission treatments include inhaled heparin and N-acetylcysteine. Those may be helpful. Nutritional considerations. VTE prophylaxis is an interesting one in that it's actually not all that common. It's much lower than your general trauma population. So on the order of, say, 1 to 5% will get a VTE, which is kind of surprising given the amount of systemic inflammatory response. So lastly, most importantly, pharmacists, most important people in the room, obviously. In 1982, there was a paper that concluded that there was a rewarding experience from the pharmacist and their input was considered very valuable. And then in 2006, another study came out, and this one was published in the Journal of Burn Care and Research, which is an old boys club journal for burn stuff. It's not really a pharmacy journal, but we got it published in here, not me, not these people as in we. And they showed a cost savings of over $11,000 in just 6 months. So there's definitely a lot of room for pharmacy involvement. So take-home points. I'm just going to let you guys look at these at a later time. There are definitely some good take-home points here, and even more take-home points. And apparently I went way over. Sorry about that. So learning assessment questions. Which of the following is method for determining percent TBSA? B, rule of nines. Excellent. You guys were listening. I thought after lunch you might have a little bit of a hard time with that. So yeah, rule of nines is a good way to do that. That's going to be what the physicians in the group are usually going to use to tell you what the TBSA is. What is an appropriate initial fluid regimen to start in the ED for 40% TBSA injury in patients weighing 67 kilograms? So liter bolus of saline, 4 mils per kilo per TBSA of LR over 12 hours, 400 mils per hour of LR, or 5% albumin, 350 per hour. Let's go with, how's C sound? Do you guys think C sounds all right? All right, that's what it is. So answer is C. So the Parkland formula, it's utilized, but the thing is it doesn't have to be right away. We can make it easy on ourselves. TBSA, this is within a specific weight range. So if these people are average weights, typically you're going to take the TBSA, times it by 10, set up the LR, and let it infuse, which is not a component of burn-related hypermetabolism. Hyperglycemia, tachycardia, increased nutrition requirements, or weight gain. D, weight gain. So these patients actually usually lose weight. It's always a consistent battle to keep them with adequate nutrition. On that note, questions? If there is any questions, I'm happy to answer them. And again, sorry I went over a little bit.
I think if we do have questions, we can add them to the chat, and then we'll address them in there just to keep things moving.
All right.
Thank you so much. And the CE code for this session is the number 8. A is in alpha, B is in Bravo. 8AB. We have a group of speakers coming up next. So it's my pleasure to introduce Dr. Chantrell Johnson, who is currently an emergency medicine pharmacist at Grady Hospital in Atlanta. Dr. Stephanie Wong, emergency medicine clinical pharmacist at Dignity Health St. Joseph's Medical Center in Stockton, California. And last but not least, Dr. Mark McDowell, who's an emergency medicine pharmacist and EM PGY2 RPD at Advocate Christ Medical Center in Illinois.
Hello, everyone. Like you said, I'm Chantrell Johnson. I'm one of the pharmacists at Grady. So today I'm going to talk about an out-of-pocket case, rock and reverse. So I have nothing to disclose. And this is the objective. So recently we had an interesting case brought to our department by one of our ER attendings. He had a conversation with our neurosurgery resident, and the neurosurgery resident said that he felt a patient was not a candidate for surgery because they were clinically brain dead on exam. And something about that struck our ER doctor as strange, primarily because the patient's imaging and vitals didn't match that of a patient that was clinically brain dead. So he thought to immediately call pharmacy and say, hey, do you guys think that the rocuronium could still be on board in this patient? And we were not involved in the case at all, so the pharmacist said, I'll take a look in the chart and I'll get back with you. So let's take a look at the case really quickly. So the patient was a 76-year-old female who had some neurological complaints the day before. She decided not to go to the hospital, and she ended up in the trauma center the following day for a ground level fall and a GCS of 7. Her last known normal was 12 hours prior to presentation, and she was immediately intubated with etomidate and rock on presentation. And she was sedated with propofol, which was stopped pretty quickly after being started. And we'll get more into detail about the drugs in just a second here. So these were her abnormal labs. If they are not reported here, you can assume they were normal. The two that I think may be pertinent to this case were the serum creatinine of 9.8, maybe the direct bili of 2.9. So neurosurgery was evaluating the patient because she had a subdural hematoma with midline shift and uncal herniation on the CT brain. And at the time of his exam, the patient had no cough, gag, or corneals. She also wasn't on any medications at this time. The propofol had been off for 40 minutes. And so now we're back at the original question, which is, could this exam have been under the unexpected yet persistent presence of rocuronium? So the pharmacist looks in the chart, and what does she find? The patient got 150 milligrams of rocuronium, and that is a pretty hefty dose. It's not something that we see or do very often. So she went and looked back at the patient's weight, right? And what did she find? The patient got 2 milligrams per kilo of rocuronium, so significantly higher than our 0.6 to 1.2 milligram per kilo dosing. Now, neurosurgery evaluated this patient an hour after they got the rocuronium, and rocuronium lasts about 45 minutes to an hour. So I want to ask you guys a question. By show of hands, how many people agree with the neurosurgeon and you believe the rocuronium should be worn off at this point? Kind of gave it away, huh? All right, how many people would, how many people believe that the rocuronium may still be on board and they would reverse with neostigmine? Are you all Sagamidex people? It's not an option. Okay, and then how many people would get a trainer for before deciding how to proceed? Right. So the pharmacist in this case, given that hefty dose of rocuronium, she says, look, I think we should reverse with neostigmine. That's what we have available. Neurosurgery agrees. They give their first dose of neostigmine roughly 80 minutes post that initial rocuronium dose. They wait around for 7 minutes or so, and in my clinical experience, the neostigmine works fairly quickly. I would say in less than 10 minutes, 5 to 10 minutes, you start to see a clinical response. In this patient, there was no clinical response. So 7 minutes later, what did they do? We gave another dose of neostigmine, and now we're giving atropine because now we're bradycardic. So they wait around for 10 more minutes. What happens? Nothing. So the neurosurgery resident is confused. I think pharmacist was confused. Neurosurgery comes back to the bedside 3 additional times to examine this patient. Every time he comes to the bedside, the patient is still doing the same thing they were doing before, nothing. So I think everybody was sort of frustrated at this point. And he decides, you know what, the only way that I can tell if this patient is under the influence of a neuromuscular blocker is to get a trainer 4. So he gets the trainer 4, and he finds that the patient has 1 out of 4 twitches, and this is 3 hours after getting rocuronium. So some of you may be wondering what that means. So a normal person like you or I on a trainer 4 probably have 4 twitches, or those people that have less than 75% of their receptors blocked, they have 4 twitches. This patient had 1 twitch, which correlates with 90% of their receptors still being blocked 3 hours after getting rocuronium. So how long do you think the rock lasted? It lasted 4 hours and 40 minutes. So 2 doses of neostigmine, and the rock had to wear off on its own. It lasted 4 hours and 40 minutes. So when it finally did wear off, the patient's neuro exam did improve. However, the family decided to withdraw care. But I think the point to drive home here is this could have delayed definitive care for a person that was a surgical candidate, you know? So I know you guys are like, well, why didn't they use the Gamedex? This could have been over a long time ago, right? We're broke, that's why we didn't use it. Well, that and because the patient serum creatinine was 9.8. Now, could we have used it? Definitely. There are studies out there that talk about using Gamedex in this patient population. It appears to be safe, but given that it's restricted to anesthesia, it's not something that we typically do, and then we're going to use it outside of the recommendation. We're probably not going to do that in our ED. But you're right, we could have done Gamedex, it would have worked. So what did we learn? And I don't know if you guys have experienced this, but we have experienced this so many times where people get these large doses of rocuronium and they are paralyzed for 4 hours, 6 hours, 8 hours after receiving the dose. And it's something that we don't see with succinylcholine. We have attendings that used to give everybody 200 milligrams of succinylcholine. We didn't have this issue. But with ROC, we definitely have this issue now. Some other things you may want to consider are drug interactions and drug metabolism, but to be honest, I don't think a direct Billy of 2.9 is causing this ROC to last for 5 hours, you know? The other thing you want to do is get a train of 4. So if you have less than 2 twitches on your train of 4, neostigmine is never going to work. You have wasted your time. You have to go straight to Gamedex. And then in this case, if Gamedex is not an option, then you have to wait for the drug to wear off on its own. And so in this case, we ended up waiting that 5-hour period. But that's pretty much it. So assessment questions. I think this is not something that's really well documented. I don't know if anybody else has any experience. We can talk about it later. But so giving doses of rocuronium above the recommended dosing range can prolong the duration of action of drug. I think this is true. And then in patients with deep paralysis from rocuronium, train of 4 of 0 out of 4, which drug should be given for immediate reversal? And the answer is Gamedex. That's pretty much it. Does anybody have any questions or comments? No, I think I'm not sure why the probe was stopped 13 minutes after being started. It wasn't documented and nobody remembered. Yeah, but so the patient went to CT without the propofol, and by the time he examined the patient, it was off for a long time. Yeah. But has anybody else seen this? Yes, right, yeah. Lasting this long as well? Not as long? Okay. All right, thanks.
Curious, show of hands, is anyone using ideal body weight for ROC dosing?
We should be using it.
Couple, technically. It's tough, yeah.
I've always had 100. Yeah, we do too. We typically do. But pharmacy was not involved. Did I say that pharmacy was not involved?
But like low dose ketamine, the highest dose ROC, right?
Yeah, right.
There we go. There we go.
Hello, friends. I'm Stephanie Wong. My talk today is titled Beyond the Drips, Strategies to Prevent Post-Intubation Oversedation in the Emergency Department. So the learning objective for today is to describe the role of PRN, IV push analgo sedation in intubated patients. No disclosures for me. So we'll start off with a patient case. LM is a 24-year-old female brought in by ambulance, unresponsive, after receiving unknown pre-op medications for an outpatient elective surgery. She was intubated for airway protection. No RSI meds were given, and the ED attending didn't want to start any post-intubation sedation because he wanted to see what would happen, whether or not the patient will wake up. A few hours later, you see the nurse hustling out of the room to get fentanyl and propofol drips because LM is waking up. And I know what you are all thinking. Over sedation? I thought this was an EM talk. Isn't this an ICU problem? And I'd like to argue that this is an EM problem. So the PADIS guidelines from SCCM, and also the PANDEM guidelines from SCCM, which is the pediatric version of the critical care guidelines, it recommends light sedation over deep sedation. And in the PADIS guidelines, it lists multiple clinical trials that support this recommendation. I don't have enough room in one slide, so I just picked a few as an example. But the one I'd like to point out the most is that light sedation compared to deep sedation is associated with fewer ventilator days. And that's something that we should care about in the ED, because holding ICU patients is not fun. So what else can we do beyond our usual fentanyl, propofol drip, see you later? As with all things, what are some non-pharmacological interventions that we can consider? And that would mainly be what potentially can be making the patient uncomfortable. To give you an example on pain, there was one time, room 7, patient not sedated, even on max fentanyl, max propofol. We were about to start a Versed drip, and we checked, and it turns out someone left the ET blade under her right shoulder, and her right arm was trapped between the mattress and the bed rail. Once we adjusted the patient, got her a warm blanket, she didn't need any more sedation. So like I said, temperature, light, is the overhead light glaring right in their face? Is the alarm just beeping nonstop right next to their ear? And another thing to take into consideration with the drips is that it takes time for the drips to kick in. This is a picture of an IV pump on a real patient. And if you look at it right now, the sedation, it's at our hospital protocol starting dose. So the fentanyl drip is at 50 mics an hour. The propofol drip is at 5 mics per kilo per minute. And it must be a smaller patient because the drip rate on that propofol is 1.7 mils an hour. In this patient, they're starting to wake up, fight the vent. The nurse is the nurse is saying that, quote unquote, the drips aren't working. But if you look at it, how long would it take for that 50 mics to go in? And this is something that I'm constantly having to teach our newer nurses, our new residents. 50 mics over an hour. It's going to take a while to get in. So PRN pushes for the win. But I understand that it's easier said than done. There's challenges in the ED with trying to shoot for light sedation. Under sedation is also bad. We don't want patients pulling out their ET tubes. We also don't want our patients to be in pain or experiencing anxiety. The ED itself is a challenging place in that there's a lot of potentially noxious stimuli. We have overhead paging going on all the time. People are talking, patients are yelling, monitors are beeping. Also, the volume and the acuity in the department can be unpredictable. So maybe your nurse has 2 intubated patients that they're trying to titrate down the drips, find the perfect dose for them, and then suddenly we have 3 codes at the same time. And what if that nurse needs to leave to go help with the code? What's going to happen with that patient that just got their drips titrated down? Another challenge is that perhaps the ED nurses or the ED physicians or ED residents, they're not familiar with post-intubation sedation strategies that are utilized in the ICU. And then the last potential challenge is lack of familiarity with these guidelines. And I state that because if you're not familiar with the guidelines, then a lot of people in the ED can think, oh, the patient is snowed, that's where we should be. So what can you as the EM pharmacist do to help with this? One is to evaluate the patient's pain, either through CPOT or BPS, and their anxiety level through RASS scores, and doing these scores yourself to assess how well the patient is being sedated. Another thing you do is to take into consideration the patient's safety. So do we need restraints on this patient? Is the department blowing up? If it's COVID surge and we have 5 codes at the same time, that might not be the right time to figure all this out. And then lastly, what non-pharmacologic and pharmacologic recommendations can we discuss with our team? Coming back to our patient case, you approach the bedside, introduce yourself, and ask Ellen if she's in any pain. And she looks at you and nods yes with that ET tube. You tell her that you can request some pain meds and that you'll call the intensivist to see if we're ready to have that breathing tube removed. She relaxes and nods in agreement. The nurse pages the intensivist, who orders fentanyl 50, Q30 minutes, PRN, with a RASS goal of 0 to -1. The intensivist comes down soon after, evaluates the patient, calls RT, and the patient is soon extubated without any incident. No supplemental oxygen was needed. So take-home point is, I hope you all walk away feeling as I do, that PRN sedation should be utilized in all of our intubated patients. If this is something new for you, please implement it in practice tomorrow. And if this is not new to you, please educate and share this with your team. We get, for example, room 50. I had a traveler nurse holding down a patient's arms, and she's just standing there waiting for the drips to kick in, which who knows how long they'll be. So I had her call the doctor. We got an IV push, the fentanyl, and we were good to go. I've also had locums ED physicians tell me that they've never heard of this idea either. So please help out our patients. All right, assessment question. JM is a 64-year-old male intubated for airway protection, status post-traumatic ICH. Both the fentanyl and propofol drips have been infusing at starting doses, but they're not working because the patient is now sitting upright, gagging on the ET tube. He is not responding to verbal reassurances and is unable to follow commands. What would you do to quickly sedate the patient? A, start a Versed drip. B, start PRN IV pushes of fentanyl and Versed. Maybe more hands, yes. Max out the fentanyl and propofol drips. So A and C are potentially options. It's just that we're not going to know for a while if it works. And so the benefit of B is that you get that effect right away. And then C, a one-time rock push. It does solve the bucking the vent problem, but it doesn't solve the sedate the patient problem. Okay, and here's the explanation. This was a big topic for 10 minutes, so come find me afterwards and let's chat. Thank you.
All right, good afternoon, everyone. It is such an honor to be here at like the first in-person one. So just really thank you guys at the steering committee and the exec committee for having me here. I'm really excited to talk about this topic. This is something I think might be a little bit on the cutting edge of opportunities that we have as EM clinical pharmacists, and really something that we should be considering in some of our catastrophic TBI injury patients, not only to optimize their hemodynamics in the room, but really think about the long-term sequelae that come with some of these other drugs. All right, you have my learning objective listed here. I do not have any financial disclosures. I do have a disclosure. My wife is a transplant pharmacist, so she has a lot of creative control over this talk and my life. All right. All right, well, picture yourself in the Bay. It's a Friday afternoon. Maybe you have a PGY-1 with you, and you hear over the radio a level 1 trauma activation. It's about 6 p.m. The gentleman rolls in. He unfortunately has some brain matter at the head of the bed that's frankly obvious. Also 3 GSW wounds to the head, a couple to the hand, and a few to the left lower extremity. EMS endorses there was very minimal blood on scene, and actually there's really not too much bleeding coming from that left lower extremity or that hand. Unfortunately, during primary exam, the airway is not patent, spontaneous breathing is not really occurring, and circulation is 1+ throughout. He does pick up a point for his GCS on disability for disarrowant posturing and giving him a 4. Intubation is actually completed without induction or paralysis by one of our rockstar PGY2s in the back of the room, and he's rushed over to CT. Unfortunately, this CT on the right is actually the patient's CT, and it passes what I call the pharmacist prognosis test, where we can actually identify retained ballistic materials. There's also a number of etiologies of hemorrhage in there, including subdural, subarachnoid, and intraparenchymal. The radiologist also comments that there's severe edema already present. Here I have listed the vital signs that are peri-presentation and after intubation, and also returning to the Bay status post-CT scan. You can see we're seeing a precipitous decline in both our systolic and diastolic blood pressures, and also a narrowing of our pulse pressure. It's at this point the trauma surgeon looks over at us and calls us by our collective name, "Hey, pharmacy." Maybe it was Amy Faith Ho, I don't know. Let's initiate HRT cocktail. Okay, all right. So this is a good transition point to really take 2 steps back about what we can really do and what kind of opportunities that we might have here. And what I want to do is frame this in some sobering statistics about organ transplants. So as of 2022, there was about 100,000 candidates listed for organs waiting right now in the United States alone. But over the past decade, that number has increased by about 19 to 20%. Conversely, organ donations have only increased about 3.7%. So there's a huge, huge gap there that we might be able to make a small impact on. Along with that gap of higher need and less organs available, we're also seeing an odd progression in our TBIs in North America. So about 61,000 TBI deaths occurred last year in North America alone. And this is a staggering statistic when you think in the past 20, 25 years, this has increased by about 25%, with the majority of these now being penetrating TBIs. What we can do then as pharmacists is really kind of think, all right, we can stratify these presentations of severe or catastrophic TBI into early and late complications, early occurring in the field all the way up to presentation to the ED, and this late phase that might start to occur in the ED and really progresses up and during their ICU stay. I think in the early phase, this is what we're great at, right? We're the kings and queens of optimizing ICP management down in the room and stabilizing hemodynamics. But I think there's some other opportunities here too that we might not think of as intuitively. That's potentially treating or preventing the hypertension myocardium, preventing or treating diabetes insipidus, and really this idea of hormone regulation. You might be thinking, Mark, I don't know. That doesn't seem like it's really within my wheelhouse. I feel like potentially a charlatan. I'm not sure if you guys are familiar with that term. But really, what I think is we have the tools within our armamentarium to really conquer this already. I'm going to pause on this so you guys can all take a picture for Twitter. But HRT, what we're really getting to here is really a combination of 3 different pillars of attack. We have our anterior pituitary, we have our posterior pituitary, and we also have our adrenals. And I don't know if you guys are a fan of the best show on television right now, but I think these personalities and the associated drugs really line up really, really well. Okay, so let's talk about those 3 pillars, starting with our anterior pituitary. A little brief physiology review of our thyroid process. We have inactive thyroid hormone, T4, also known as levothyroxine, that's metabolized into our active form, liothyronine, or T3, via that DIO2 enzyme, which is eventually metabolized via DIO3 to our inactive reverse T3. However, in severe TBI, what we actually see is a downregulation of DIO2, resulting to a net loss of T3 or liothyronine, and also an increase in DIO3, leading to, again, a more abrupt metabolism of that T3, resulting in RT3. From my perspective, this is a drug target that we can optimize, right? This is something that we can act on within that trauma bay itself. And really, to better frame this, I want to orient you to the graph here on the left. This is old data, so much so that it's copied from the 1980s or 70s. That really demonstrated that the more severe the TBI, the lower the GCS, those patients, if you draw a serum T3 level in the bay upon presentation, they're going to have markedly lower endogenous T3. This is an immediate process that happens within the time to transport. And we actually have guideline-recommended therapies about how to supplement this deficit. 20 micrograms IV push, followed by a 10 microgram per hour infusion. We can debate some of the logistics of that infusion afterwards. This does tie up a line. A lot of these patients have polytrauma. They might be requiring massive hemorrhage protocol. There's some nuance to that as well. But what's really interesting is that T4 actually improves organ procurement, and early T4 greatly improves organ procurement. Here I have listed the main organs that we procure from these catastrophic TBIs: kidneys, livers, hearts, and lungs. And you can see patients who were received early T4, the definition was before 6 hours, actually donated upwards of 20% more of livers, kidneys, and hearts. That's fascinating. That's a huge, huge opportunity for us in the room. All right, moving off of the anterior pituitary down to our adrenals, we know that catastrophic TBI also really just produces a huge upregulation of these pro-inflammatory molecules, TNF-alpha being primary one. And we see this, right? These patients get hypotensive. They almost go into a form of distributive shock on top of their hypovolemic shock. And what we can do is we can give what our transplant friends do, and is slam these guys with steroids, give these guys huge doses to clamp down on that TNF-alpha and really decrease that donor hypotension. What we've seen there is what we've known for a long time. Giving these massive doses of steroids not only increases the amount of organs that we can procure, but also increases the quality of those organs. What I mean by increasing the quality of those organs is that we're going to see less antibody-mediated rejection upon receipt from the recipient. You can see here we have some pretty whopping doses of methylprednisolone, again, the guideline-recommended therapy. I'm not saying this is why there's a shortage right now of this or hydrocortisone, but something to consider at your own practice. And then third, let's talk about that last pillar, your posterior pituitary. This is something I think we've all understood and kind of been exposed to. Upwards of 80% of these patients go into diabetes insipidus, just dumping fluid out of their urine, right? We know that's going to lead to hypoperfusion and potentially even hypovolemia. And what I want to do is orient you to the slide on the left. What's really fascinating is this is a really abruptly occurring process. In red here, you see our endogenous vasopressin levels after a catastrophic TBI. Those levels drop to negligence within a couple hours to a day. Conversely, the blue line is your urinary output, which makes sense, skyrockets within those first couple hours of the first day as well. So just like the other key caveats to these medications I've listed, let's supplement what they need and let's do it early on. So DDAVP or vasopressin can be used. That's something that we all have readily access to in our emergency departments. And really, this has kind of really been uniquely studied by these large transplant registry databases. By virtue, they collect the nitty-gritty data on all these patients. And what we know is over the past year, there was about 10,000 organ transplants. About 4,000 of those transplants were considered from catastrophic TBI patients. And when they did a retrospective analysis on what were these patient demographics, who donated better, who donated more, what they saw was if those patients received, prior to donation, any amount of exposure to vasopressin, they saw higher rates of procurement, and they also saw higher quality procurements from per patient. The top line here, I just want to highlight, shows, of course, their catecholamine requirements are going to go down, right? They're being exposed to vasopressin, extremely intuitive. So what I want to propose is potentially, if you're going to be reaching for something to transiently increase your blood pressure, maybe norepinephrine is not our ideal agent in this situation. Let's treat the actual deficit that our patient is suffering from. All right, so some key takeaways I want to leave you guys with. PTHP increases with severity. Remember that graph of worsening GCS correlates with demonstrably lower T3. There's an increased odds of organ procurement associated with the use of early HRT. And then early administration in hemodynamically compromised patients in the ED may result in improved organ procurement as well. So let's move on to our post-assessment questions. True or false, PTHP is most common in mild TBI. Anyone for true? For false, I agree, right? Okay. Our second follow-up question, which of the following is true? Donor quality of organs is unaffected by HRT. All right. PTHT is associated with higher levels of T3. Also false. And then HRT has been associated with a statistical increase in organ procurement. Excellent. Okay, let's go back to our case. If you remember where we left him, his systolics were in the 50s. He was on 0.5 mics per kilo per minute of norepinephrine. He received a liter of isolite, and he'd also gotten 2 units of PRBCs. So pretty promptly, we were able to administer our institution's version of HRT. You can see it's a little different than some of the studies I had mentioned. Levothyroxine given at 100 microgram IV push, followed by a continuous infusion vasopressin that you guys are all familiar with, so our shock dosing. And then our steroid du jour was hydrocortisone 200 milligrams is what we had in stock. You can see about a half an hour after that, we were able to decrease that levo requirement by about 50%. A half hour after that, we were actually able to turn off that norepinephrine completely, leaving this patient just on that vasopressin continuous infusion. And then I think the most miraculous thing about this case, the patient got an ICU bed within 2.5 hours. I've also expanded our vital signs here too. You can see we do see that concomitant increase in both systolic and diastolic after being exposed. And I'm happy to report that this patient actually did go on to the procurement phase and donated 2 kidneys and a liver. All right, thank you guys for your attention.
We have any questions for the group?
Hi, thank you. Great talks from everyone. Regarding sedation, do you have the ability to bolus off the pumps at your institution instead of IV push?
Do you mean
With like fentanyl, propofol?
me as the pharmacist, or do you mean the IV pump itself?
the ICU pump, or the infusion pump itself at your institution.
Our IV pumps are not programmed to deliver boluses.
I see. Okay, thank you.
Thanks.
Any other audience questions? Nick?
This question is specifically for Mark. Because sometimes in the devastating TBI patients, sometimes their hemodynamics hold. So in those settings, do you make the argument for desmopressin, like DDAVP, instead of vaso, like if they're hemodynamically, relatively okay?
Absolutely, and the guidelines actually comment on that too. That just pick your poison based off that simple algorithm, hypotension versus not. Dosing on that is well less studied, but throw a couple micrograms at a time, titrate to urinary output, but I completely agree. Yeah, if you don't need to pull the trigger on vaso or they're already hypertensive and you worry about herniation, absolutely. Yeah, exactly.
All right, thank you, everyone. The CE code for this session is 6, P is in pharmacy, 6PP. All right, it's my pleasure to introduce our next speaker. Claire Zagorski earned a bachelor's degree in anthropology from the University of Texas, so we got a local, at Austin, and a master's in medical sciences from the University of North Texas Health Science Center. She's currently completing a PhD in translational science at the University of Texas at Austin College of Pharmacy, and is completing a master's science in public health at London School of Hygiene and Tropical Medicine. She's been a paramedic and a harm reductionist since 2013 and has worked in both EDs and street outreach for people who use drugs around the city of Austin. So it's my pleasure to introduce Claire Zakorski, who's going to be talking about taking care of your family addiction, and the EM healthcare professional. Un momento.
Hi. Hey, y'all. Sorry I'm late. Got turned around. And I got pulled over on the way here, and that's always fun. All is well.
Did you get out of it?
I did. Thank you, thank you, thank you. All right, cool. Well, let me get rocking. Thanks for everyone for being here today. That's me. I wanted to talk a little bit about who I am. If any of y'all have heard of me before, you probably know me as like a drug checking and harm reduction person. I'm also a paramedic, and I worked in the ED for about 10 years before I went to grad school. So yeah, this is something near and dear to my heart. Here we go. Yeah, I don't have anything. No one pays me to talk about wellness. All right, yeah, so we're going to talk a little bit about, some things that I think are kind of helpful for our EM team. One of the things I like to say is the big reason why I haven't come back to the ER. Well, for one, I'm a grad student and I don't have time for such things, but also I'm kind of tired of seeing it chew up and shit out my friends. So we're going to talk a little bit about not doing that. All right. And I am an addiction person, so that kind of keeps coming back up. Plenty of what I see in the ED comes back to addiction and drug use. So we're going to talk a little bit collaboratively. I don't want to talk at you. I don't think that's very fun. All right, so addiction and dependence. Who finds these to be meaningfully different terms? Hence meaningful. Okay, yeah, I appreciate the honesty. For a lot of people, these are used pretty interchangeably. One thing I wanted to kind of point out before we get going is that addiction means something pretty specific. And it's not quite as clear-cut as you would think, but I went ahead and went with the NIDA definition, which describes compulsive drug seeking despite negative consequences, which is kind of the big thing. And unfortunately, that's a big context-dependent thing, yeah? And then we can compare that to dependence, which is an adaptive state. This can be physical or psychological. It can be both. And it can describe things outside of substances as well. So this is kind of a good example just to kind of prime us. We can talk about different things, and this is very simply put. Please no one come after me about physiology right now. Yeah, it's complicated. But yeah, so we can certainly develop things like a physical dependence to caffeine, but if anyone ran around talking about their caffeine addiction, I think we'd all roll our eyes because it's not really that hard to get caffeine in the United States, is it? And to make sure it's pure and it's not adulterated, and you probably aren't going to go to jail for stealing our caffeine. It'd be a bit intense. Cannabis, probably not physically dependent forming, but sure, psychologically we can get there. It's becoming less and less of a problem in terms of seeking it out.
No, they're built, well, they are, well, no, they're moving into something much smaller than the apartment, but they're gonna build a house.
I can help you this weekend, okay?
Did I type something?
You want help or you got it? Okay, be careful getting out, okay? Grab that stuff. Good job.
That's what it is.
Got everything?
Zoom is going to be the end of us all. Truly. Poor person. All right. Yeah. We're probably pretty on board with things like fentanyl and alcohol. We understand this, but it kind of depends, right? So there are dependencies on this. It depends whether or not you're going to get negative consequences from seeking out a certain substance. This is an important thing to consider, and I think it really matters when we talk about our own substance use as educated professionals in EM versus our patients. Because when we compare our drug use, and some of the more impressive drug use that I've seen in my life has been from white-coated professionals in the ED. Compared to a lot of our patients, it's a very different story in how it plays out and the consequences that are experienced. So it's a good reminder, the war on drugs is not equitably applied. We tend to look at convictions, laws, criminal records as a de facto indicator of how good a person is. And that extends beyond drug use and drug convictions. It extends into a lot of things. We tend to think of convictions equaling moral fortitude. And it's really not that true. There's a lot of disproportionate arrests and convictions based on things that people don't really have any control over. And it's a good reminder, a tremendous amount of what we see in terms of drug arrests come down to things that a lot of us would agree are not greatly harmful to the community, like personal possession of cannabis. And there also really isn't a statistically significant difference in drug use between racial groups in the US, but there certainly is in terms of imprisoning. So this is all a good thing to remember. I could certainly go on about this, I won't, but it's a good primer to remember that we aren't talking about something objective. We aren't talking about a lab that you can run that's going to return a value within a standard deviation that we can run with. There's a lot of differentiation here. So that is the last of my preachiness on this. Please bear with me. So why does this really matter? And it's because of how we conceptualize of drug use, how we talk about it, and how that projects onto our patients as well as ourselves. So we tend to talk about drug use in a very moral way, which is interesting because we also take care of it in the clinical sense, right? Like how many other contexts do we have something that's clinical and treatable and diagnosable that we talk about in terms of good and bad, like as a human? So we do talk about this in terms of something that's inherent to a person. It's something intrinsic to who they are. But we see over and over again that the consequences which are applied are extrinsic. They don't have anything to do with this person's moral value. And this is also significant because people in healthcare are especially good at hiding their substance use as well as managing it well because they know exactly how to. And worse yet is the fact that we don't have a plan in place to help our colleagues when they need it. So one of the things that we research in our group here at UT Austin is what plans are in place? Like what kind of consensus have we reached as a profession in order to help people in pharmacy as well as other health fields get through substance use and get back to patient care when it's appropriate? And there is no plan. So we worked on this for a while. We did this scoping review. I'm not a fan of scoping reviews. I don't recommend them, but hey, we learned something, although it is tedious. If you're a librarian, I'm sorry. So this is what we found. So we went through everything that we could find that laid out a clear on-paper plan for if this healthcare professional is found to have a substance use disorder, what are we going to do and what metrics do they need to meet in order to be able to get back to bedside care? And we found nada, well, essentially. There is one article that detailed this explicitly, that laid it out. There's a lot of kind of iffiness and gray areas. There is a lot of policies that described naltrexone as the most desirable or the only allowed form of MOUD that someone could use to return back to patient care, even though we know that while it works for some people, it's really not the best in terms of its performance numbers at population level. So that's a problem. And there's a lot of kind of iffy descriptions of we're concerned about impairment, which sure makes sense just in general if you want to talk about anyone being on a medication that could impair them at work. But there were no clear guidelines for how to quantify that. So there was just really, really nothing, and you can even see the sentence above where I started highlighting no articles specifically on practice reentry policy for pharmacists. So this seems like an oversight, like logistically speaking, but I actually think it's a lot worse than that, because if there isn't a clear plan in place for moving from, oh damn, I'm not in a good place and I feel unsafe with my patients, to this is how I can get through it and still be able to participate meaningfully in my profession, you're going to be strongly incentivized to say nothing and to hide it for as long as you can. Okay, so moving from there, I'm going to look at this a little bit larger because there is more ink on paper about substance use within physicians, and while I don't think it's quite the same, I think there's a fair degree of comparability here. And we do have some physicians here today, I'm sure. So one thing I'm going to say about this is that there has not been recent work on this. When I was doing research for this talk, I was like, there's definitely been something since 1993. Hoy vey. No. This is probably a different number today, but I do not find good, clear statistics that back that up. So this is from 1993. So big asterisk on that. Someone in this room, please do us a solid and do this study. But it looks like the substance use rates within the general population pretty well mirror healthcare, between 10 and 14%. But there are 3 specialties that definitely stood out in this study as having higher rates of substance use than their compatriots. Who do we think they are? Anesthesia. EM. Surgery. It was high up there. Psych. Why is that? Oh, I don't know. So this is what they found. Again, I would love for this to be redone, but this is what they found. EM is not surprising to me. Marijuana and cocaine, not surprising to me. They also split out cocaine utilizing specialties, which is a fairly small niche. It's a lot of, orofacial surgery, and then also benzodiazepine using specialties, which I think the largest single one was psychiatry, and they found that benzos were an issue for psychiatry, OB-GYN, but definitely anesthesiology, emergency, psych, and then chronic pain, which tends to get looped back into anesthesiology, so that wasn't the clearest separate domain. But those are the 3 that really stood out. So why do we think EM? So there is a few discussions floated in this article. There are other discussions floated in other articles. This is something that I've certainly spent a lot of time talking to people about. I'm sure everyone in this room has spent time at least thinking about this. So there's a few different things, and this is probably multifactorial, as many things are. So we can access medication pretty easily on unit. I'm willing to bet that most of us know someone along the course of our career who was able to divert meds from the unit. I certainly do. So there's that, access. So the authors of this paper suggested the second bullet point. I don't know enough about neurochem to really get into like how valid I think that is in terms of reinforcing a dopamine cycle, but okay, I get it. It's a long-standing joke with us, right? That we're really a bunch of adrenaline junkies that just like to run around and be cowboys. Okay. There's the culture, and then there's moral injury, which is what I'm going to talk about, because I don't really know that there's a good way to get around the others. I have a degree in anthropology, and one thing I'll say that I think it's terrifying to try to change culture. Hachi-machi, no ma'am. But I think we can talk about moral injury. So, unscientific poll, raise your hand if you have ever had to complete a mandatory module, on wellness and or burnout during your own time, or you had to do it at work and then stay late. Yes. Who's had to do it like multiple times? All right. So you mirror my highly scientific Twitter poll. Yes, this is not scientific. That was a joke. Yeah, absolutely. This is, I feel like, the biggest joke at this point is where we are exhausted and just want to sleep, and you have to do the burnout module. Got to bust open the health stream and make it happen. So why is this happening? I like to call this the smiley white woman with a salad effect. It's this idea that if we just are happy enough, if we just choose the happy, if we choose the leaves, if we eat the salads, if we do the yoga, everything's going to be okay. Does this sound familiar to your mandatory wellness modules? Yeah. All right. So, I don't want anyone to be crabby at me any more so than they're going to be anyway. Yeah, absolutely. I, in fact, get a little bit annoyed when I'm exercising regularly and I feel better. I'm like, God damn it. Yeah, absolutely. That happens. So exercise, eating well, meditating, whatever works for you in that sense, trying to be mindful, trying to kind of process your own thoughts, journaling for some people. These are good things. They do help. I don't want to be that much of a hater. But the thing is that this has been pretty well described at this point. I'm doubting that this is news to anyone. Is it news to anyone? Whew, all right. So I'm going to move past this. We do not have an issue of hypoyogosis. These are not bad suggestions. They just aren't adequate suggestions. So I'm going to try to introduce some kind of other things that I bet aren't necessarily news to you either, but I'm going to break them down a little bit more of an organized fashion and try to make a good argument for them. The biggest single problem with these kind of strategies to addressing poor mental health, burnout, substance use that becomes problematic is that they are individualizing a structural problem. They are individualizing a collective problem. This is not your individual issue. If you feel exhausted and strained and at the end of your rope because of your work environment, that is not a you thing. You can do as much as you can to preserve yourself, and you should, but that's not the answer. So why do we keep seeing them? 2 reasons. 1, your proximal colleagues is how I'm describing this. So this is your PIC, your charge nurse, your medical director on the unit that you actually see in person in the flesh. Maybe your HR rep that actually supports your unit and you actually see eyeballs on at the bedside. Don't have that much power. This is especially true if you work in a large healthcare system. So the approach to this is, you know what, this is going to be better than nothing. Maybe they really did need to hear about journaling. Maybe that really will be the thing that helps. It's better than nothing. I mean, they're not wrong, right? It's better than nothing. So this context, I think, is true to varying degrees, and it's certainly specific on context. Having said that, the slightly uglier reason for this is that as long as the larger staff remains convinced that the collective problem is theirs alone, an individual problem, it lets the institution off the hook, and that's valuable. I'm here to remind you that this is what's happening with healthcare. I doubt, again, that this is a surprise to any of us. Most of us do not have the luxury of working in small, independent clinics and hospitals where we are really well loved and cared for, and we understand and know everyone from the top down. We're seeing more and more consolidation, and good, bad, ugly, otherwise, what this does incentivize for sure is reducing overhead and consolidating down into the least possible, into the least possible kind of kernel of accountability. The less we can do to try to kind of take care of our larger staff, the more we can pull everything together into a single point of pressure, like with a wellness module, the easier and the better. So since the 1980s or so, there's been a steady move towards consolidation of healthcare organizations, as well as profit maximizing. And this is, again, definitely not here to get into an econ argument. So I'm not saying that the profit maximizing is bad, but what is bad is the outcome minimizing as the trade-off. So there's been more and more of a focus on maximizing profits, even if it means that outcomes are going to drop both for patients and our staff. This is inherently an extractive measure. So I think extractive kind of gets used a lot in social media, and it kind of loses some meaning. What I mean here is that this means we're going to extract from our labor and extract from our staff in order to benefit the larger collective, which is the business. Again, hypoyogosis is not the issue here. This is a collective problem. But I do have some suggestions for getting started to make this better. So we're going to actually talk about looking out for one another. So the reason I had this whole dramatic lead up is because I think looking out for one another is, on one hand, it's going to be something that we can individually do every day. We can try to be there for our staff. We can try to be more of a team. But then this starts getting into the creepy whole, we're a family here, so we don't have boundaries issues, right? Yeah, okay. So sure, let's look at this practically. So the emergency department is a team. Absolutely. It was the hardest reason, or the single hardest reason that I found to actually leave. Loved my staff. I worked for HCA. I have no love for them. The staff that I worked with, amazing. I would walk over hot coals for them. So I think everyone probably gets that. You get how we're kind of like trauma bonded with one another, seeing the horrible things that we see and going through the night shifts and all of this exhaustion. We can start behaving more collectively. We just aren't used to doing it, especially in the US, especially in Texas. Working collectively is not only more effective, even if you don't have a big collective goal in mind. The fact that you're doing it at all is incredibly empowering. It is a tangible, laying eyes on another person tangible reminder that you're not alone and that you're all in it together and that you all are going to rise and fall as a unit. So this can be informal. This can be things like employee councils, or if a new rule comes up, you literally all get together and go to your manager's office and say, we all have a problem with this, all 12, 15 of us have a problem with this, and we're going to be intimidating and stand here and talk about it. Or it can be formal, and you know where I'm going. I know you do. We're gonna talk about unionizing. Yes, I'm in Texas, I live here, I know, it's all right. This is happening. I know it's scary. I'm gonna talk about what small, tangible first steps we can do here. Penn, very famously, very recently, successfully voted to unionize their house staff, so the residents at Penn. This is the first house staff union in all of Pennsylvania. And in 2021, we started seeing some pharmacist walkouts as an early step towards unionization when things were really poorly organized around COVID, when it was this like peak horribleness, no one knew it was going on, we didn't have PPE, and we were running around like chickens with no heads. And it actually succeeded in these contexts at changing things quickly because of how, excuse me, because of how much power is behind the suggestion of unionizing. So again, this sounds scary to a lot of people. I cannot talk about this without seeing the fear in people's faces, and I understand, I do. So I'm going to draw some comparisons to other things we're more familiar with. Really, this is just collective bargaining. And you've probably heard the term collective bargaining before because it's incredibly common with a lot of our colleagues. This has been true for EMS around the country for a long time. Pretty much all fire and police are unionized and work under a collective bargaining agreement. So joining a union is going to look very different for different workplaces. It's going to look different for different groups. It's going to depend on who your actual boss is. It's going to depend on whether or not you are employed by a third-party staffing group versus a hospital versus a clinic. It's going to make a difference if you are academic, for example. So it may not make sense for you right now, and that is okay. But I want to put the seed in your mind so you can at least start thinking about it. Because the thing that's really cool about this is that it takes working together and gives it teeth. It actually gives it teeth. So again, so this is a news clip from here in Austin where our EMS has been unionized for several years now, and they just settled a labor contract dispute a few months ago to renew their union agreement and their staffing agreement. So all of the EMS that bring in patients to your ER are unionized. This is really common, and it has, in the case of Austin anyway, it allowed them to collectively negotiate for adequate PPE, help with staffing, and adequate overtime during COVID. like peak COVID. It allows for you to work as a single unit to address issues with your own safety at work, with your patient's safety at work, with things like pay and benefits, contract negotiations, and all kinds of things. So it takes these individualized issues, like your salads and your yoga and your wellness, which again are good things, and makes them a collective issue. It allows all of you to join together and demand collective action, because if we are all suffering from not enough yoga, then it's no longer an individual issue, is it? All right. Whether you are unionized or not, these are some other things that I have learned that very few of us actually know, and are very common points of exploitation in the workforce. It is unlawful for a workplace to ever prohibit employees from discussing wages with one another. Raise your hand if you've ever been told not to talk about your wages at work, that it's against the rules and you'll get fired. Yeah, absolutely. So that is illegal per the National Labor Relations Act. It is also unlawful for your employer to retaliate against you if they find out that you've been doing that. These discussions are hugely important, because if no one talks about what they're getting paid, that allows your employer to hide really shitty, unlawful pay discrepancies. And it's never going to come to light until you dig it up. Courts have also consistently ruled that promises made in employee handbooks are binding, which is fun. You also cannot be paid like a contractor if you're treated like an employee. If your workplace is telling you when, where, and how to work, you're an employee, and you are then entitled to things like PTO, employee benefits like insurance. So this is kind of my big thing. I say this a lot. I'm a big believer in being really hard on institutions and gentle on individuals. Taking care of yourself is important. It really is. It's just that it's been really well described at this point. There's an entire industry behind it. So what else can we do? Because I don't have solutions to fixing addiction in EM. But I can try to get us to see how we can make our workplace less draining and less exhausting, less demoralizing, and make us feel like we don't have outlets. So as a reminder, corporate healthcare is going to always be focused on profit over outcomes. That is simply the business model. And that is going to also translate to a healthy, happy workforce. We're seeing this now with the tremendous shortage of nurses, for example. A lot of them are packing up and leaving, and they're exhausted because they have other things that they could go do. And we're starting to kind of see some of the outcomes of that not going super well. So even though substance use is more common in EM than a lot of other specialties, there also are not plans in place for addressing this and bringing our colleagues back to the bedside when they're ready to do so. One of the things that definitely came up in our scoping review of this was how much, or how frequently rather, people described feeling that they could go to their employer, letting them know that they needed help, letting them know that they wanted to go into rehab, and never finding a place back, never found a path back, despite working really hard at it. There's a lot of really outdated misconceptions of buprenorphine and methadone out there. A lot of people that are assuming that if you're on methadone, you are stumbling around in a fog all day, where if you are overdosed, yeah? So there's a lot of misconceptions about how this is going to impact someone's work. And we have not addressed actually fixing this and putting it on paper so that there is a clear path in place for people that want to get back and be able to speak honestly with their employer. So that is another thing that we need to address. And if nothing else really clicks with you today, I do want you to know that stress, anxiety, depression, burnout, substance use, all of these, quote, maladaptive behaviors, all of these things that we hate and we lay awake at night staring at the ceiling wishing would go away, are not uncommon. They are even a rational reaction to having to work in a very broken healthcare system and seeing the horrible things that happen to our patients without adequate support and help to process it. All right, you are not alone. And step one is realizing that we aren't alone and deciding that we're going to work together to take care of ourselves. The learning assessment question. Is there any particular way to do this? Just kind of run through it? Okay, cool. All right, let's see if we remember. All right, drug use rates among people in healthcare are higher, lower, or about the same as what we see in the general pop? About the same. Good, good. Yeah, so again, per the literature on this subject, it clocks in about equal. I will say that trying to get population data out of a population that's strongly incentivized to not say anything is rough. Woo! Like reading these studies gave me an itis because I was just like, man, the methods are it, and they don't want to talk about this. I certainly wouldn't. We need more work on this, but yeah, that's where we are. All right, which of the following is a lawful workplace practice per the NLRA, the National Labor Relations Act? We've got an employer prohibiting employees from discussing their wages with one another. Is that lawful? No. An employer retaliating against employees for discussing their wages with one another. No. An employer denying employee benefits like PTO or insurance to contracted workers. Yes. Okay. Cool. Yeah, so the NLRA is kind of big, it's kind of dense, but it's online. If you're interested in learning more about this, it's an entire document that lays out exactly what your rights are as an employee-employer relationship in the US. And it is online. I come from a family of lawyers, so I have a slightly higher tolerance for reading very long pages of jargon. All right, which of the following medical specialties is not among our top 3 for rates of substance use disorder among its professional ranks? C, ortho, yeah. Okay, cool. Yeah, well, that's it. Thank you, everyone.
Do we have any quick questions for Claire? All right, thank you so much, Claire. The CE code for this session is 3, A is in Apple, C is in Charlie. 3, A is in Apple, C is in Charlie. We're gonna take about a 10-minute break. If you haven't done so already, please visit our vendor Chessie next door, and then we'll pick back up just after about 3:05 p.m. here. Thank you. All right, we'll go ahead and get started with our last 3 sessions of the afternoon before my favorite time, happy hour. So it's my pleasure to introduce Dr. Heather Tilley, an emergency medicine clinical pharmacy specialist at the Johns Hopkins Hospital and previously focused primarily in pediatrics as an emergency medicine clinical pharmacist at Children's National Hospital. She's going to be talking to us today about big problems for small people, pediatric emergencies for non-pediatric EM providers. So please welcome Heather Tilley.
Thank you. Hello, everyone. Delighted to be here. I'm excited to lead you into your afternoon session. You and I both know that there's only 3 sessions between us and happy hour. So with that, I'll go ahead and get started. I have no disclosures. So in talking about these pediatric emergencies, the organizers here wanted to focus on 3 specific topics. So I'll be expanding on that a little bit. We're going to compare treatments for psychiatric emergencies. We'll talk about sepsis, primarily considering the management of sepsis and septic shock. And we'll also describe the recognition and treatment of non-accidental trauma sequelae. Just by a show of hands, are there any non-pharmacist providers in here? All right. Just want to keep that in mind as we're going through where we're focusing. So we'll start with psychiatric emergencies. Why is this an emergency? So what is a psychiatric emergency? This is thank you. A psychiatric emergency is is basically a life-threatening or dangerous change in thoughts, moods, or actions that are life-threatening and are distressing and require immediate intervention, right? So for our pediatric patients in particular, this is important. Something else to consider is that in pediatric patients, different from adults, this is often the age of diagnosis for most of our patient population. We know that for those who are going to later be diagnosed with some sort of mental illness, that 50% of patients receive their first diagnosis by age 14, and it's 75 by age 24. So a lot of these patients coming in may be presenting with a new presentation for them and their families, which adds to the distress of the situation. Additionally, coping and communication skills are not well developed. That's not, to say as adults that we're not still developing our coping and communication skills, but they are particularly underdeveloped in the child and adolescent population. Also, as a child coming into the adult emergency department, as you know, it's not really the most welcoming environment. So that's something else to consider in these situations. We're often being handed off patients who have had potentially mismanagement or underutilized resources as well, so trying to come in there. And something I really want to encourage you, we should always meet patients where they're at, right? But coming to these patients, particularly with empathy and setting your judgments and misconceptions aside, children who are having psychiatric emergencies in the emergency department can be quite distressed, so we really want to meet them with as much empathy as we can. A little frozen. So just as in adult patients, right, we're ruling out our physiological, any infectious, intoxicant reasons for patients who are presenting in psychiatric emergencies. If we're going to diagnose a psychological primary disorder, right, we want to rule everything out. The thing is, though, is that generally when we're having to intervene and treat a patient who's experiencing a psychological emergency, we're not really able to determine at that time that we have to intervene, what exactly is the cause. But these are the things that we want to be thinking about. And so in children, it might be a little bit different what our root cause is that has led to this. You see things in pediatrics that you don't see in adults, like the PANDAS associated disorders. But essentially in the moment, those are not going to be what we're going to be able to determine before we have to make an intervention. We are going to be focusing specifically on two of these, generalized agitation as well as intentional ingestion. When we think about intentional ingestion, right, it's usually with the intent to cause self-harm or not with the intent to cause self-harm, so generally substance ingestion, and then agitation and its various forms. So when we're going through agitation management, right, we keep coming back to the circle. We generally start with de-escalation. And children, this is particularly important. I think in all instances dealing with agitation, we could maybe do a better job often at de-escalating the patient than we do. For our pediatric patients in particular, like I said, for the reasons before, there's a lot going on for them, and also not having coping skills, being in the environment that they're in, first-time diagnoses, et cetera. Focusing on de-escalation before we really consider medication administration, because that can also be traumatizing, especially for thinking about giving intramuscular therapy to kids. I like to try to aim for at least one step down, and I would say as the pharmacist too, you do have a role in this. If a provider or a nurse is coming to me asking me about medication recommendations and explaining the situation to me, I like to go and assess, see the patient, see what's going on. If they come in, particularly with law enforcement, to be present there to help de-escalate the situation, to remove people from the room who do not need to be there, who are particularly escalating the situation, and really try to minimize who's in there, and make sure that everyone is on the same team in de-escalating the situation. If anyone on your team is escalating the situation, they should step aside so that people can actually try and calm the child. Anyways, if we do decide to give her medications, we need to think about where self-harm is. Really, we should be reserving intramuscular or IV therapies for patients who are a danger to themselves or others. We don't always do an excellent job of that. I know in adult medicine that's also not consistently the practice, and we really don't want to carry that over into pediatrics for all the reasons I just mentioned. So really trying to aim for oral therapy when we can. Medication selection seems like it should be easy enough, right? You just pick the medication that matches whatever symptoms they have. But it doesn't really work like that, and that's not what we do in practice. In addition to what's on the slides here, some things to consider for patients presenting with psychotic features. If they have a known history, right, we want to try and base our medication selection off of that. Can we give them an additional dose of their home medication? Have they particularly responded to one antipsychotic over the other? Peeking at the chart, talking to the family, depending on how acute the situation is, you may or may not have a lot of time to investigate that. For non-psychotic mental distress, that is going to be patients who are presenting with general agitation that does not have psychotic features. It may be primarily anxiety-driven, post-traumatic responses, general agitation. There's actually not a lot of evidence for the use of antipsychotics in these episodes, although we generally want to reach for them. The exception for that is particularly in children who have conduct disorders or developmental delays or autism. The data does show us that using antipsychotics in those patients has more efficacy, and retrospectively, we've seen that that's how most emergency departments practice. Similarly, in pediatric patients who are not presenting with psychotic features, most emergency departments have seen that benzodiazepines are the first medication used, which is reasonable. For ingestions, similar to adults, right? You can carry a lot of that knowledge that you already have over into caring for pediatric patients. It's just the confidence to know that, like, I can apply this same therapies that I use in adults to children. Not always, but in this instance. So benzodiazepines are going to be what we're reaching for most commonly, and then you can consider antipsychotic medications as well, but of course, in undifferentiated ingestion, which you're more likely to have in pediatric patients, adolescents, right, because they don't really want to be forthcoming about what they did or what they took because they might get in trouble. So they're definitely going to be a little bit harder to crack in that situation than adults will more likely just tell you, like, what substance they're on or what they did. In that case, when you're using antipsychotics, you want to consider all the concomitant effects of that. So is the drug you're using, does it have serotonergic effects? Do we have to worry about cardiovascular effects? How does that align with the detox syndrome that we're managing at that time? So just make it simple, right? Non-psychotic mental distress is where we have a little bit of leeway. So when we're selecting antipsychotics, we want to think about our binding affinities as we generally would, but just bringing that a little bit into practice, right? Thinking about our dopaminergic activity. This is where we're trying to manage our positive symptoms. So also clozapine is not used acutely. That's just there for reference. just to clarify. So we're thinking about, like, the ones like Haldol and risperidone, and then we want to consider next things like EPS, right? So we know that the activity at H2A helps kind of mitigate the EPS symptoms. So if you think about things like Seroquel, where you know there's not high incidence of EPS, you'll also know that there is more equal affinity between dopamine and 2A, whereas in Haldol has a much stronger affinity for dopamine, less for serotonin, you see more EPS. 1A is more an affective mood and doesn't vary too much between those. Histamine is going to be important when we're thinking about level of sedation. We want to either avoid or utilize to our benefit, where we know things like olanzapine and Seroquel have higher levels of sedation. Haldol doesn't actually have a great affinity for the H1 receptor, so generally less sedation, although that varies in the literature. Olanzapine is a nice option, though, because it does have more equal dopamine D2, 2A, and then can provide more histamine if that's the effect you're trying to get at. Finally, don't forget about your alpha-1. So really, we're just thinking about orthostatic hypotension. Again, this is most important potentially with patients who may have ingested other agents or maybe having some cardiovascular abnormalities initially or be at risk of it. So we're not going to go through all of this here. The intent is really to just kind of make some quick comparisons as well. So medication selection, right? We're thinking about how they're presenting. If we're using antipsychotics, we're thinking about how they work and our effects that we want, and then we want to think about how fast it works. Because when you have a child who's experiencing agitation, everyone wants to do everything really fast and fix it right away, which we do want to alleviate their symptoms, but in the most reasonable way possible. So you'll notice here, as we do want to utilize oral medications where we can in pediatrics, that there are some where their oral onset is quite similar to intramuscular. And again, so these onsets are based on more of like that peak therapeutic, well, not peak, but your true therapeutic effect, where you know in practice sometimes you may see effects in like 2 minutes, 5 minutes, where you're starting to see that. This is more documented in terms of where you're getting into more full therapeutic benefit. So we know that olanzapine ODT and olanzapine IM, as well as midazolam oral and midazolam IM, don't differ a whole lot in terms of their onset. So unless it is a true emergency, which reminder, the patient who's presenting to you has probably been like that for some time. So like really ask yourself, like, does 4 to 5 minutes make that big of a difference in this intervention? And can we avoid like traumatically using parenteral therapy for a patient who doesn't really need it? When you want orals though, right, we're not gonna go for risperidone, it doesn't work very quickly, or Haldol unless it's a patient where you know that's worked before and they're not particularly agitated. Lorazepam isn't one of our fast options. There is some data to use lorazepam intranasally, which generally wouldn't be our choice. Things you want to consider also is what do you have available to you in your emergency department and what's available in your Pyxis, and then also age for the patient. For younger patients, hopefully we don't have to use these, but things like Benadryl and risperidone are an option. Olanzapine is an option for our potentially younger school-age patients. And lastly, to point out here, B52's onset is actually not documented to be that impressive. Although some providers may feel like they want this as their quick regimen, we actually know that there's a lot of other things that work faster, aren't quite as messy. We're not utilizing medications that we don't need. And particularly in pediatrics, most patients do not need 3 medications administered at once. Maybe not adults either. So what is so special about olanzapine though, and its parenteral issues? You may have heard that like you can't use these concomitantly. So olanzapine actually has a structure that's quite similar to benzodiazepines, phenobenzodiazepine. It's similar to lorazepam in particular. So literature has shown us that maybe there's an increased risk of respiratory depression when using these together. We know children have a more at-risk respiratory system, and their cardiovascular system tends to be a little bit stronger. So children are going to be more at risk for this, so just keep that in mind when you're selecting your first therapy. This comes up a lot when you have an agitated child. You make your first plan, and then you always want to have a second plan. So when you're discussing that with the provider, if they want to use one of these parenterally because the child is experiencing severe agitation, ask them what their second plan is and remind them that, like, really, if you're going to use intramuscular olanzapine, then next you're going to need to use either something orally if you want to use a benzo or keeping in the same drug class. And then also olanzapine repeat dosing actually hasn't really been studied, particularly in pediatrics. So keep that in mind too as you're kind of thinking about your next steps. Comparative efficacy, again, thinking about options that we have intramuscularly, orally. The literature shows us actually, again, in relation to the kinetic slide, that there are options orally that provide the same efficacy as intramuscular. ODT and risperidone, similarly effective in olanzapine IM. However, this was a small study in about 50 patients, but was one of the ones that first showed us that. Similarly, olanzapine ODT and risperidone oral, they work. More recently, these 3 studies, again, these were all in adult acutely agitated patients in the emergency department, but we don't have this literature in pediatrics, so we extrapolate it. IM olanzapine and IM midazolam proved to be more efficacious in terms of time to onset of sedation than Haldol and ziprasidone. And potentially, IM midazolam was a little bit more effective than olanzapine, so this is helpful too, right, because we're looking at 2 different drug classes and trying to determine how quickly can we get our effect that we want. And then our new friend, droperidol, which is slowly creeping into pediatric medicine as well. We want to know, can we use that? Some of the providers in adult medicine are more comfortable with using it, as you would expect, but not so sure if they can use it in their pediatric patients, and our pediatric providers are not as comfortable using it in general. So looking at olanzapine, which you may be getting, it is a nice option for many reasons and works very quickly. How does it compare to droperidol? 2 studies that were very large. One was like 1,000 patients. The other one was 15,000. There was no difference in time to sedation or need for additional therapies. So based on what your patient needs, I would consider these both reasonable options. And particularly in pediatric patients, we also have data that supports that. a larger systematic review, despite its issues in terms of it being a systematic review. They had a fair amount of studies. Most patients were sedated quickly. Most didn't need additional therapies, around the same that you see in other studies in terms of how many will need additional medications. And side effects were rare and transient. You can see the numbers here. However, unlike droperidol, ketamine is something we use a lot in pediatrics, particularly for sedation. In adults, it also has data in agitation as well, right? But unfortunately, in pediatrics, this is one where it doesn't actually translate over. There's not a lot of data to support the use of ketamine in pediatric agitation. It generally wears off and just hasn't been well validated. So this is one where you may not want to utilize your awareness of the use of ketamine to extrapolate that into like, oh, they use ketamine a lot for children, like this child's agitated, like maybe we should give them ketamine. I would generally not recommend using ketamine. So moving on to other forms of agitation caused by substances. Nancy Reagan did try hard with her Just Say No campaign to prevent people from doing drugs, but as it turns out, humans in the United States still do drugs, and that includes adolescents and young adults and children. So sometimes they come to your emergency department. We're not gonna get into the nitty-gritty here, although that's fun. I just wanna, again, point out some patterns that you can use, starting with cannabinoids. So we often think of this as being low risk in terms of overdose physiologically, but there are actually some important psychological effects that can happen with the use of cannabinoids, potentially, especially, and the developing adolescent brain. So studies have shown one of the largest ones was 16,000 patients in Europe, and they evaluated patients who had a diagnosis of schizophrenia and was associated with psychosis initially and substance use. And what they found was that the greatest conversion from first episode of psychosis caused by a substance to diagnosis of schizophrenia was seen with cannabinoids at about 70%. Additionally, we've shown that like the quicker you can terminate these episodes, the greater likelihood there is of resolution. And there was also another study by Shaw and colleagues that demonstrated for patients who abstained after that first episode that they generally do not convert to other issues. So this is often patients who are at risk for mental health issues anyways. They're just exacerbated in that moment. So that's something important to point out, because we really do want to terminate these episodes as quickly as possible, right? Like sometimes I've heard providers that they don't want to give additional medication because the child is already intoxicated, right? And like they'll just write it out, but this is actually not great for the child's health, especially if they're experiencing moderate to severe agitation. So benzodiazepines have been most reported in the literature for that. And then there's also some counseling that can go into that, right? Like once a child is more reasonable, having an honest conversation with them. Our synthetic cannabinoids, less common now that with the legalization of marijuana, but they still do come up. We know that these in overdose, right, are a lot more toxic physiologically, cardiovascular effects, renal effects, seizures, etc. Benzodiazepines work. Cocaine, benzodiazepines work. Entactogens, so MDMA and ecstasy, rarely reported in the literature to contribute to psychosis, but there are some rare reports. This is where it differs, and that the sparse literature that there is actually has found benefit with antipsychotics and anticonvulsants. But keeping in mind too, when a child presents, it's less likely that that's probably going to be the cause of what they're on. So again, we're probably not using those. Hallucinogens, the variety of them also respond to benzodiazepines primarily in the literature. Methamphetamine as well, yep. And with some literature out there on antipsychotics depending on the severity of their agitation. And then PCP and ketamine. PCP back in the day was actually created to be a sedative agent. Obviously we don't use it anymore. Ketamine has largely replaced it. Adolescents are less likely to present with PCP psychosis, but it can still happen. That's something we see generally in older populations. And ketamine as well, because of its duration of action, you all know activity, it's not likely without like large ingestions that patients are actually, particularly pediatric patients, are going to be presenting with that. That's another one where benzodiazepines are preferred, but there is some literature, primarily in PCP, to use antipsychotics. So In pediatric patients, if you're not sure, we really do want to terminate, like if a child is having distress, the length that that episode lasts. So I would encourage you to advocate for the patients. We don't want them to like ride it out or teach them a lesson. Of course, if they're like safe and in not too much distress, we don't want to give medications that like they don't need additionally. But do know that in pediatric patients, like it is okay to utilize benzodiazepines in ingestion when a child is acutely psychotic or experiencing a lot of distress, because sometimes there seems to be a little bit of fear in approaching it that way. Totally switching gears, moving on to septic shock. In 2020, we were invited to join the Surviving Sepsis Guidelines, which is nice because we haven't had a true guideline update in 15 years. These definitions were based on the old definitions, which are very old now, but they are still utilized, the 2005 International Pediatric Sepsis Consensus Conference. If you look at these briefly, they kind of look like our old sepsis definitions, right? We have sepsis, we have severe sepsis, we have septic shock. These have been criticized because they're not great at defining. As you'll see, severe sepsis includes cardiovascular dysfunction, so does septic shock. What's the difference? And then also it's hard to utilize these in lower resource settings because the monitoring parameters are quite involved. They utilize pediatric SIRS criteria, which is helpful for you to know. An important thing to point out is the difference in pediatrics. We need an abnormal temperature, an abnormal leukocyte count initially, plus one of the other pediatric SIRS criteria to meet the definition. But you'll notice it's not as easy in adults, right? So you just look at the patient, you look at their vitals, you're like, oh, okay, sure, they meet SIRS criteria. It's really easy, right? You know these numbers. And then we say, okay, they look really sick. I wonder if they have organ dysfunction. Do they meet criteria for severe sepsis? Let's see. Really easy. Fortunately, the 2005 guidelines made this easy to follow chart for you so you can determine if your child has severe sepsis or not. And then, you'll take your treatment from there. This is really encouraging, especially when you're not used to dealing with pediatric patients and you're like, oh my gosh, they're sick. I don't know. How do I intervene? What do I do? Actually, this doesn't really matter. So in the initial phases of treating a patient, what we know now, you don't actually have to diagnose these things. If a child is having organ dysfunction, you're going to manage it just like you would an adult having organ dysfunction, right? You're going to go through and treat those things as they need to be. And we don't really have to worry about these definitions outside of academia and our practice. In children, we're going to see a little bit of difference in the primary causes of sepsis. We see more meningitis. Appendicitis rarely can progress to sepsis, things you're not going to see in adults as commonly. Pneumonia is our most common cause. A difference, too, in children, though, is that most cases of pneumonia are viral, which we don't see in adults. However, in children, it's still a little bit harder to differentiate. Is it a viral cause? Is it a bacterial cause? You can use the same things you would generally do, like is there a flu onset? Is it unilateral, bilateral presentation? Is there productive cough, et cetera? But really, a chest x-ray is gonna be the most helpful in determining that. But again, it's still hard to consider in children or determine in children. Also, we're gonna wanna keep meningitis higher on our differential, kind of a bimodal distribution. So our infants and toddlers are more likely to have meningitis. It kind of dies off in school-age children, where we see atypical infections for pneumonia becoming more common, and then again, you'll see meningitis. So kind of keeping those age range things in mind as you're thinking about what your potential source is. And again, appendicitis is a different one that we see in pediatrics. We don't often see in adults. Anyways, you're gonna start with your ABCs as you always would. In pediatrics, adults, we have our pediatric assessment triangle here, which helps us do that. Appearance, there's a nice mnemonic, tickles, do they have abnormal tone? Has their interactiveness changed? Are they consolable? Is their gaze different? Are they speaking or crying? Work of breathing can be particularly helpful in a pediatric patient who can't express to you or describe their symptoms, right? We're listening, for abnormal sounds, abnormal positions. So tripoding and head bobbing, you can also see in adults, like if you think of an asthma attack. Retractions and nasal flaring are particularly helpful when you're looking at a child. So if you see that they have subcostal retractions or clavicular contractions up here, it's a lot harder for them to breathe than if you're only seeing intercostal. So as they rise, the patient is generally experiencing more respiratory distress. So these are things we want to think of too, because we're trying to anticipate how sick is this patient going to be and like what might my next steps be. Circulation, always important. Hypotension, however, is a late sign of illness severity in pediatric patients. So in adults, we're thinking of this initially. And as you might have noticed, it's not actually included in our criteria for sepsis. So children have incredible cardiovascular reserve that allows them to keep their cardiac output up by continuing to be tachycardic without this myocardial ischemia. So hypotension is a late sign because they just tack away and keep that heart going until it crumps, and then it's pretty much done. So just want to point out the differences in definitions here. The surviving sepsis guidelines were actually quite lenient. I would encourage you to look more towards the PALS definitions or the any age definitions, right? Cold extremities and slow cap refill are always bad. But for me, I'm not going to wait until my 5-year-old has a systolic blood pressure of 60 until I think like I should be concerned. So I would encourage you to steer away from these if you're pulling up the guidelines and you do have a sick patient, to use more stringent considerations for hypotension, because these are pretty lenient. Also, warm and cold shock, you might hear that. That's old terminology. The guidelines actually called this out specifically to tell us not to use this to guide our therapy. It doesn't correlate well with clinical practice. Now we've replaced that with decompensated, compensated shock. Essentially, you're thinking the same things, and it's helpful to know, like, if you're not familiar, warm shock meant that you had perfused limbs, like warm fingers, warm toes. Cold shock meant that you didn't. And that's how we would determine what we thought was their cardiac index. But it turns out that doesn't work. So still, you're assessing the patient in terms of what you think their overall ability to perfuse is, and then going off of that. The new guidelines also adjusted the way that we approach pediatric sepsis. You can see severe sepsis is taken out of here. It's just suspected and shock. And they now allow us 3 hours with the identification of sepsis to initiate antibiotics. That doesn't mean like you wait until the end if you're pretty sure that they have sepsis, but it means take your time to identify, do you think this patient really has sepsis? Have you ruled out that there's not a viral component? Have you ruled out that their SIRS criteria are not caused by other things, right? So that we're not doing all of this stuff that we don't need to do, particularly in pediatric patients. If shock develops, then we treat it as shock. We give antibiotics quickly, we initiate our fluids, and then vasopressors where needed. We also have no new fluid guidance. Children, just like adults, are getting a lot of volume overload, and we want to reduce that. So they basically broke it up in terms of, do you have an ICU, do you not have an ICU? So if you do not have an ICU and you are not hypotensive, they actually do not recommend fluid resuscitation unless there is evidence of ongoing dehydration, which is different. Otherwise, you can use 10 to 20 ml per kilo boluses. You're probably at least familiar with that. They also changed that to, it doesn't have to be 3 times. It can be 2 to 3 times. It can actually be 10 times 3. So not everyone has to get 60 mLs per kilo. That was not producing better outcomes. We use vasopressors when we think fluid overload has happened or they've had enough fluids and they continue to be hypotensive. If you do have an ICU available, they then recommend to use 60 mLs per kilo when needed. So just know that you don't have to meet these criteria specifically. We should always be only fluid resuscitating how much a patient needs, but sometimes that's not what's done in practice. Vasopressor selection, this is also new. Old guidelines used to say only epinephrine. We now have data that says only with a low quality of evidence versus very low quality of evidence that you can use norepinephrine. Again, we're guiding this to what the patient needs, right? Do they have a need for a little bit more beta activity? Do we think they need a little bit more squeeze? Not just because we think they have warm shock or cold shock, right? And dopamine has been removed, so dopamine is no longer our first-line therapy. It's really not our second-line therapy either. The guidelines say vasopressin is okay if these other steps have failed. We're not going to get into steroids in this scope, however, but generally they are not widely recommended in the initiation of pediatric patients, just like adults, but a little bit differently than we practice. Also for children, you do not need to wait until you have access as well. I know we're like nervous about children's lines because they may be small. If you have to initiate vasopressor therapy before you transfer your child out, it is okay to utilize these as well, of course, trying to get in the biggest line possible. The guidelines do not include a lot of information to guide you on infants. If you have a sick kid comes in, there's this nice little mnemonic of the misfits that you can use to think in your brain what could be going on with my kid. And then after you run through all of that and you think about their electrolyte abnormalities and what's on their x-ray, you still end at sepsis. Neonatal sepsis is differentiated into early and late. These are just things to consider when you have a kid come in. These are not things that you need to memorize. There's also differences in practice, whether we define early onset as 72 hours or 7 days. Really what we're trying to determine is the pathogens. Are they from mom or are they from the baby and the environment? And there's also additional risk factors that you might want to consider if a child comes into you. This isn't going to be super common because generally they are going to bring these infants to pediatric hospitals, but it can happen. So things that you want to think about too in getting a history to determine how sick your patient is are just what risk factors for sepsis they might have. Again, you're generally just going to stabilize the patient before you send them elsewhere. Unfortunately for you, as you're trying to figure it out, everything's pretty non-specific. UAs don't really help you. LPs, like people don't do them right or in the right instance. And white blood cell counts are also really unhelpful. So you have a lot to guide you when you're trying to assess this sick child. Healthy infants can have white blood cell counts between like 10 and 40,000. So that's not going to work. Fortunately, when you're trying to treat either early or onset sepsis or late onset, there's not a whole lot of differentiation on the initial antibiotics that you'll need to give in the stabilization phase. Early onset, we're generally treating group B strep. And listeria is less commonly being treated in the late phase. So infants who are within normal term or within the first 72 hours of, or beyond the first 72 hours of life are much less at risk for listerial infections. So AMP and GENT are going to be your go-to. The aminous glycoside provides synergistic activity for group B strep, but also listeria. Some institutions are moving away from the utilization of aminoglycoside empirically because of the low risk of listeria, unless patients meet that criteria. You can also use third-generation cephalosporins and always consider the need for potential HSV. And then in late onset, you'll see here a pattern. You can also use ampicillin and aminoglycoside, so that's nice. You might think about broadening those in patients who meet specific criteria, just as you would in adults. MRSA risk factors, broadening to vancomycin. You can use carbapenems, particularly though in high-risk patients with the potential to have an MDRO early on in life. We most commonly see ESBL. And you would also want to consider acyclovir and fluconazole for stabilization though in patients who are coming to you from outside. These are not really things that you'll have to worry about. So ampicillin and aminoglycosides are where you're going to go. All right, moving on to the last one. Switching gears entirely again, we're going to talk about non-accidental trauma. So non-accidental trauma is our medical term for child abuse in any way, shape, or form that it comes. This is really important because homicide is actually the third leading cause of injury for young children, so between 1 and 9 years old. And the issue here is that it generally escalates in severity if it is not addressed early on, which is why we want to make sure that people are aware of this, because it is really the approach of the whole team. Especially in areas where you're not used to treating pediatric patients, it's a lot more likely that patients presenting here will be missed, and that repeat abusers may bring them to places where they know that people are not technically trained to deal with pediatric patients, because they're more likely to be able to, because they're less likely to be able to identify issues. So there's those psychosocial aspects to consider. Nobody is exempt from this. There are some factors that predispose patients to this, which is young parental age, children with developmental disabilities, low income status, but it happens all across. And then the unfortunate thing for our children is that physiologically they have a lot of considerations that predispose them to these injuries, right? So their skulls are not completely formed. They don't have well-developed musculature to protect them. They're more likely to experience fractures and things like that. So when we're thinking about identifying these patients, there's some things that are going to clue us in, which makes sense as you go through the list, but if you're not familiar with these, they may these aren't things that are in the forefront of your mind, right? So we're thinking about absences of care or delays in care particularly, or the injuries don't match up with the story, right? So you have bruisers on non-cruisers, children who are not like ambulatory, and then they have bruises in strange places. That's not consistent with injury. There's overall things like your ABCs there's general indicators of neglect, changes in neurological status, dentition care, frenulum injuries. You really were like checking all of these from being hit in the mouth. Abdominal exams can also hide a lot of non-visual injuries on the outside. And then we're always wanting to do a thorough skin examination as well. In recognizing this isn't going to come up a lot for you, but just making sure that, you know, in these patients that we're doing a really thorough interview is the point in trying to do these questions open-endedly. And if you happen to see something before maybe your provider says something, you should always say something. So maybe you're going to talk to a parent about a child's medication and you see some strange things, right? These are things that we want to step up and investigate. There are additionally, aside from our visual exam, there are other ways that we can evaluate the likelihood of non-accidental trauma. A lot of studies here, things that they evaluate. One to keep in mind is the PCARN pediatric head injury algorithm. That helps us identify with a high sensitivity and specificity over 95%, whether or not there is a clinically important traumatic brain injury present so that we can reduce the risk of CT scans in patients who don't actually need them, especially if you're not used to treating these patients. You have a child who's experienced trauma, so you want to like scan them and make sure everything is okay, but this can actually do more harm than good. So we want to make sure that we're really only scanning patients who need it. Of course, skeletal surveys, though, can be quite helpful. In terms of medical complications that we'll see, these are specific to NAT where we may not see them in other areas. So children who have traumatic brain injury caused by NAT, certainly more likely to see cerebral edema and subarachnoid hemorrhages in particular, as well as retinal hemorrhages. These are very common in TBI that's caused by NAT. Fractures, of course. We learned a little bit about burns earlier. In these burns particularly, you're looking for concerning burns, right? So like if a patient supposedly has poured tea on them, but they have circumferential burns in certain areas, that's concerning. Or any burns that look like it is the shape of an object. So these are things that, if you're not used to seeing burns in children, may seem a little bit strange, but we always want to make sure that we're assessing this if a child comes into you and has a burn, doesn't match with the picture. And unfortunately, NAT can be severe enough that it does progress to cardiovascular collapse. Keep in mind, these are generally non-shockable rhythm algorithms that you'll be running through. We'll leave it at that. For traumatic brain injury, I want to point out that while the adult guidelines don't really differentiate, the pediatric severe TBI guidelines do prefer hypertonic saline to mannitol, so recommend starting there. Other considerations, you manage them generally as you do adult patients, so have that confidence that the knowledge that you already have to manage adults, you can carry over into children. Also for fractures, we're following EAST guidelines just as you do in adults, or IDSA guidelines, and then we always want to consider tetanus. Burns, again, knowing when to transfer for a child depending on the severity of the burn. If you're at an institution that doesn't primarily deal with children, knowing how to manage the procedural sedation, pain management, follow-up can be a little bit challenging. So trying to stabilize the patient where you can, making recommendations for pain control, and then transferring the patient if that's what needs to be done. So how do you assess pediatric pain? Primarily what we want to do is be sure that we are separating pain from anxiety. Anxiety is a large component of the agitation and presentation of children. So if you're getting a question, maybe from a nurse, like this child's here, they are crying, I don't know, or a provider comes to you like, what do I give them for pain? The first thing you should do, just like we do in adults, is assess what level of pain they have. So for our younger patients, less than 2, we're primarily doing observational scales. So you are assessing the patient and determining their level of pain. At least 3 years and older is recommended for self-reported pain scales. So keep in mind that we should be determining what level of pain they have before we give them medications, which sounds intuitive, but is not always. Alternative routes of administration are also super useful in pediatrics, so knowing which options you have to manage pain. Knowing your intranasals, musculars, rectal, also ibuprofen, but not as common, and trying to utilize these where possible. Just a couple studies to point out the efficacy of intranasal medications for treating pediatric trauma. The Pitchfork trial compared fentanyl, 1.5 mics intranasal, to ketamine. These were isolated limb injuries. Pain scores were moderate to severe. They had similar pain reductions. So you can use them in long bone injuries. There was another study after this, quite similar, almost similar dosing, showed the same thing. We have also compared fentanyl intranasal to a standard of care, morphine intravenously. This is for long bone fractures, so again, like higher levels of pain, right? This showed us that in doses around 2 mics per kilo, and you can go up to 3 in children. Intranasally provided the same efficacy in reducing pain as our previous standard of care morphine. So if you can avoid getting line access, or your nurses are having a hard time because they're not used to putting lines in children, you have intranasal as an option. So some final thoughts on this. Don't be afraid to encourage your provider or call yourself if you're not sure how to manage a patient or have specific questions, to call your local pediatric emergency department. We received many calls from other providers in the area asking questions and seeing how to manage things, trying to determine when to transfer. If you're getting asked questions like that in the team-based environment, don't be afraid to encourage your provider to call outside and get a second opinion. We are mandated reporters. I'm just encouraging you, if you ever have suspicion, to be verbal about that. It's really a multidisciplinary approach, and it can be traumatizing to observe. It can be traumatizing to manage, so keep that in mind. I think in EM, we often think that we work in a tough environment, but these things can be hard to watch. And I would also encourage that if you ever do have NAT that requires resuscitation, whether that be with or without cardiac arrest, to debrief with your teams. See what you can learn, and then also deal with any emotions that may be surrounding that, because it's a bit different than dealing with resuscitation in adults. All right, so with that, I'll hop into our learning assessment questions. Starting back from the beginning. So we have TJ, he's a 12-year-old male. He presents to your emergency department. He's with law enforcement. He's there for a psychiatric evaluation, and this is after a reported public disturbance. With law enforcement, they say he's been non-compliant with their request. They're frustrated with his attitude, and they ask you to just hurry up and fix the problem. He is verbally escalated. He's notably agitated upon arrival, but you find that he's redirectable with nonviolent movements. Which of the following would be the least appropriate next step for TJ? Are we going to administer an intramuscular medication for agitation, attempt an alternative de-escalation technique, or offer the patient an oral medication for agitation? So of the least following would be administering an intramuscular medication for agitation. I point this out because people are often a little bit frantic, and we need to ask ourselves, are we treating us or are we treating the patient, right? So we always want to de-escalate, offer oral medication. A patient who's redirectable and is being nonviolent, I would, separate the agitators from the room, talk to the child, and see where you can go from there. We do not jump to intramuscular medication. According to the 2020 Pediatric Surviving Sepsis Guidelines, which of the following is correct? Patients should receive 70 mLs per kilo of crystalloid fluids before vasopressors are initiated in septic shock. Broad-spectrum antibiotics may be administered within 3 hours of initial suspicion for sepsis in the absence of shock. Age-based hypotension must be present to meet diagnostic criteria for sepsis, or dopamine is the vasopressor of choice in septic shock. Good, I know you guys all know the answer in your brain, which is all of the other ones are wrong, and broad-spectrum antibiotics may be administered within 3 hours now in the absence of shock, right? So fluid changes, vasopressor changes, diagnosis, and we're not using dopamine anymore. And lastly, in the assessment and management of acute pediatric pain where suspected non-accidental trauma is on the differential diagnosis, which of the following is correct? Self-reported pain scales should be reserved for evaluating patients who are at least 3 years of age or older. The PCARN criteria help us determine the likelihood of a clinically important TBI and indication to pursue CT imaging. A full physical exam is not recommended in verbal patients who do not report pain, or intranasal fentanyl has proven efficacy in the management of moderate to severe pain in pediatrics. So the question is, which of the following is correct? Which of the following are correct, excuse me, everything except a full physical exam. So just because the child is verbal and is not reporting pain, if NAT is on your differential, you should be pursuing a full physical exam. We're using self-reported pain scales only in 3 years and older, so don't ask your 1-year-old how they're feeling, what their pain is. Don't scan every child who is NAT on the differential, and keep in mind that there are alternative routes of administration in dealing with pediatric pain. Thank you. I'll take any questions.
Thank you for the presentation. Regarding pediatric agitation, what are your thoughts on sublingual or intranasal dexmedetomidine?
I actually think that there is a fair amount of data in pediatric patients. It's just not something that I think for providers who aren't practicing in EM are super comfortable with. I also find that dexmedetomidine is not available in most emergency departments. But there is options for that. Intranasal dexmedetomidine in particular has, I think, a little bit more data in pediatrics as far as I'm familiar. But if you do have it available in your emergency department and your providers are comfortable with using it, that can be an alternative primarily for its more sedative effects, not for pain, obviously.
Thanks.
Thank you.
For your management of pediatric patients who are agitated, for somebody who's uncooperative but not a danger to themselves or others, and you're offering oral medications, what are your perspective on the conversations with that patient, or maybe with parents about consent and offering the medication to the patient where he would rather not?
Yeah, that's a really good question. So having these conversations is important when you can have them, and I would totally encourage that because oftentimes we unfortunately don't have the chance to have those conversations. So I think explaining to the patient and having a shared decision-making, asking them sometimes if they are how they're feeling. Sometimes patients surprisingly do want a medication, even though they seem like really not trying to agree with your recommendations. If you can calmly be like, how are you feeling? Are you uncomfortable? Like, do you think one of your medications would help you calm down? And those where you're able to have a conversation, sometimes doing something like giving an additional dose of their home medication that they know works and isn't going to provide any effects that they haven't already experienced is a nice option. But I would certainly encourage having those conversations. And even for escalated patients, I'll say, like, look, we're really concerned that you're gonna hurt yourself. You've already hurt our staff. Like, you need medication, and we would really like for you to take it by choice. So can you please take this medication, because we don't want to give it to you intramuscularly, but we are concerned that you're going to hurt yourself or others. Like, you just really trying to have like very honest conversations.
Thanks, Heather.
Thank you.
The session code for this pediatric talk is 5. P is in pediatrics. N is in Nancy. 5PN. Realized I probably shouldn't have said how happy I am about happy hour right after a talk about substance use in pharmacy population. So I retract my statement. Just kidding. Yeah. All right, our next speaker is Dr. Gabrielle Prococchio, who is an emergency medicine pharmacist and PGY2 RPD at Hackensack University Medical Center. She's going to be teaching us all about blood pressure management in intracranial hemorrhage. Thanks, Gabrielle.
All right, hello again. I know we have 2 more sessions, so try to bear with me. We're going to try to make this as fun as possible when we talk about spontaneous ICH. Okay, no disclosures still. And the objectives today. So today we're going to summarize the consequences of blood pressure derangements in the setting of spontaneous intracranial hemorrhage. I do want to preface that today I'm not going to be talking about traumatic intracranial hemorrhage or aneurysmal intracranial hemorrhage. We're going to specifically talk about spontaneous ICH because the data is very different for each origin of the ICH. So today we're going to really look and dig in deep about the data with spontaneous intracerebral hemorrhage. We'll look at the clinical literature and then deal with the patient case. So this is the case that we're going to follow throughout the presentation. This is ZA, a 72-year-old male that presents with confusion, nausea, vomiting, ataxia, and has a GCS of 12. Patient's past medical history is hypertension, home meds. He's only on amlodipine, but his wife states that he's not compliant. His blood pressure today on presentation is 195, over 95, heart rate 72, and O2 sats 98. So just keep this patient in mind as we go through the presentation. So spontaneous intracerebral hemorrhage. About 10% of all strokes are spontaneous ICHs. The origin is really, it's acute blood extravasation into the brain parenchyma from a ruptured cerebral blood vessel. And the mortality is actually pretty high. It's about 30 to 40%. So this is one of the reasons why we really want to have a preface and acknowledge the blood pressure management and the overall management for these patients. Associated causes for spontaneous ICH are hypertension. This is the strongest attributable risk factor, so particularly for patients that have a history of hypertension, we want to look out for them. Cerebral amyloid angiopathy, and then anticoagulation. So we wouldn't be pharmacists if we didn't focus on medications that put these patients at risk for spontaneous ICH. So obviously all antithrombotics, NSAIDs, but particularly vasoconstrictive agents. So this is for cerebral vasoconstriction. So triptans, SSRIs, decongestant stimulants, phentermine, and sympathomimetics. SSRIs are also interesting because they can also cause platelet inhibition as well, which is an additive effect. Antihypertensives, so patients being on antihypertensives, not the antihypertensives themselves, it's just the marker of their chronic hypertension. And then estrogen-containing oral contraceptives. This one is more so associated with the discontinuation of estrogen-containing therapy, and we're not 100% sure what the actual mechanism of that really is. And as far as substance abuse, so smoking, alcohol, and sympathomimetic use, these are all also risk factors for hypertension. Marijuana is listed, but when you look at the actual data, it's more so associated with concomitant medications that they're taking, not actually the marijuana itself. When patients are presenting with a spontaneous intracerebral hemorrhage, it's a mimic of any other type of stroke, right? So how many times we see patients that roll in with stroke, we don't know if it's going to be hemorrhagic, ischemic, until we scan them. The differentiations are very subtle between ischemic and hemorrhagic stroke in this setting, and really you're looking for headache, nausea, vomiting, and depressed level of consciousness. That's more specific to spontaneous ICH as opposed to ischemic stroke. And as far as the pathophysiology for spontaneous ICH, it can occur in deep brain structures. We're going to go over what some of the imaging looks like and where they occur, but it can occur from small blood vessels that have wall damage, and then specifically branches of large blood vessels that supply blood to the entire brain, right? So we think about the circle of Willis, how it supplies the basal ganglia, thalamus, pons, and so on. There's also putaminal and thalamic hemorrhage that can also cause, have lipid deposits that ultimately causes the rupture of those blood vessels as well. And then lobular hemorrhages are more so associated with chronic hypertension and anticoagulation use. So overall, the pathophysiology of spontaneous ICH, the brain is so complex. I think it's super interesting that hypertension will occur in the setting of reduced cerebral perfusion pressure. And the mechanism is actually really cool. So you have a patient that has an intracranial hemorrhage. They it causes transient and permanent damage to the patient's brain regulation of their blood pressure. So it can just be transient and the patient can recover, but also it can be permanent as well. This direct injury to the brain regions and indirect effects, they reduce the parasympathetic activity in the brain, causing increased tone, increased the release of renin and vasoconstrictive of arterioles, ultimately causing more hypertension. So this is why we want to make sure that we're focusing on blood pressure management in this setting, because the disease state itself is actually causing more hypertension. And ultimately, a hypertensive response can cause hematoma expansion, and we'll talk about why that's so important to recognize. Here are some images of spontaneous intracerebral hemorrhages, but based on non-con CTs and MRIs. You can see here, obviously, where the bleeds are. I like to say if the pharmacist is recognizing it, and the easier it is for us to recognize, probably the worse clinical severity the patient's gonna have. I don't think you need the ICH score when you can recognize it. So these are obviously profound bleeds here. They're not subtle. And as far as hematoma expansion, the reason why there's such a preface on this is because it's a predictor of clinical outcomes at 3 months and actually early as well. So increased volume occurs for 25% of patients overall, but that increases to 30 to 40% if the patient's also on anticoagulation therapy. And this can also lead to secondary brain injury, causing tissue injury and surrounding edema. So here's the ICH score. It's not used too much in clinical practice, but this helps define the patient's severity of illness with an intracerebral hemorrhage. It estimates the functional outcomes and the risk of death, both at 30 days and also at a year. So the ICH score is composed of GCS, ICH volume, intraventricular hemorrhage, if they have one, yes or no, intraventricular origin of an ICH, and that's more so associated with brainstem injury, and then age over 80. So that total is up to 6. 6 is death, and 5 is obviously the highest severity that's still alive. And on the right-hand side, you can see from one of the original trials from 2001, on the x-axis, it's the ICH score. On the y-axis, you have 30-day % mortality, and obviously 3, 4, 5 have a much higher mortality rate. So the treatment of spontaneous ICH, this is what we're here to talk about and what's important. We obviously want to prevent secondary brain injury here because the injury has already occurred. So we want to make sure that we're preventing hematoma enlargement and secondary cerebral edema. So the treatment modalities, anticoagulation and antiplatelet reversal is appropriate, cerebral edema, and today we're going to focus on blood pressure management. So back to our case. Your patient AZA goes to the CT scanner and finds an ICH in the cerebellar region. As you are the pharmacist, what is something that you want to manage about this patient now? Their blood pressure, yes, that's why we're here. All right, so we have an updated guideline from 2022. This is actually just published last year. So I won't review this too much in depth, but obviously we have the class, the strength of recommendation, and then the quality of evidence on the right-hand side. So I'm going to go over the AHA-ASA updates on the guidelines for specifically spontaneous ICH recommendations. And here we'll start with the bottom 3. This is blood pressure recommendations. So for patients with spontaneous ICH of mild to moderate severity, presenting with a systolic blood pressure of 150 to 220, acute lowering of systolic blood pressure to a target of 140 with a range of 130 to 150 is what's recommended. They also say if patients have large or severe ICH or those requiring surgical decompression, that efficacy and safety is not well established for blood pressure goals, and that there's actually been proven harm if patients have a blood pressure lowering of less than 130. And we're going to look at the trials that showed this. So I'm sure everybody has seen these trials. This one is from 2013. It's the Interact 2 trial. This was an international, multi-centered, prospective, randomized, open-labeled trial that had over 2,800 patients. Here they took patients with spontaneous ICHs. They had to have a presenting blood pressure of 150 to 220 without contraindication to blood pressure lowering treatment, and they were treated within 6 hours of onset. They were randomized to either having a blood pressure goal of systolic less than 140 or treatment as standard treatment to have a treatment if administered if their blood pressure was over 180. So we have the intensive treatment arm and a standard treatment arm. what they found was after treatment was initiated, and this was treatment as per provider preference, their actual mean systolic blood pressures that they achieved after 1 hour in the intensive group was 150. So not all patients, only 33% achieved that goal, so with that tight regulated goal. And the standard treatment arm had a mean systolic blood pressure of 164. And what they found was there was no difference in the primary outcome of major disability and death between the intensive and standard treatment arms. However, what they did find a difference was their modified Rankin scores, the intensity of death of disability. So they actually found lower modified Rankin scores in the intensive arm, making us think that we should aim for a more intensive treatment goal, right? Then ATTACH-2 came out. This was in 2016. Now, the previous iteration of the AHA-ASA guidelines were prior to this being published. So now this update in 2022 now incorporates the ATTACH-2 trial. And they had a very similar study design. So they had patients with spontaneous ICH and had a blood pressure, systolic blood pressure over 180. So these were actually patients that were a little bit more hypertensive than in INTERACT-2. And they were treated within 4.5 hours after symptom onset. Their intensive treatment arm had a tighter goal of systolic of 110 to 139 for the first 24 hours after randomization, and then the standard treatment arm was 140 to 179. And what they found was the intensive treatment arm, their mean blood pressure that was finally achieved was 129. And then the standard treatment arm had a mean systolic blood pressure of 141. And they found no difference in the primary endpoint of death or disability. However, what they did find was they had higher rates of adverse renal effects in patients that had the more intensive group. So based on this, the recommendation would be we don't necessarily want to drop the patient's blood pressure to the intensive treatment arm of about 130 because of that renal issue, the side effects there. But again, no difference in death or disability, no difference in modified Rankin scores. So that is where the AHA took their recommendations from between those two and made the recommendation of a goal systolic blood pressure of 140 with the range of 130 to 150, and then to avoid less than 130 because of this adverse renal effects. Now, the next recommendation that we'll look at is in patients with spontaneous ICH requiring acute blood pressure lowering, careful titration to ensure continuous and smooth, sustained, controlled blood pressure is recommended. So instead of having like peaks and valleys of giving bolus intervention, now we're talking about having more sustained, controlled blood pressure with maybe continuous infusion. And this data is actually interesting. It comes from two 2019 trials. The first one is pooled analyses from INTERACT-2 and ATTACH-2, and they actually found favorable outcomes, specifically in functional status in patients with acute ICH of predominantly mild to moderate severity if they had stable and early blood pressure management. And then there was also this retrospective data that looked at over the course of 10 years in 2 different hospitals that found that higher systolic blood pressure variability, so more variability in 24 hours, was associated with unfavorable in-hospital outcomes. And that was having an MRS score of 4 to 6. And as far as the next recommendation, here they also recommend initiating treatment within the first 2 hours of ICH onset. And that comes from 2 post hoc analyses. First, on the left-hand side is from the ATTACH-2 trial, where they had about 38% of patients receive nicardipine in 2 hours, and they found lower rates of hematoma growth, higher rates of functional independence, higher rates of good outcome, and then death was the same. And on the right-hand side, you have the post hoc analyses of INTERACT-2 trial. This looked at an odds ratio of death or major disability, and they found for patients on the x-axis, you can see the percent or the amount of change in systolic blood pressure in the first 60 minutes. The more the blood pressure was reduced, the less death or disability that the patient experienced. So that's where they're getting that recommendation from. These are post hoc analyses. All right, so now we're back to ZA. We heard all the AHA recommendations, we looked at the data. How do you want to treat this patient? So what's our blood pressure goal going to be? 140 with a range of 130 to 150, right? It's almost impossible. I can't imagine that anyone's going to ever achieve 140. So we're gonna have that range, right? 130 to 150. And then what do you want to use to lower your patient's blood pressure? Okay, so I'm hearing a lot of answers. I heard a lot of clofidipine and nicardipine. So here's the controversy. Which one do you use? So we'll talk about this. So nicardipine and clofidipine, there is a lot of discussion about what should be the IV dihydropyridine calcium channel blocker of choice. They obviously have very different pharmacokinetic properties, right? So nicardipine, its onset is within a few minutes. Clofidipine is very similar, but the peak effects are very different, right? So the peak effects for nicardipine in the package prescribing information, it's listed as 50% of the maximum effect is seen only by 45 minutes. I think clinically we see it work a lot faster, but that's what the prescribing information lists. And then the duration of action is it works a lot longer, right? 1 to 2 hours, sometimes up to 8. As opposed to clofidipine, while the peak is not well defined, I'll show you the dosing strategy on the next slide, the duration is quicker as well. So, clinical controversy, what are we gonna use? So the dosing strategy here, clofidipine can be titrated every 90 seconds based on its peak effect, right? We see it potentially working a lot faster. It's in a lipid phase, as you guys are familiar with. So theoretically, it's working a lot quicker. It's crossing the blood-brain barrier quicker. It's lowering the patient's blood pressure faster, right? Nicardipine is titrated every 5 to 15 minutes, but we saw that the clinical effects may not be maximized until 50% by 45 minutes. So I'm gonna have the group shout out. How many, or raise your hand. Who has nicardipine on formulary? All right, I do as well. Who has clofidipine on formulary? Okay, and who has both? Very interesting. That's not what I expected, but about 50% of the room has both on formulary. So I think that's really interesting that you do have both. So let's go over the data and see what we should be using. So I'm going to go over several studies that review the efficacy of clofidipine versus nicardipine. Now I want to preface, there's very limited data out there on what we should be using, and all of this data is really on all neurocritical care patients. So while this discussion is specifically on spontaneous ICH, the data really reviews all different neuroemergencies. So we'll go over the first study. The purpose of this study was to compare the time to achieve target systolic blood pressure with clofidipine versus nicardipine. For neuro-ICU patients. It's a retrospective review that happened over the course of 3 years. And what was nice about the study is they matched the patients based on the indication for blood pressure lowering, and the primary endpoint, again, was time to target systolic blood pressure and percentage of time within blood pressure goal. And what they found was about 42% of patients that they included had an intracerebral hemorrhage. The other patients, so about 10% of patients had ischemic stroke, and about 47% had other indications. So their primary endpoint, the time to target systolic blood pressure in minutes, was not significantly different. So in the clofidipine arm, 19 patients that received it, the time was about 30 minutes, and then in the nicardipine arm, it was 46 minutes. So you can see it's a little bit longer with nicardipine, but it's not statistically different. And then on the right-hand side, you can also see it's a little bit tighter with the time to target. With clofidipine, there was more variability with nicardipine as well. But again, not statistically significant. This next study was, again, to compare the efficacy and safety of nicardipine and clofidipine in acute stroke. This, again, was a retrospective review from 2015 to 2016 for ischemic and hemorrhagic strokes. Patients were excluded if they were under 18, had traumatic brain injury, had intracranial neoplasm, were on dialysis, and so on. And their efficacy outcomes were time to goal blood pressure, percentage of time in goal, blood pressure range, and then need for additional antihypertensives. So this patient population, about 47 to 45% of patients had an intracerebral hemorrhage. So you have 60 patients in the nicardipine arm and then 59 patients in the clofidipine arm. And here you can see there was no difference in the systolic goal reached within 1 hour between nicardipine or clofidipine. Same thing with systolic goal reached within 6 hours. The only thing that was different was I believe it was time in ICU or ICU length of stay, but after that was adjusted for other variables, it was not statistically significant. So no difference in this study for time to blood pressure goal reached. And then this study was also compared the two for patients with either acute ischemic stroke or spontaneous intracerebral hemorrhage, like we're evaluating today. So here's what they found. They found that patients with ICH were about 47% in the clofidipine arm and 71% in the nicardipine arm, so not exactly the same. They also did not do an aggressive titration with nicardipine. We know that we can titrate nicardipine every 5 minutes, but they did it every 15 minutes. And the results. So on the left-hand side, you have we'll focus on the intracerebral hemorrhage. On the x-axis, you have time to the drip initiation, and then on the y-axis, you have systolic blood pressure. And you can see that the clofidipine and the nicardipine arms are both pretty much over each other. So not a big difference in blood pressure lowering and time within goal. On the right-hand side, you can see also clofidipine versus nicardipine. There was a significant difference in the initial systolic blood pressure between the two, with the clofidipine arm actually being higher, but the actual change in blood pressure from baseline to goal was no difference. So again, no difference in the change between the blood pressure, the percent time in blood pressure goal. So it leads us to believe clinically there may not be any difference. So ultimately, the neurocritical care guidelines put out a statement for comparison of intravenous antihypertensive on blood pressure control in acute neurovascular emergencies. This was a review. They reviewed all of these, the literature that we looked at today. And they found that time to reach blood pressure goal was not statistically different in all 3 studies that we looked at. 2 maybe pointing towards longer times to getting blood pressure goal within goal for nicardipine, but again, they were not significant with statistics. And their ultimate conclusion was the optimal IV antihypertensive for patients with acute neurologic emergencies remains unknown. There's very low level evidence quality for outcomes across the 3 head-to-head comparisons, and our systematic review highlights this knowledge gap and need for more investigation. So that's their recommendation. All right. So, in summary, per the AHA guidelines, the update recommends patients with spontaneous ICH presenting with a systolic blood pressure goal of 150 to 220 should have acute blood pressure lowering to a target of 140, but having that range of 130 to 150. Blood pressure management should be initiated within the first hour of treatment. Continuous, smooth, sustained control should be achieved, avoiding peaks and valleys in blood pressure variability. And then current literature, based on current literature, the data is insufficient to recommend clofidipine versus nicardipine. And I know people have very strong feelings. We have a neuro intensivist that has very strong feelings about clofidipine, but we have not actually added clofidipine on formulary due to having 2 on there. But that's a whole other discussion for another day, maybe. All right, learning assessment questions. So we're back to our patient ZA. I think we talked a little bit about this patient. So ZA, as a reminder, is a 72-year-old male presenting with confusion, nausea, vomiting, ataxia, and a GCS of 12. The CT shows a spontaneous intracerebral hemorrhage. The blood pressure is 195/95. Heart rate is 58. O2 sat is 98%. What is the patient's blood pressure goal at this time? Should it be A, a target of 140 with a goal of maintaining a range of 130 to 150? B, target of less than 130, C, permissive hypertension, or D, decrease the MAP by 25% in the first hour? So who says A? Okay. B, C, D. All right, cool. Everybody learned something today, I guess. So A is the correct answer. And then the second question is, what agent do you want to use for this patient at this time? A, nicardipine, B, diltiazem, C, labetalol, or D, none of the above? So who says A? B, C, D. And who says they want to use clofidipine? That's not listed here, also totally fine. So the answer in this case is A, but again, clofidipine would be equally efficacious. All right. I'm happy to take any questions at this time.
Notice you listed labetalol as not an ideal option because of pharmacokinetic properties.
Mm-hmm.
Can you describe where you see labetalol fitting into the management for blood pressure for ICH?
Yeah, so the question was, where do you see labetalol in the management for ICH? I typically don't, because it's not necessarily, it's one of those agents where, again, you're gonna worry about peaks and valleys, right? So if you have, maybe if you don't have access to a pump right away, I know nobody ever has that problem, right? You know, that could possibly be an indication, but honestly, if you have the ability to start a continuous infusion, that's what I would recommend. I don't think anybody has labetalol infusions readily available in their emergency department. Plus, in the key scenario that I had, that patient was mildly bradycardic, and we know that for labetalol, the alpha to beta ratio is 1:7 for IV. So we don't necessarily want to institute something that's going to also make them a little bit more bradycardic. So almost never do I recommend labetalol. If I can, I always start nicardipine or clofidipine on these patients. All right, thank you.
All right, the CE code for that session is 2BP. 2B as in boy, P as in Paul. I'm going to hand it over to my colleague, Lance Ray, who is going to moderate the last session of the afternoon.
Thank you, Kyle. Last session, one session standing between us and a happy hour. I'd like to welcome up our panel. We're going to have 4 of our colleagues. We've got 2 physicians and 2 pharmacists that are going to help. I'm your charlatan for the hour. I'm going to moderate, act like I know what I'm doing. But while Jimmy's getting everything set up, I'm going to introduce our group here. We've got Dr. Elliot Blum. All right. Dr. Blum is an assistant professor of emergency medicine at Emory University. He serves in several capacities in the department's Equity, Diversity, and Inclusion Committee, GME Pride Committee, and has spoken nationally on mentoring sexual and gender minorities. He currently works at Grady Memorial Hospital and lectures within the School of Medicine on the topic of LGBTQIA+ health and allyship. We've got Dr. Judah Brown. He's a clinical pharmacy manager specializing in emergency medicine at New York Presbyterian Hospital, Columbia University Irving Medical Center. Dr. Brown is a RPD at a PGY2 emergency medicine program, is passionate about advancement and representation within postgraduate education on this topic, has done a ton of helping with mentoring ethnically and racially minoritized pharmacy trainees and advancing their careers, and has done lots of work in social determinants of health. Dr. Katrina Gibson. Dr. Gibson hails from Ann Arbor, Michigan, as assistant professor of emergency medicine at Emory University School of Medicine, where she practices clinically at Grady Memorial Hospital. Dr. Gibson received her undergrad at Yale University with a master's in public health in health management and policy from University of Michigan, Ann Arbor, and an MD from Case Western University. Then went to complete a health policy fellowship in emergency medicine health policy. Then finally, last but not least, we've got Dr. Jacinda Abdul Madagabar, is assistant professor of clinical pharmacy at University of California, San Diego, in the Skaggs School of Pharmacy, and the Division of Black Diaspora and African American Studies. She completed her pharmacy residency at the Howard University Hospital in Washington, D.C., and an infectious disease pharmacokinetic PK/PD research fellowship, and went on to earn a Master's of Public Health and recipient of numerous awards, including a 30 under 30, right? And also active in several national and international ID pharmacist societies. I had to work really hard to abbreviate these bios because they were incredible. All these fantastic practitioners are well-versed in this subject and do a lot of work in this area. They are amazingly decorated, very active, and interested in the vulnerable populations and health policy in these areas. So I will turn it on to them, and we'll hopefully make it an interactive discussion. I'll pass along the mic too, so whoever's talking can hold the mic. Or yeah, if you want to get up and use the podium.
I will click through this way. Okay. Well, I will read the slide. So at the conclusion of the presentation, you all should be able to recognize the barriers to ensuring DEI in healthcare settings, describe strategies for pharmacists, preceptors, RPDs that can be utilized to implement DEI initiatives, and then finally, discuss DEI enhancement opportunities from a patient-centered perspective, and that being health disparities projects and so on and so forth. So for disclosures, nothing to disclose with relevance to the presentation, so.
This is my part. How has your institution defined equity, equality, all these words that we tend to use? How's your institution done that? And we'll go through the panel.
Oh, yeah, this is you.
All right.
We'll switch sides. I'll go this way.
All right, so I'm just going to give a quick brief overrun of some terms just so everyone's on the same page if you're unfamiliar with these terms. So this is a slide that I found that I've used previously that I think shows the difference between what really goes on, what reality is, what equality is. I think some people think equity and equality are the same thing, but they're actually not. Equality is seen in the second picture. Equity is really what we're trying to discuss here. Not everyone kind of understands the difference there. And then what we're trying to achieve one day is liberation. There's no more fence, but we're at equity right now. Let's see if I can, there we go. This is a slide that just talks about intersectionality. Being minority status or diversity comes in many different forms, ethnicity, sexual orientation, but it also can come by minority status and gender expression, culture, age, religion. And so there's a lot of different aspects to this, and some people can have status in many different arenas. And so it's important to talk about it, and I think realizing that there's just a lot of overlap between different minority status. And then this is the minority stress model. So minority stress model discusses how minority status can lead to different outcomes, but it's not just minority status. So you can have minority status based on the color of your skin, based on religion, based on section, gender, minority, based on religion. But on top of that, you also have to realize that there's circumstances in the environment and general stressors that all play a role and can lead to mental health issues, substance abuse, and require social support. And who's next?
Who's going to go next? So what resources do all of your organizations provide for implementation of diversity, equity, inclusion, training, teaching, and various assessment tools?
And if anybody wants to chime in, we're trying to make this interactive. So if you guys want to talk about what your organization or institution does to implement any of these goals that you hear us talk about today, please step forward at the end.
Hello. So if no one has anything to add yet, some of the things we'll talk about are implicit bias. What is it? So I'm sure it's 2023. A lot of you have probably sat in training sessions by now. We kind of talked about those and clicked through endlessly through various diversity trainings, whether willingly or unwillingly. But implicit bias is something that is pivotal to the discussion of diversity, equity, and inclusion. So to make sure that we're on the same page, implicit bias it's something that is automatic. It's something that is unintentional. Is this showing up for you all? I don't think that it is.
Automatic did. Now it is.
There we go. We're having a technical difficulty. There we go. I'm just going to click through to spare us all. So, so we talk about implicit biases, sure. We're all intelligent people. We know what these terms mean. But if implicit bias or these prejudices are something that are automatic and unintentional, a lot of times it's easy to ask ourselves, well, how can we do something about them? But it's important to realize that even though these prejudices that we all hold, that they do have real impact and effect on patients, our colleagues, as well as prospective applicants. These are things that can be barriers to recruitment, as well as a barrier to obtaining a diverse scientific research faculty, and that, of course, can negatively impact your health equity and outcomes. So how do we address these implicit biases? Or these are something that are, not on the forefront of our mind. It becomes that much more difficult to say, what is there that we can do about it? Some of those things include don't stereotype. Look at your patients, your colleagues, and your prospective applicants as individuals. Respect the power of implicit biases. Sometimes this can manifest themselves as microaggressions, assumptions, seemingly benign questions or assumptions that we make about someone based upon their appearance, or assumptions about their religion, their gender, their socioeconomic status, or even their health literacy. That can impact patient outcomes, as well as your ability to recruit individuals that can decrease or increase diversity, equity, and inclusion. Recognize when these situations may occur. And particularly now, for instance, in the recruitment process, a lot of times, we're using Zoom now. Hopefully that will start to become less and less, but are we making assumptions about people based upon where they may live, how they're dressed, their accent? And also, have a basic understanding of your patient's culture. Are you in an area where people speak a certain language, or you are predominantly treating a certain minority group? It's important to kind of educate yourself about these things so that you're not making assumptions about these people just based upon their perceived race, ethnicity, or religion.
All right, so in terms of structure, how has any organization, open to anyone in the room too, we can start with the speakers, how have we implemented a structure to help our learners, whether they're applicants or active learners, future students, residents, in regard to minority and underrepresented groups?
And yeah, we'll open it up to the audience now. How many of you are involved in either residency training or mentoring students or taking on students? Good. So like, the majority of the audience here is at some point have been involved with, working with our trainees and bringing them up through the profession. And how many of those people that have raised their hands have felt that they've had the support to understand how to best support a minority student or a minority applicant? Right, so I think that's truly telling, and I think those of us that that are involved in residency training and student training, I think there's a large push to be able to facilitate diversity, equity, and inclusion of the next generation of clinicians. However, as we know, those resources aren't always readily available to us, or they're not always taught to us, or they're not always readily available. I think a lot of us struggle with, we know that diversity, equity, and inclusion might be important, but we don't necessarily know the tangible things to do. Or the tangible things that we can implement in order to make our environments more inclusive to applicants or students to come to our programs. Specifically, our governing bodies or our accreditation bodies like ASHP have put out statements, to implement or to focus on diversity, equity, and inclusion, but not always have they shown, exactly what we should be doing or how we should be implementing that. Additionally, it's different for each institution, right? It's different for wherever you are and however you're assessing that part of your culture. So some ways that we can do that are optimizing the climate. So create an inclusive climate. Diversity is a stated value, and diversity should be visible. So how do we do that amongst our organizations, amongst our residency programs, amongst our student training programs? And I'd be happy to interested to hear from the audience if anyone has had any experience creating inclusivity in their workplace or their training program.
Well, since John won't go, I will make sure that I mention some of the things that I experienced as a student and some of the things I've tried to carry over as a professional. I think some of the times what comes up for me is that people feel that you have to look a certain way to embrace diversity. And I'm hoping that's what we get out of this. When I went to Grady, the one thing that kept me driving back 2 or 5 hours just to go work there was the environment of just being comfortable. I felt that as a black man, I was able to be black there and it was okay. Having John as my RPD for the entire year, I didn't have to speak a certain way, or I didn't have to put on what I consider and what's usually talked about is put it on my face, or putting on a certain act to feel included. And when it came to that, it really helped me, excel. And that's why I feel bad. John has to do everything that I do. John has to be part of it because he has, again, led to that. So if you're a preceptor, if someone is talking to you about a particular issue, just saying, hey, at this moment, you can speak the way you want to speak about this issue, and we're going to make sure all the other things are not going to be involved in that. And I think just being accepting of different cultures, and I think speech is being able to talk a certain way is going to be that. I'm probably the worst speaker in this room right now, but I feel comfortable being able to do that. And it all started with having people that supported me. And I think John and Chantrell was those people that did it for me. And what I do now from a technical way of me and other people, if you don't look like me, I make sure I say the same thing. Hey, talk to me. You want to talk to your friends about this particular issue that's bothering you in the ED. This is a crazy environment. And I think that when I was at MUSC, one of the things I tried to do in recruitment is making sure that in open houses, doing all these different things, making sure I meet people where they're at and speaking to them in those languages. That was the big thing to let people know you're going to be comfortable here, because DEI is great, but how do you make people feel that they belong in the location they're at? And I think that one small thing is something that everyone here can do, is making sure you're meeting people where they're at and speaking to them and making them feel accepted.
Thank you.
I think it's important to include Emory's program because they have one of the most diverse EM programs I have ever seen. And it's incredible to work in an environment where the people that you work with are reflective of the environment that they treat. And it does make a difference, and it does make an impact on patient care. John doesn't want to come up and say anything, but John is really great about trying to be inclusive and trying to get different cultures out there. I think he does a great job. He doesn't want to come up and admit it, but yeah, he does. But yeah, and there is a difference. I know there are not a lot of minorities in the room, but I noticed that in pharmacy residency programs in general, there's usually a token. There's not diversity that we see in Emory EM's program, and I wanted them to be here to tell us how they do it so we can start doing it in our programs as well.
And I'll make this quick, but on my previous institution, so we created a colleague work group, and it was the LGBTQ work group. And while it was originally, I think, meant to facilitate community and all of that, we were actually consulted, if you will, to create educational materials for our hospitals in our region. It led to putting pronouns on our badges, and it also we had booths at Pride festivals in our areas. And so what was meant to really be a community work group, we were actually to make actionable items that was really, I think, impactful for our communities and our face with the queer community.
Thank you.
I wanted the Emory EM people to answer the question.
All right, the old white man has decided to get up here and say, I'm going to.
You want him to put?
Oh,
I apologize. I am hiding behind the podium. But first of all, I want to thank you all for standing up and speaking. I know that a lot of times that these conversations can feel either forced, cliche, or even uncomfortable, particularly if you are not a part of a minority group, whatever that, how you may define that. You may have a difficult time feeling as if you're taking up space. So I just want to make sure that everyone does have the opportunity to speak. But as Dr. Johnson alluded to, this isn't just about numbers. It's about feeling not just seen, but heard and respected. I think a lot of, and I also want to speak to some of the programs, say maybe you're in a certain area where the likelihood of, you're in rural Idaho, and the likelihood of you getting someone that doesn't look like the population is low, but this conversation still includes you as well. And speaking from personal experience, I think one of the most important things that you can do is, be realistic about the types of experiences that you can provide for your residents, for your, as well as for your providers that stay on as faculty. And I think one of the most important things is, acknowledging the fact that people are going to experience prejudices and microaggressions. But with that being said, how comfortable are the recipients of said microaggressions going to feel advocating for themselves? Our leadership, are you creating environments and cultures where you can have these difficult conversations? For instance, is the onus going to fall on the individual to respond in a way that makes the oppressor or aggressor comfortable, or is your emphasis or impact on the individual? Do they feel supported in sticking up for themselves? Are there ways in which these difficult conversations can occur? And of greatest importance is, like I said, people need to feel not just seen. They don't need to just be a part of the table and have a seat at the table. They need to understand that what they shall we say, want on the menu is reflected. And those are some of the many ways that Emory's been able to flourish. Of course, the fact that it's a major city, we're in Atlanta, the population is relatively diverse, but in addition to just numbers, we don't want to know just who's at the table, but whose voices are being heard. Are you retaining your residents? Is this a place where people just keep their head down and they've got to get their education and get out? Or do they know that is this a pipeline for success? Can you be promoted? Can you be celebrated? And those are things that are important to acknowledge. So the important thing is leadership is these difficult conversations can occur, and if you are on the recipient, you have backup, and you're not going to be made to feel as if you're somehow the aggressor or the problem, when in actuality, you may just be the recipient. So it's important to be an ally. If you see something, say something. Don't run away and send the email afterwards and say, I'm so sorry that you experienced that. If you see something, say something and offer support. And I know a lot of us are on different areas of the spectrum of confrontation, but with that being said, I'm not being facetious, practice in the mirror. If somebody says something to your colleague or to you that's uncomfortable, ask them, well, what made you say that? That, in a moment, gives people the opportunity to pause and reflect. And, a lot of people will respond in kind, others may get defensive, and that's okay. But you need to provide the climate where you can have these conversations, difficult conversations can occur. Backlash is not tolerated, and people can feel as if not only can they advocate for themselves, but they also have allies at all levels within their department.
Thank you. Thank you. Great points. Where'd the old white man go? Oh, there he is. Frank.
So anybody is welcome to confront me at any time, because I have horrible habits ingrained over a long time where nobody ever bothered to care or say anything about it. And I can't get better with horrible habits that have been built into me over a lifetime that people don't point them out to me. So please, and I haven't been rude, and I'm deeply apologetic to the people that I either interrupted or didn't even realize I wasn't being talked to. I will say two things. One, to give you an idea, just over my career, I took over being the PGY1 residency director at the University of Illinois. I gave up my had my PGY2 taken away in 1999, and I was told, this is what we need from you. And one was, you have to do paperwork, and we're going to meet with you monthly to see your paperwork. One of the things I was told, and make sure we stop getting those gay people in the program in 1999. And I said, I couldn't say a word. I was shocked. I don't think I've ever paid any attention to that, and I have no idea whether I succeeded in any way, shape, or form. And maybe I'm supposed to know, but I'm kind of proud that I never really understood whether it was or wasn't happening. Two, sometimes I think we still have horrible biases that we don't think about, and not the worst. We have biases. I shouldn't have used the word horrible. But I would just say it's a lot of extra work for me as a PGY1 director, but I always made sure I look at what percentage of students fit into different GPAs. And maybe 5% of all my applicants had below a 3.0, but 5% of my interviews went to those people. Because how they performed in damn school, especially if they're working 60 hours a week in a job or something like that, maybe all they could get was a C. But damn it, the person who worked that hard is a person I want to have be a resident. And I would make sure that, however, if a school sent me 15 people and that was 10% of all the applicants I got, well, then maybe they get 10% of my interview slots. We can't stop. Dropping the fence I like, but the whole damn fence has to come down, fair? And I think we got hung up on these scoring rubrics to make certifying organizations happy, and we're letting those rubrics create fences. So I ain't that smart a person when it comes to this. I don't have a whole lot of social skills. And I wasn't sure what was going to be said here, but I do appreciate having the opportunity to speak. I've been given the opportunity at organizations to speak despite being the way I am. And I really would like to say that there are some people who are willing and capable of listening sometimes. Doesn't mean we're any good at it, but I at least would like to try.
Thank you, Frank.
Hi, my name is Kristen Robinson. I feel like, well, I'm a relatively young EM pharmacist. I graduated from Grady in 2020, so props to Grady again. Yeah. And so I came from a program that I felt was extremely supportive, and then ended up as an EM ICU pharmacist at a rural site where I experienced probably my first true experience with actual microaggressions and discrimination, and basically I was the first African American clinical female pharmacist on staff, and quite a few opportunities were quickly taken away from me, from teaching to even having my position in the emergency department taken away from me. Which resulted in me getting an amazing job at where I am now. So I love my practice site and what I get to do, but just as someone who, that was the first kind of experience that I had, and especially in a rural setting, I want to know if you guys have any strategies, because now I do have residents that I get to teach, and I am seeing more residents of color and more I'm just seeing more diversity with the residents and students that I'm teaching. So I'm trying to figure out what strategies that I can use to prepare a lot of my students and my residents, because I was not expecting that, right, in 2022, 2023, and it hit me full in the face, and it was horrible. I still feel like there are times where I reflect back on those moments and I have to still go through and adjust. So I would just love to hear some of the strategies that you guys have, especially for us young practitioners coming out, and ways that we can kind of manage that.
Thank you for sharing. And if maybe we can kind of twist that into leveraging, right? And maybe there's two buckets here. It's kind of a personal. I see it as how we can be interactive with each other and direct with each other, as Frank mentioned. But there's also how we can leverage, and we can start with our organizations, how we can work with our organizations. Or did I jump to another? Sorry.
Okay.
We'll start with this.
Yes,
That's
it was so good, Lance. I honestly wanted to click back, but because the question you asked really feeds into the topic I was going to discuss in terms of research and things like that. So I wanted to click through here so I could integrate my answer to your question. I think that first and foremost, as also a black identifying woman, and a young black identifying woman in this very, I like to always say the academy is not kind to young folks. So I mean, when you couple that with being young and being black and being, a part of a gender minority, so as a woman, it is very hard. And I oftentimes struggle with my students because I know how it felt for me to be the first and the only, and it still is that way. I am oftentimes the first, the only, the youngest, and then you're not only like the first and the youngest, professional, person, you're also the youngest professional, or you might have a professional disparity. So when you're a room, I know for our physicians, it's probably the minority because it's a room full of like pharmacists, and then you all are the physicians here. But for me, oftentimes, I'm an infectious diseases professional, so thank you for welcoming me in this space. But for me, oftentimes, I'm the only pharmacist, and then I have all of those other areas like Elliot talked about, areas and levels of minoritization. So it's hard for me to even kind of relay things to my students because I'm moving through it myself. But I think the biggest thing, and that you can tell any trainee of color, any trainee of any marginalization status, is to, one, prioritize their mental health. Because oftentimes we let that go to fall to the back burner. We don't think about how hard it is. We just carry the weight. And me being a part of the Black community, oftentimes it's touted that Black women, we just have to be strong. And it's hard being strong. So I think what has allowed for me to see success with my students is exposing my vulnerability. So I expose the fact that I do go to therapy. It is hard for me. Every single thing, doing a talk, standing up here right now, it's hard for me, but it's important work. So I make sure that I relay that to them. I advocate for them. I think that Dr. Gibson did a phenomenal job in really talking through the importance of creating a safe environment. And you don't have to be racially concordant for that. You don't have to be racially concordant to understand. We don't have to be racially concordant to understand how implicit biases turn into explicit biases. We know when we tell a trainee, hey, irrespective of you having all of these phenomenal stats, you just don't fit with our training environment. Well, if you've never had a trainee like that trainee, they're never gonna fit in that training environment. But I think for me, and one thing that I explain to my students is how I now use my race and ethnicity and my marginalization status to do different research or to kind of spend my career on my really good friend, she calls me a martyr, but to martyr, and I hate that, us as minoritized people feel like we have to do that. But, sometimes we have to knock down, the barriers for others. But one thing that I do is I say, okay, I'm a researcher, I'm an infectious diseases researcher. But for me, my interest is, well, where are the racial disparities in this research? So something that I really work to do is to bring my students into this research with me. So to give them tangible experiences. So that now it doesn't look like that I'm the first and the only and I'm doing all this work, but now you create an experience and an atmosphere of empathy, but you also give them that tangible experience to where they can identify how explicit biases can be so detrimental. So for my group or my research group, or for myself in general, COVID-19 was a turning point for me personally, because it happened when I just left my training program, but I saw myself being a benchtop researcher. That's what I trained in. Like, why am I here at this emergency medicine meeting talking to you all? So I said, you know what? I'm going to do benchtop research, and that's what I'm going to do, because that's what I was trained to do. My mentor ingrained it into me. I was once again the first and only Black trainee in this really high-profile infectious diseases training program. Was also diagnosed with hypertension at 25 years old while in the program, because that is a burden. That's something that you carry with you. So when COVID came, I thought to myself, well, I'm not the only Black person being faced with COVID. I'm not the only person being tasked with this responsibility to get vaccinated, but then also to disseminate this information. So of course, I started promoting info and involving communities. So really taking myself out of the ivory tower and then going into minoritized communities to promote vaccine uptake. But at the end of the day, my priority was bringing my students into these atmospheres, because when we think about the culmination of what these training experiences are, our students are the future. They are the folks that are going to be sitting here. We want them all to raise their hands when we ask, have you all received resources? Have you ever received training in how to navigate these circumstances? But we have to make sure that we're responsible when you do it. So when you teach your students about these diverse experiences and you bring your own personal experiences and your intimate experiences into that, we have to inform them. They have to remember to reach back into the community. So for me, my work is community-based. So when I do this work here, I make sure that I can provide resources into the community, because we have to remember that we have to give these minoritized communities what they give us back. So that continued investment. I have additional slides, but I won't run through them because I know we're running short on time. And I want you all to be able to have the bulk of your questions answered. But I do want to reinforce that our trainees are the future. They are the important piece. But when we think about what it is that we want to ingrain them with, we want to ingrain them with the tools to be able to go and take what it is that they learned. And when we make our residency experiences more diverse and we recruit these diverse individuals into them, that we make sure they can go out into the community and they send it out there, right? Because at the end of everything that we're doing is a patient. So yes, we want to diversify our training experiences because that's how we get to that end goal. But we have to always remember that as we are training them, ingraining them with the tools that they need to be able to serve the community in the best way that they can, or to serve that patient irrespective of color, creed, sexual orientation, gender identification, the very best that they can. And then also remember, and I won't get into my research piece here, but research is important because we're at that stage where we need to start figuring out where do the disparities exist. We know training experiences have disparities, but we cannot pinpoint them. We aren't able to inform where it is that these disparities are occurring. So let's remember that that's the important piece. So that's all that I have to say, and I hope that answered your question sufficiently. It's not an easy task, and I wish you the best as you take it on, because it's not an easy experience, but it's one that it's important for us to do. But the biggest thing, and I hope that I leave you all with this, is it's not an easy task to be the one and only in these spaces. So let's give our folks that are grace, understanding, but if we are those people that can provide those experiences to others, let's do it with care. And let's also make sure that we stress the importance of checking in terms of mental health, because it's not an easy cross to bear. That is it for me. I hope it won't be.
Done.
We can go
Mic
back to
drop.
Julian's question. Right. We can go back to Julian.
Oh, want to go back?
Yeah, because that was all mine, but we switched the order. I should have.
We're flexible, we pivot.
Yeah, right there.
Oh, that's
Perfect, yep.
okay.
All right, so I want to kind of pivot a little bit and talk about different strategies to implement, structure for this, structure for creating a diverse workforce in support of all of our different learners and applicants.
Sorry, I'm just going to pivot here. So thank you all for sharing and opening up this space. I do want to emphasize a few points that were already made. Meeting people where they are, I think, is a very powerful statement, right? So I think that a lot of the time there's hesitancy to discuss these things, especially if you're on a more one-on-one or intimate level, or you feel that you don't have the knowledge to sort of to move into this space. I think that if you take the stance of meeting people where they are, that might help you drop that barrier and open up the door to create that safe space. The second thing that I want to emphasize as well is the importance of mentorship and sponsorship specifically. So identifying that mentor, and as you pointed out, sometimes that's difficult for a young trainee, right, to find if you don't see anyone that looks like you or thinks like you or has experiences similar to yours. That can be a little bit difficult, but again, going back to meeting people where they are can help break down that barrier. Additionally, we don't want to just mentor, we also want to sponsor people, right? So we talked initially about, having the seats at the table, how do we pull people in? That's an intentional process, right? Those seats aren't just going to create themselves. They're not just going to magically appear where you can just walk right in, especially for someone that is minoritized or is, has structural barriers preventing them from doing so. So being that person that can sponsor that individual to pull them into a space where they can be successful and can continue to succeed and then give back to the community, as Dr. Jan was saying. So moving into this next question, so how have you been able to leverage institutional, local, and national organizations for DEI implementation? I think that this is important, right? I think that, as we mentioned before, we have limited resources that are known to us or that are made known to us, but we can definitely utilize these higher institutions, not just us as individuals, but the institutions themselves as opportunities to create these spaces. One of which is we don't know what we're dealing with unless we have the data, right? So going to these institutions to collect that data or utilizing them as large pieces or large networks that we can go through and connect that, gather that data, specifically for training programs. So if you don't necessarily know what your makeup of trainees is, historically, that might be a good place to start to identify where those disparities may occur, right? So we have a lot of maybe anecdotal evidence, but if you don't have the data, that's going to be hard for you to have the impetus to make those changes. So there are things like doing collecting the data, doing anonymous surveys. I know several programs have implemented survey data to reflect on the types of trainees that they're recruiting to their programs and what has drawn those trainees to those programs. I know we mentioned a little bit earlier on working to eliminate those structural barriers and biases. So the review of rubrics, I think, as we mentioned earlier, I think we've pigeonholed ourselves into saying that we need to be so objective, but that sometimes creates an additional barrier that we may not have intended for. So going through your residency or recruitment rubric, is GPA really important, right? Or is another characteristic that would create a successful trainee more highly coveted? Independent assessment by your organization, I think a lot of the times our recruitment task forces themselves aren't diverse, so you never get that additional viewpoint. So you never know what implicit bias that might be present or what other thought process that you might be missing. Remember to define characteristics and qualities, right? So, like I said, what aspects of your recruitment are important and why is that important to your trainee? Why would that be important for them to be successful in your program? Opportunity creation, so scholarship and sponsorship opportunities. So where possible, you can utilize these national organizations to create sponsorship and scholarship opportunities. So Dr. Jam and I work on the Pharm Grad Wish List, which works and advocates for minoritized pharmacy trainees and really offering them the financial support, but also the advocacy to be able to continue on their training despite the structural biases that might be in place for them. So this is a targeted approach. So you should have targeted collaboration with national organizations that can really spread your message and get the information out there. Additionally, leveraging these organizational partnerships in terms of funding, resources, outreach, and data collection and samples. These organizations have financial means, so you ask for it. That's one way to help get to break down those barriers and reduce that fence that we showed in that one slide. So I'll open it up here again for any questions or any comments from the panel as well.
I have a quick question while we're waiting. We saw a show of hands earlier on how many residency programs have residents working on a project with Connect Place and Altaplace, right? Like half the room. I'm curious because we've started implementing a few project ideas for our residents. How many pharmacists here that have residency programs associated with them have residents working on projects in the DEI sphere? Okay. Cool. And then also, likewise, how any residency advisory committees that have integrated DEI task force or workforce within their RAC to look at like rubrics, screening, interviews. Okay.
And then briefly, because I do want to take into consideration that there are a lot of programs where maybe this is not on the forefront of their agenda, and I don't want you to feel as if you have to reinvent the wheel and come up with your own resources. So quick plug, SAEM, if you go to SAEM.org, there are resources, teaching resources, activities that you can incorporate into your training for residents, as well as faculty, whomever you think may benefit from this training as well. And of course, you can always Google Emory's website as well. There's a lot of, and I'll bring up the QR code on the way out as well if you all want to take a picture of it as well. But the resources are out there. You shouldn't feel as if you need to come up with this information and these activities from scratch, particularly if you're at organizations where maybe this is not a priority. And I think that's particularly important for those programs where maybe it's not, to leverage your national organizations where maybe you don't have the support locally and regionally. So please visit those websites. We probably don't have much time for other questions, but the resources are out there. Email us, call us, text us if you have other questions about how to access those.
Right.
Thank you,
Yeah,
guys.
sorry,
so
I
much.
I was checking our group chats to see, and it kind of all fell silent. You know, it's an interesting space. We didn't have a lot of questions, but if there are any other questions, happy to take them. I want to give another huge thank to our group here. It's an amazing panel. We're lucky to have them. Any closing comments? Any?
I'm sorry, I do have a question. I know we're running late on time, and it doesn't necessarily have to do with residency or incorporating DEI into that space, but it's in general, so I'm hoping you can help me answer this. I've been trying to think about how to phrase this question the whole presentation, so apologies in advance. But long story short, our institution has now changed how we document gender, and it's based on how the patient identifies, which it's just a challenge sometimes when we have to pick medications based on some of those anatomical realities, and when we have to go off of provider notes that state if there has been a transition, and we all know in an EM, provider notes aren't always available at the time that we need to verify medication. So how do you navigate that? How do you be sensitive to that patient if you can't determine based on their chart an anatomical reality for them and what medication we should choose?
That's a great question. So we're going to be given a lecture about something related to this at Emory fairly soon. But within EPIC, which is the EMR that we use, there's an ability to change someone's gender versus the gender assigned at birth. And so I know a lot of providers don't do that, but that gives us an opportunity, at least at Emory, to be able to have something congruent with where the patient identifies. But I also think going into the room and speaking to the patient, I think, is sometimes the only answer there. And there's a lot of different ways to do it. Sometimes you can speak about the way that you identify and then start the conversation that way. But I think a patient who especially is a sex or gender minority would appreciate it rather than you going in there and, let's say, even doing something like ordering a pregnancy test or something that's that simple that you don't really even think twice about. Going in the room, having a conversation with the patient, because I think we visualize it in our heads is a lot more difficult than it actually is. And when you go in the room and speak to the patient and you're just like a real person with them and just say, hey, this medication was ordered, this is how I identify. How do you want to be identified? How do you what do you want to be called? How do you want to be referred to? And do you think this medication is appropriate to you? Instead of, a lot of the times, especially in the emergency department, we order medications, the nurse gives it to the patient, there's no conversation there. And I think that is probably the most offensive. But if you see something or hear something, you can also go to the provider, right? Hey, did you consider this when you ordered this medication for this patient? Did you have this conversation? Maybe didn't document it in your EMR. I know at Emory, I can't speak for other institutions, but at Grady, we have a very, very close relationship with our pharmacists, and they come to us with questions all the time. And the way we look at it at Emory is everyone's on the team, right? And so the pharmacist is just as important as the attending, as important as the person in environmental services who cleans the rooms. And so I think that you always have an opportunity to first talk to the provider, see if they maybe didn't document something or heard something. And then the second thing is talk to the provider, hey, I'm gonna go to the room, speak to the patient about this just to be 100% certain what's going on.
if that is how that person was born. And so sometimes there's no way to know when you're just quickly looking at a chart to even know to ask. You know, it could be, I don't know, you can't play somebody's name, or sometimes there's no picture. All it says, it would be, you know, but that, I wouldn't even think twice about it potentially.
Yeah, so I think that's a conversation just to have I mean, if you can speak to the person in the emergency department, or your CMIO is the person who's in charge of informatics in the hospital, because you can mess with Epic 1,000 different ways, and that might just be something institutional at your institution, because I know at our institution, you can have a specified gender assigned at birth versus your gender identity, and we have the ability to change that now in our charts, and I would just raise it up the chain, speak to the CMIO, ask them why this changed, and kind of explain to them why you're asking the question, because it's critical, and you don't want to create distance between you and the patient.
Yeah. I will say that I ran into a similar, well, not ran into, as I've been educating myself about other areas of marginalization, irrespective of my own. I was talking to a friend of mine that does identify as a part of the LGBTQIA+ community, and I asked him, you know, how do you do this? Like, basically the question that you relate to us. So what I've adapted is I always introduce my pronouns when I'm talking to a patient, or in a setting. I say, hi, you know, this is my ghost. But I say, hi, this is my name. I give my name, and then I say, you know, my pronouns are she, her. And then typically that prompts the other individual to then give me their pronouns. But I think, you know, one thing that Elliot said is this power in, you know, really dropping your guard and talking to the patient and being humble and saying, listen, you know, I would like to ask you with your gender, like how you identify, because I want to make sure that I prioritize this as I'm designing your treatment plan. It's power, you know, in talking directly to the patients. And like Elliot, I mean, like if I were a patient and I'm not a part of the community, so I don't want to misspeak. But I've appreciated that when folks have, you know, asked me directly, listen, you know, I want to make sure that I can do the best things for you. So will you allow for me to help you in this way? Or how can I best help you in this way? So I think, you know, it's power and humility in talking with our patients as well. But one thing that I have adapted is just introducing my own pronouns. And if you have interacted with the patient before, I just ask them if their pronouns have changed. So every time that I interact with the patient, and I've worked in the HIV space, I just say, hey, you know, are your pronouns still the same? Just so I know as I'm continuing to design the treatment plan, if that's helpful.
Thank you. We'll move on to the learning assessment question, which you've all been able to stare at for a few minutes. Hopefully you get the right answer. Which of the following are barriers to enhancing diversity, equality, and inclusion in healthcare? A, unconscious bias, B, mentorship and sponsorship, or C, lack of representation? D, A, and C. Or it's inclusive. Next, which of the following are techniques to support diversity in pharmacy education? Use only subjective criteria in applicant scoring rubrics. Utilize diverse selection and admission committees. Minimize targeted recruitment for underrepresented groups. Or D, none of the above. B, so utilizing diverse selection and admission committees is a wonderful group, fantastic technique to support diversity in pharmacy education. While I have the microphone, I have to say, if Google U.S. News World Report college rankings, there's been some recent movement in that space, and it's really interesting, I guess, what makes up rankings, and a lot of the law schools and different schools have kind of dropped out because of the metrics that are used for that. So it's kind of making a contemporary issue. More interestingly, pharmacy schools. Anybody know how pharmacy school rankings for U.S. News and World Report are determined? It's one question. It's a one-question survey from deans of pharmacy schools, so it's one opinion, aggregate. Isn't that fascinating? It's different than even medical schools or law schools, so that's quite embarrassing. Yeah. 3, research focused in diversity, equity, and inclusion. A is not usable information to inform change. B provides transparency and allows for the development of objective goals. C allows for analysis of target improvements. B and C. The correct answer is D, B, and C. All right. Well, thank you again for our panel. Wonderful, wonderful conversation. I know we could keep going if we had the time. I'm going to turn the final comments over to Dr. Oh, yep, CE code, which I don't have. All right, 9WA. Again, that's 9WA. All right, we're going to turn it over to Dr. Jimmy Pruitt for our last couple comments. And thank you all on behalf of our committee. Thank you for coming. I think it's been a successful day. Jimmy?
Yeah. I'm just gonna get this one off.
It opens the desktop. A lot of y'all want to know what we do in the ED. Well, Harriet opens the big this your boy Farm D in the ED, and I'm gonna let you know. But first, shout out Jim, Chantrell, OT, John.
All right, guys, so I want to thank all of you guys for coming to the Empowerx Conference. I thought it would be no better way than to end the conference with our own EM Pharmacy song. I'm just super excited for all that we was able to accomplish. This is a dream come true. This was a text message 2 years ago. We had over 100 people here, over 200 people virtually, so I'm just super thankful for all that. And I want to give you guys a round of applause for being here, being attentive, and I thank everyone for coming, so thank you, and keep taking the brain to vein. Oh, yeah. And guys, we will be going for happy hour at Caroline's. I believe it's walking distance from here. It should be on, if you guys received the email earlier, it should be there. But again, if you're in the group chat, we'll post the address of getting that there. 681 Congress, 681 Congress. So after this long day, I need a beverage to kind of cool myself off. So I'll see you guys there.